each an expert in their respective fields with a wealth of knowledge and experience to share. Let me take this moment to extend our heartfelt welcome to the immediate speakers who have graciously accepted our innovation. Dr. Suchna ma'am, it is our honor to welcome you ma'am to this institute gathering. Welcome to you ma'am. Mrs. Malati ma'am, we are truly privileged to have you with us. We welcome you ma'am. Dr. I. Clement sir, your presence is deeply appreciated. A very warm welcome to you sir.
Thank you, ma'am.
Dr. Dipti ma'am, we look forward to your
Thank you so much. Good
look
morning,
forward
Jai.
to your valuable insight and delight. Welcome you ma'am. Dr. Gopi Chandran sir, with great respect and administration, we welcome you sir to this occasion. Welcome you sir. Mrs. Latasha ma'am, we express our sincere gratitude for your presence. We cordially welcome you ma'am. Mr. Abhishek sir, it gives us immense pleasure to this distinguished event. We welcome you sir. And Mr. Paite Panwar sir, we are truly grateful for your instant presence among us today. We are honored to welcome you sir. On behalf of the entire organizing committee, Ruma Institute of Medical Sciences, Pratapgarh, I once again extend a warm and respectful welcome to all our speakers, participants, and guests. Let us embark on this academic journey together, driven by our collective commitment to excellence in care, research, and public health. I take this opportunity to express our heartfelt gratitude to our chairperson, Dr. Rajen Singh sir, whose visionary leadership inspires all our academic and health awareness effort. We extend a warm and respectful welcome to our institute chairperson. Your presence adds immense value of this occasion. We welcome you, sir. Our director, Dr. Manish sir, and Dr. Manisha ma'am, whose unwavering support guides the mission and growth of our institution. It is the privilege to have your precious presence with us today. We wholeheartedly welcome you, sir and ma'am. Manager, Mr. Vijay Singh, for the continued encouragement and administrative strength. We warmly welcome you, sir. Respected Principal, Mr. Rahul Sir, Chairperson, Nursing Service Section, TNAI, UP State Branch, for being the pillar of academic excellence and innovation. On behalf of the entire faculty and student community, I take this opportunity to express our heartfelt appreciation for your visionary leadership in organizing the first national webinar of our esteemed college. This remarkable initiative is a reflection of your commitment for academic growth, innovation, and excellence. Your constant encouragement and dynamic leadership have opened new avenues for knowledge sharing and collaboration across institutions. The national webinar stand as a proud milestones in our college journey, as we are truly grateful for your inspiration and efforts in making it a reality. We are also excited and motivated to look forward to much more academic achievement under your guidance. including upcoming national and international webinars and conferences that will further enhance the prestige of our institution at a global level. Once again, thank you, Principal Sir, for guiding us with your wisdom and for always striving to elevate our college to new height of academic excellence. We welcome you, sir.
थैंक यू कायनात विश यू ऑल द बेस्ट अच्छे से करो ठीक है एंड आगे प्रोसीड करो आप
Thank you so much, sir. Our Vice Principal, Ms. Aisha Khan, whose dedication and coordination bring every event for life, and the organizing committee, whose meticulous planning has made this webinar possible, and all the students, attendees joining us online, I welcome you all. We hope today's session will not only enhance our knowledge, but also motivate us to take meaningful steps toward better health practice. Once again, I welcome to all and wish this webinar great success. Thank you, and with great enthusiasm, let's begin the session. We are truly honored to be in the presence of most respected leaders and nursing experts who has graciously joined us today to enhance their deep knowledge and insight on their various aspects of hypertension is silent a serious health concern affecting millions globally. Thank you. Over to Ms. Diksha ma'am.
Thank you, Ms. Kainat ma'am, for that warm and heartfelt welcome. Now, I am pleased to invite our Vice Principal, Ms. Aisha Khan ma'am, to introduce our esteemed institution and to acknowledge the gracious presence of our Honorable Chairperson, our Visionary Director and distinguished speaker, and our respected Principal, sir. Over to you, ma'am.
Am I audible?
Yes, ma'am, you are audible.
Good morning, esteemed guests, participants, and colleagues. It is with great enthusiasm and honor that I introduce you all to this prestigious national webinar on World Hypertension Day. The theme of this year, Measure Your Blood Pressure Accurately, Control It, Live Longer, powerfully underscore the critical significance of precise blood pressure monitoring and proactive management for sustaining long and healthy life. World Hypertension Day, observed globally 17th May, serve as a vital platform to amplify awareness about the silent threat of high blood pressure and to empower individuals with the knowledge to combat these pervasive health challenges. Today's event is a confluence of knowledge, expertise, and commitment decided to advancing hypertension awareness and control. I am Aisha Khan, Vice Principal of the esteemed College of Nursing, Ruma Institute of Medical Sciences, Pratapgarh, and it is my distinct privilege to acknowledge the presence of the distinguished dignitaries and renowned experts gracing us with their presence and invaluable insight. First and foremost, let us honor our visionary chairperson, Dr. Rajen Singh sir, whose pioneering leadership has been the cornerstone of the Ruma institution's remarkable journey. From the establishment of the Ruma Hospital in 1987, a beacon of compassionate healthcare to the foundation of the Ruma institution in is to be guided by the dynamic and dedicated leader of our director, Dr. Manish sir, and Dr. Manisha ma'am, whose unwavering commitment has propelled this institution to new pinnacles of academic excellence and healthcare innovations following the ultimately loss of late Anis Singh sir. It is now my honor and pleasure to introduce a stellar panel of speakers, a group of erudite scholars and practitioners whose expertise and passion promise to illuminate today's discussion. Dr. Smriti Arora ma'am, Professor cum Principal, Center of Excellence in Nursing Education and Research, College of Nursing, AIMS Rishikesh, renowned for her work on accurate management of blood pressure. Dr. Suchna Roy Bhumik ma'am, Assistant Professor, College of Nursing, KGMU Lucknow, recognized for addressing the challenges in managing resistance hypertension in India. Mr. Malathi ma'am, Assistant Professor, Geetam Institute of Nursing, Vishakhapatnam, acknowledged for her insight into the impact of environmental and blood pressure on population health. Dr. Lucknow and Vice President TNAI UP, acclaimed for her expertise in the pathophysiology, genetics, and epigenetics of hypertension. Dr. Gopi Chandran Sir, Assistant Professor, and Mrs. Latasha Ma'am, PhD scholar, both representing NIMHANS, Bangalore, distinguished for their work on hypertension control through the Heart Initiatives. Mr. Abhishek Sir, Mental Health Nursing Tutor, GIMS, Greater Noida, working on BP by 200 mm of plant. Mr. Panwar Sir, Nursing Officer, GTB Hospital, New Delhi, respected to his guidance on dissemination and implementation strategies for effective hypertension control. We are truly honored to be the presence of such highly respected thought leaders and healthcare professionals. Their scholarly contribution and vast experience will undoubtedly broaden our understanding of hypertension, a condition that continues to challenge public health system globally. Thank you all of your attention and enthusiasm. Let us make this event a memorable and impactful milestone in our collective fight against hypertension. Without further ado, I invite our skilled and charismatic moderators, Ms. Diksha ma'am and Ms. Kainat, to gracefully steer this program forward. Thank you.
Thank you so much, ma'am, for beautifully highlighting the essence of our institution. To begin today's enlightening session, we are honored to welcome you, a truly exceptional speaker, Dr. Smriti Arora ma'am, Professor cum Principal, CENER, AIMS Rishikesh. She will be discussing the importance of accurate management of blood pressure. Over to you, ma'am.
A very good morning to all of you. At the outset, I would like to say thank you to all the organizing committee and especially the principal for having me on this stage today. Indeed, hypertension is a big problem in our country and it will lead to a lot of problems if not managed properly. So,
and yoga session and sanitary napkin distribution and anemia program of student and ANC mother and LCD clinic of the diabetics mental health, cancer, stroke, and diabetes, and COVID-19
Yeah.
ENT. Paralysis and
I think Dipti ma'am's mic is on. Somebody else's
Sorry,
mic
ma'am.
is.
Sorry, ma'am.
Yeah, it's
Please,
okay.
technical team.
Yeah, so a lot of congratulations to all of you on this when you have decided to take this step to celebrate this World Hypertension Day. Since I have a
Thank
very
you, ma'am.
important academic commitment, so may I request Miss Devanshi, who is a very intelligent faculty in our College of Nursing, and she'll be taking this subject. Thank you very much.
Yeah, thank you, ma'am. Thank you. Take care, ma'am. We are pleased to inform you that Miss Devanshi Chaudhary, ma'am, nursing tutor AIMS Rishikesh, will be taking her place in today's session. We are grateful to her for stepping in on short notice and sharing her valuable insight with us. She will be discussing the importance of accurate management of blood pressure. Over to you, ma'am. Devanshi Chaudhary, ma'am.
As already introduced, I'm Ms. Devanshi Chaudhary. I would just like to know if I'm audible or not.
Yes, ma'am, audible.
Anyone? Okay, so I'll share my PPT. So sharing is also not turned on. Please just turn on the sharing also. If it's a problem, then you can share the PPT. It's not an issue for me.
And you can share. I will share. Ma'am, just a minute.
It's okay. You can share the PPT if it's not happening. It's okay.
Just few minutes, ma'am.
Okay, okay, no problem.
Let me give introduction about Ms. Devanshi Chaudhary, ma'am. Ms. Devanshi Chaudhary is a PhD scholar recognized by Indian Nursing Council in 2023. She holds an MSc in nursing with a specialization in cardiology, CTVS nursing, along with BSc in nursing. She has professional experience in cardiothoracic vascular surgery and operation theater, CTVS, and intensive care unit, and has also served as a heart failure nurse at AIMS Delhi. Currently, she is working as a nursing tutor at AIMS Rishikesh. She has conducted numerous national level certification and continuing education programs for nurses across India. Ms. Chaudhary ma'am works closely with the TNAI and SOCN and is recognized as a pioneer in organizing ECG training programs for nurses, including hands-on training. She has authored 12 research publications, including 2 articles indexed in Scopus and 2 in PubMed. Now, please share, ma'am, slide PPT. Ma'am, please share your PPT.
Okay, okay.
You are authorized, ma'am. Thank you, ma'am.
I think it would be better if you share it because there is some problem from my end. I'm new with this laptop, so can you share it for me?
Just few seconds. We are sharing. Just few seconds.
Sorry,
So
sorry for
sorry
the
for
inconvenience.
inconvenience.
I think it's okay. It's okay. I open it. I hope it's visible to everyone.
Yes, ma'am, it's visible.
Is it visible to everyone? Thank God.
Yes,
Thank you
ma'am.
so much. So we'll start without any further delay. We'll start with the topic that is accurate blood pressure measurement. I hope all of you are nursing students, maybe nurses somewhere, and you need to take the blood pressure measurement accurately.
Can
So
you make
we'll
it full screen, ma'am?
full screen. Okay.
Yes.
Is it okay now? Okay.
Yes, ma'am.
So we'll start with the clinical scenario. Clinical scenario, a woman, she's aged 72 years, has blood pressure of about 150 by 70 mmHg and 150 by 80 mmHg, obtained by a medical assistant on consecutive office visit, and she does not have a history of hypertension. The blood pressure cuff is properly sized. The assistant is inquiring about the patient's last mammogram while obtaining the blood pressure, and the patient is helping to hold her arm up with the medical assistant's grasp. The mean of a dozen blood pressure readings that the patient has obtained at home is 128 by 64. Does this patient have white coat hypertension? Probably yes. Maybe there are reasons of this blood pressure variations, like we will dive into the topic more and we will come to know about it. But in this particular scenario, you can know that the medical assistant is talking to the patient regarding the mammogram. Obviously, this is something concerning for the patient, and probably this is the reason why again and again the blood pressure readings are coming out to be slightly raised, because by 64 there are so many things that we have to keep in mind while taking the blood pressure, and it is very important because as a nurse we need to know that how to take the proper accurate measurement of the blood pressure. Okay. So hypertension remains a leading risk factor globally for deaths, and quantitatively is the most important non-communicable disease because it has its impact on cardiovascular, neurological, and renal disease. So we have three main diseases that hypertension is actually a very big risk factor for. That is the stroke, we have the heart failure and the heart attacks, obviously, and we have renal disease, that is CKD. And because of this, hypertension remains the leading risk factor. Over 1.28 billion people worldwide, they are estimated to have hypertension, and only 1 in 5 people are adequately controlling it. So this is contributing to about 10 million deaths per year. This is the data that is given by the CDC, and that is why it is also known as a silent killer. The hypertension is known as a silent killer. If we talk about India, the NFHS 5 data, which was done in 2019 to 21, it showed a prevalence of elevated blood pressure of 21.3% in females and 24% in males, age 15 and above. This is a considerable increase from the NFHS 4, where the prevalence was 19 and 17% respectively. So in India also, it is it is increasing at a tremendous percentage, and a lot of people, about 8% people, they do not even know that they have hypertension. Of the total complete people that have hypertension, about 8% people, they are undiagnosed. They do not know for a long time that they have hypertension, and that is leading to a lot of heart failures at a very young age. So why is accurate BP measurement needed? Now, BP, obviously, you know that it has a lot of the hypertension, it has a lot of adverse effects, and that is why we need to accurately measure it. Then if we start with we have wrong BP measurements, and we start with different treatments, then the side effects of it are also very severe. And obviously the patient also has psychological distress. So we cannot take a wrong BP measurement and start treatment on that. Again, on the point of care diagnosis, it is also important, because many risk stratifications, like in the Apache also, if you see, and many cardiovascular risk stratifications, we have BP as a very important criteria. So we need to know that BP is right. The measured BP is actually the correct BP, and also for proper medication dosing. So just, I think a lot of people might be knowing how to measure BP correctly. This is something that you might have known. It is just a revision and maybe some detailing about what happens if you take the wrong BP. We have rest and ingestion. So you have to confirm that the patient is completely rested. In a various amounts of studies, it has been seen that at least 5 minutes is needed for the patient to rest, because you do not know maybe for a person, maybe only walking is too much of physical exercise. Maybe for a patient, only one flight of stairs is a complete exertion. So you have to confirm at least 5 minutes. They say that at least 5 minutes the patient has to rest before taking the blood pressure. Ingestion, what has the patient ingested? Maybe caffeine, smoke of the patient. The position of the patient should be such that the patient should be sitting on a chair, upright, back supported, with the feet flat on the ground, and the arm should be supported. Arm should be supported, and arm should be at the level of the heart. I hope everybody knows that. Then the cuff placement and cuff size. The cuff placement should be the lower end of the blood pressure BP cuff should be about 2.5 centimeters above the cubital fossa. And we have the cuff size. Now for the cuff size, we have the 80-40 rule of the BP cuff, which says that 80% of the it should be covering at least 80% of the length, circumference of the patient, and 40 means that the bladder cuff. We are talking about the bladder cuff. Bladder cuff should be covering at least 40% of the width of the complete forearm of the patient. Then, okay. And also it is said that we should have multiple readings. So we should not have only one reading to diagnose whether the patient is having hypertension or not. Even at a particular point, at a specific point also, we should have 2-3 readings. And then we should, again, for 1 week, we should ask the patient to take the blood pressure at home, and then finally start with the medications or not. The bell or the diaphragm. In this stethoscope, if you see, we have the bell and the diaphragm, and most of you might be using the diaphragm because of its easiness, its ease to use. But according to the book picture, if you see your books, it might be saying that the bell is better. Why is the bell of the stethoscope better for hearing the Kortokov sound is that it picks up, the bell is very good at picking up low intensity sounds like the murmurs and all. So it is the Kortokov sound is a very low intensity sound, and that is why we need that the bell is better. The book says the bell is better, but if we have done so many researches, there are so many researches on the net. If you can see that they have said that there is no difference between the bell and the diaphragm. Terminal digit preference. Terminal digit preference means that even if someone comes to you, आपने एक पेशेंट का ब्लड प्रेशर लिया एंड देन यू हैव दिस पेशेंट जिसका ब्लड प्रेशर आया है 138/78. नाउ rather than writing 138/78, many people they write 140/80. Now which will come into a classification of stage 1 hypertension. Now that is something that is wrongly measuring our blood pressure. So that digital preference also should not be given. So you should exactly note what is the actual blood pressure rather than giving the digital preference, that you are ending the terms, the systolic blood pressure and the diastolic blood pressure with 0. You're writing 140 instead of 138, or you're writing 80 instead of 78. Now for the obese patients, we come across so many obese patients in our ICUs or maybe wards and all, and you might not have actually you should have a cuff that is for the obese patients, and you should ideally have, but we have limited resources obviously in India. So we use forearm blood pressure in these patients. So we actually use the forearm for taking the blood pressure rather than the arm. Now in this forearm blood pressure, then again there is something that we have to keep in mind is that there are pressure differences. The actual pressure differences are there. That is about 3.6 in the systolic and 2.1 mmHg in the diastolic. They are higher than the upper arm. So normally, if you would have taken that the blood pressure of the patient from the arm, it would have been a slightly lesser. But now, because you're taking from the forearm, it is slightly higher. So that thing has to be kept in mind. About approximately 5 का plus minus लेके रख सकते हैं. ठीक है. Use of a standard BP cuff increases systolic blood pressure by approximately 10 mmHg. Now you use a standard BP cuff, normal adult cuff for a patient who is very obese, you will see an increase of about 10 mmHg. Okay. For people who are aged 70 years, the National High Blood Pressure Working Group report on hypertension, it has said that a standing blood pressure has to be taken. Now, why standing blood pressure has to be taken? Because sometimes these patients, while standing, they have hypotension, and if the patient is sitting, then the patient might have blood pressure on the higher side. So we need to know what is a standing blood pressure also, so that we can accurately manage the BP. Now, when a patient comes to you with who's 70 years, 80 years, you take a standing blood pressure always. You have to take it. It is good for you to take a standing blood pressure and then refer it to the physician. Okay. So while you're taking a standing blood pressure, the thing that has to be kept in mind is that you have to support the arm of the patient. If you do not support the arm of the patient and the patient is putting the full strength to just support it by himself, then there will be increase by 6 to 10 mm of Hg. Okay, so arm support is very important. And then also you have to confirm that the patient is standing 2 to 3 minutes before you take the assessment. You ask the patient to stand up and you ask the patient to stay standing for about 2 to 3 minutes. And after that, you take the blood pressure. Okay. Then there is another thing that is there very commonly in patients who are 70 years above, and even patients who are 65 maybe, and who are having hypertension, diabetes, CKD. So pseudo hypertension is one other thing that is there. Pseudo hypertension means the patient is actually not having hypertension, but is actually having arterial stiffness. उसकी आर्टरीज जो है वो स्टिफ हो गई हैं और उसके कारण मे बी द पेशेंट इज एक्चुअली द बीपी इज कमिंग हाई but the patient is not having any kind of hypertension. Okay, so that has to be also checked. So whenever a patient with 70 years and above comes to you with saying that maybe आज सुबह मेरा बीपी 170/80 था, फिर अचानक से कम हो गया, फिर अचानक से बढ़ गया, so that is something like it is a peculiar feature of arterial stiffness, and that has to be kept in mind whenever we are taking blood pressure of these patients. Proper history has to be taken in such patients. If you think that the patient is 70 years and above, proper history, whether the patient has hypertension, diabetes, CKD, then arterial stiffness could be one of the reasons why the patient is having arterial stiffness. Then there is another thing that you can do. You can confirm that this is arterial stiffness or not, and for which no test is needed, is Osler's maneuver. Osler's maneuver says that आप normally वैसे systolic blood pressure जब आप नोट करते हैं, you inflate the blood BP cuff to more than the systolic blood pressure. Okay, so you inflate the BP cuff to more than the systolic blood pressure, and you check for the radial artery. So you check for the radial artery. The radial artery is palpable. So if the radial artery is palpable but is not pulsing, pulse it as arterial stiffness. Now for this patient, you have to send the patient for other tests before starting any kind of medications, because maybe the patient is not having hypertension, maybe the patient is only having arterial stiffness. Okay, so the other tests that you are consulting, you are sending the patient are pulse wave velocity, and then again you can do serial measurements like अभी दो थोड़ी देर बाद फिर से बीपी ले लिया, थोड़ी देर बाद फिर से बीपी ले लिया, and then you can confirm की एवरेज लेके. हेलो, कट गया क्या? हाँ जी, कौन बोल रहा है? हेलो, कौन बोल रहा है? कौन बोल रहा है? Not now, not now, thank you. Sorry for the interruption.
Ma'am.
Just a minute, sorry.
It's okay, ma'am.
Mm. I thought my connection got interrupted. I thought you called. So, okay. So we can move. So we were at pulse wave velocity. What is pulse wave velocity? That you check the distance, the time the pulse takes from traveling from a specific point to a specific point. ठीक है, like maybe from the brachial artery to the radial artery, कितना time लगता है, and that delay is increased in arterial stiffness. And this we are doing it with the help of ultrasounds and MRIs and all. And if we come to know about the pulse wave velocity, we can accurately diagnose the patient actual BP कितना है without taking the intra arterial BP. So this is something that we can do. Okay. So just a few pictures that will show that how BP should be measured correctly. There is this woman who's sitting, arm supported, back supported. No one's talking to this person, at least. And the legs are completely rested. So this patient is, the BP that comes out would probably be completely right. Then if you want to take some the blood pressure, if the patient is in sitting position on the bed. Now you have to also keep in mind that supine blood pressure, if you take, like the patient is sitting in the bed, maybe lying down in the bed, that is different than the patient sitting on the chair. And the chair BP is the confirmative BP. Okay, so you have to make sure that the patient can sit on the chair. You should always take the chair BP, not the sitting on the bed or lying down on the bed. That is not the correct BP. Standing BP, as you can see over here, the person is completely holding the arm of the patient, and they should not be talking also, but I think they are talking, right? So that should not be done, obviously. Magnitude of these factors. Obviously, we know that the patient, if you're doing all you're taking the wrong cuff, or maybe you're not letting the patient rest, or the patient is talking to you and all. So at that point, these they can affect the blood pressure, but about how much. Maybe it's just 1, 2. So you do not need to obviously take the BP again, right? You don't have time enough. But if there are things that increase the blood pressure to about 20 mmHg, obviously, then you have to take the blood pressure again. So we need to know what are these things that increase or they produce a variation at a higher amount of, the magnitude is increased. Like appropriate cuff size, if the cuff is too small, the blood pressure can increase to about 20 mmHg. So obviously you have to think that you have to have that in mind. Cuff too large, 1 to 6 mmHg. Resting, if there is no rest period that you have given to the patient and just the patient has come, then it can increase to about 10 to 20 mmHg. If you're talking or texting or the patient is texting, then it can increase about 10 to 15 mmHg. Drinking coffee can increase about 5 to 8 mmHg. Full bladder, okay? The patient has to be told to empty the bladder, okay? And this is more in patients who are adults and all, because they're not able to hold the urine and they are incontinent, and that is why they will be, the magnitude of these factors will be more in that. 10 to 15 mmHg. Excess alcohol consumption, that will increase about 5 to 8 mmHg. Sitting upright, the back is not supported, 5 to 15 mmHg. Crossing legs or legs dangling, the legs are not on the feet, it will increase about 5 to 8 mmHg. And measurement over clothing will increase about 10 to 50 mmHg. So always on the bare arm, always on the bare arm. Okay. This is just a systematic review. So systematic review is some, for the people who do not know, it is the highest level of evidence. And this was published, this is an article, and the important things that are there from the article, I have just mentioned it over here. What are the sources of inaccuracy in measurement? This is from the Journal of Hypertension 2024. Most of the factors we have already discussed, but there are some other factors that needed some light. That is patient-related sources of inaccuracy. Now, for the patient-related source of inaccuracy, acute meal ingestion. Now, they say that in the study they found out, the systematic review, they found out that there was significant decrease in both the systolic BP and the diastolic BP. 180 minutes, that is about 3 hours, even more than 3 hours actually. No, 3 hours. 3 hours. After 3 hours, there was significant decrease in systolic as well as diastolic BP. But just after, like 1 hour after the food, there was no significant decrease. So all these things have to be kept in mind whenever you're taking the blood pressure. That is why we say we should be taking the blood pressure at the time, at the same time every day. It should not be like कभी खाना खाने के बाद कर लिया, कभी खाली पेट कर लिया, ऐसा नहीं करना है. It should be at the same time every day. Okay. Acute alcohol use, it can increase the BP response even after 3 hours. Even after 3 hours, it can increase the BP to about 5 to 8 mmHg. Caffeine intake, again, caffeine intake can also increase. सुबह किसी ने कॉफी पिया है, दोपहर में maybe 9 o'clock पिया है, 12 o'clock BP check करा रहा है. Again, the effect of the caffeine is there for 3 hours itself. So that has to be kept in mind. Acute nicotine use or exposure, this is about 30 minutes. If the patient has had in about 20-30 minutes, then there is considerable changes, significant changes can be seen in the patient's BP. Bladder distension, then I've already discussed this. This is the same thing that they're saying. Then cold exposures, you might have seen patients, they will complain, or maybe old age people, they may complain कि सर्दियों में BP बढ़ जाता है. सर्दियों में BP बढ़ना is a normal thing. ठीक है. Cold exposure will increase the BP significantly. ठीक है. So many studies were there in the systematic review, many studies, and all the studies said that cold actually significantly increases the systolic blood pressure. Okay, so next time someone says कि ठंड में BP बढ़ जाता है, it is a common thing. Okay, but obviously it should not increase to a limit that it is intolerable. But a little bit of increase during cold season is normal. Paratic arm. You have been told, I guess, multiple times, you do not take the blood pressure on the paratic arm. This is the reason that there is significant increases in both the systolic BP, the diastolic BP, as compared to the intact arm. Then they can be device-related sources of inaccuracy. कभी देखा होगा कि कभी automated devices जब use करते हैं, the normal automated devices that we are using, sometimes there is they'll show you're having hypertension. Sometimes they might show you're having hypertension. So they are not obviously accurate नहीं होती वो. Okay, so we'll just dive into this. So we have mercury devices and aneroid devices. Both of these, they will underestimate the systolic blood pressure. Okay, underestimation of the systolic blood pressure is there, and a little bit of overestimation of the diastolic blood pressure. Okay, so you go to the you did a blood pressure at home, and then you go to the hospital, to the physician maybe, and he was using a mercury or an aneroid device, which is basically usually an aneroid or mercury devices are used by the physicians and even the nurses. So they will be moderate. You can think that there is an underestimation of your systolic blood pressure to a smaller moderate amount, and overestimation of your diastolic blood pressure. That happens because of these devices. Okay. Then automated devices में बहुत variation है. They sometimes they can say you it is less, sometimes it is very high, sometimes so they say plus minus 5, but it can go up to plus minus 10 also in some cases. So what is the gold standard? The gold standard is an invasive intra-arterial blood pressure measurement. You put an intra-arterial line and you measure the blood pressure. Obviously, you cannot do that for this for most of the patients. Okay, so if you really want to know the exact intra-arterial blood pressure is to be done. There can be procedure-related sources of inaccuracy like insufficient rest period, already discussed. 5 minutes to देने ही है, confirmatively देने हैं. You can go up to 15 minutes, that is better. But if you are void of time, then 5 minutes is needed. Body position, again, small to moderate significant increases can be there in the sitting position. Legs crossed, again, there'll be increases. Unsupported back, and stethoscope under the cuff. Okay, this many of the people might be doing, but stethoscope should not be put under the cuff. Okay, small but significant increases have been shown because of that. So stethoscope under the cuff is also not right. The cuff should be about 2.5 centimeter above your cubital fossa, and the stethoscope should be not touching the cuff. It should not be even under the chair. It should not be even touching the cuff. So that will give you an accurate measurement. And most of us do this, that हम लोग उसको अटका देते हैं उसके नीचे, but that should not be done. Bell versus diaphragm. Again, the use of bell, it has shown that reduced systolic blood pressure measurement by a small amount can be there in trauma patient, and it can be increased by a small amount in young women, while diastolic blood pressure shows no difference. So bell versus diaphragm is actually nothing to be worried about. You can use a diaphragm, you can use a bell. These are not very big variations that we need to be concerned about. Fast cuff deflation. Whenever someone is teaching you how to measure the blood pressure, they are always telling 2 to 3 mm Hg. धीरे धीरे थोड़ा deflate करना है. धीरे धीरे कितना? 2 to 3 mm Hg per second. इतना धीरे deflate करना है. But if you're not doing that, there can be small to moderate decreases in this systolic blood pressure and small to moderate increases in the diastolic blood pressure. But obviously it is small to moderate, so sometimes the physicians are not, but if you really want to know the correct measurement of the blood pressure, you have to do this. Okay, so very slowly you have to deflate the cuff. Inter-arm variability is also there. दोनों arms में variation है. तो अगर आप एक काम कर रहे हैं, you should always be taking of the left arm. They say the left arm is more correct to take actually, but there can be variations between the systolic and diastolic between both of the arms, which can vary to about 5 mmHg. Okay. There can be observer related differences also, like observer related, like hearing deficits हो सकता है. Observer को सुनाई नहीं दे रहा. Maybe the patient is not having a blood pressure problem, but the hearing deficit है. Old age physicians, old physicians, they may have some problems. And quote of sounds interpretation. How are you interpreting that sound? Okay, that is also important. आपको सुनाई दे रहा है क्या? आप हल्का सा sound interpret कर रहे हो. Maybe you are waiting for the sound to be more clearer and then you are interpreting it. So that thing also, it depends. So there are 10 errors in this picture. Can you list only 2 of these? There are, I think there are about 200 passive participants or maybe 150 participants here. And only if you can just list me about 2 and we can move on to the next slide then. Anyone? Just 2. Anyone?
नहीं कर पा रहे कुछ लोग।
No, I need an answer from you people. 2, at least 2. There are 10 mistakes that she's doing. Only 2. The organizers can answer too. I think the organizers are also students, so they can answer maybe.
मैम आई थिंक आई लेवल पे होना चाहिए स्टेगनोमैनोमीटर.
Yeah,
And
not the eye level,
circulation
but
is not
at the
good.
heart level. The heart level. Okay.
Ma'am, the
So
patient is sitting legs crossed
yes,
Yes,
legs
ma'am.
crossed.
and
That
the
is
back
wrong.
is not supported,
Back is not supported.
and both of them are having a conversation during the BP recording or measurement.
Yes. So quite about a lot of things that you have said. Again, she's talking also. The BP cuff is also, if you see, that is not properly adjusted.
Yes. Yes.
So many things are there, and errors. There are 10 errors. Personally, I also didn't find the 10 errors actually, but there are 10 errors from the place that I took it. So at least 5 of them we can easily see.
Yeah.
So why is it so important to manage blood pressure? So important. Because there are 3 things that are very problematic because of the blood pressure: is stroke, there is the heart problem, and then we have the kidney disease. These three vital organs, they're vital organs and they are affecting the blood pressure. And other things that we can have sexual dysfunction, vision loss can be there, and many other things. But these 3 things are the main important points. That is why we need to accurately manage blood pressure. So talking about the heart diseases, why do high blood pressure cause heart diseases? There are various pathophysiologies. Now, because of the high blood pressure, what happens is that the arteries, there are micro tears in these arteries. छोटे छोटे tears होते हैं, छोटा छोटा फट जाता है artery जगह जगह से. And because ये फट जाता है, the platelets will come there, they will clot, they'll form a big plaque, and the atherosclerosis process will start occurring. So it will cause the coronary artery disease. So a high blood pressure will finally cause a coronary artery disease. Again, it can cause ischemia and angina. Then increased afterload. What is afterload? Afterload is the pressure that the left ventricle has to overcome to fill the aorta. ठीक है? तो अयोटा का जो प्रेशर होएगा उसको ओवरकम करना पड़ेगा लेफ्ट वेंट्रिकल को, एंड दैट इज द आफ्टरलोड. तो वो इंक्रीज आफ्टरलोड हो जाता है बिकॉज अयोटा का प्रेशर बहुत ज्यादा है, बिकॉज पेशेंट को बीपी है. तो अयोटा का प्रेशर ज्यादा है तो लेफ्ट वेंट्रिकल भी बहुत ज्यादा काम करेगा, और जब वो बहुत ज्यादा काम करेगा तो देयर विल बी हाइपरट्रॉफी ऑफ दैट लेफ्ट वेंट्रिकल. ठीक है? एंड देन देयर विल बी हार्ट फेलियर बिकॉज ऑफ दैट. फर्स्ट ऑफ ऑल हाइपरट्रॉफी होगा, इट इज ट्राइंग टू push out the blood. थोड़े टाइम के लिए it will be fine. Later on, what happens is the heart will start failing. There will be heart failure. ठीक है? Also because of this hypertrophy, क्योंकि जितना अगर मसल मास बढ़ जाएगा तो जो जगह है वो तो कम हो जाएगी ना ब्लड को आने के लिए. तो सिस्टोलिक डिस्फंक्शन तो होगा, डायस्टोलिक जो भरने वाला डिस्फंक्शन है वो भी होगा. So systolic dysfunction के साथ diastolic dysfunction भी होगा. So this can lead to a variety of problems. BP can lead to a variety of heart problems, and then we have arrhythmias also that can lead to. Then we have stroke. Again, for the same reason, same pathophysiology, there's it can lead to ischemic stroke. ठीक है, micro tears हो जाएंगे, plaque buildup हो जाएगा, atherosclerosis हो जाएगा, and there will be ischemic stroke. Okay, it can lead to hemorrhagic stroke also, obviously, because high blood pressure है, weakened walls हो जाएंगी, तो it can cause aneurysm, abnormal dilatation of the vessel wall, and they can be bleeds. Hemorrhagic stroke हो सकता है patient को. ठीक है, although this is not the aspect of the class, but I would want to just emphasize be fast. Be fast means stands for, these are the signs of stroke that you need to know, that you need to accurately see the patient, and so that the patient can get treatment as soon as possible. B fast, that is, B is balance. There will be loss of balance or coordination. E is eyes. There will be change in the vision. There is blurring. The patient is not able to see. F is for the face. Face starts drooping. There will be drooping of one side of the face, or maybe both sides of the face start drooping. Arms. The arm, the patient cannot hold up any arm. You ask the patient to hold up the arm straight, and the patient is not able to hold up the arm straight. There'll be weakness in the limbs. Then speech, slurring of speech will be there. And T stands for time. Okay. So time कीमती है, time को जल्दी हमें, मतलब we have to keep that thing in concern. Okay. Any of these three symptoms, if the patient is having any of these three symptoms, then the occurrence or the probability that the patient is having stroke increases by 72%. 72% तुम probability बोल सकते हो कि हाँ भाई patient को stroke ही है. ये 3 signs हो जाएंगे तो, ठीक है, इसमें से कोई भी 3 signs, ठीक है. Then we have metabolic syndrome. Metabolic syndrome क्या है? Metabolic syndrome is that the patient is having any of these factors that I'll be discussing is the high blood pressure है patient का, ठीक है, high triglycerides है, high or low HDL है, diabetes है, okay. All these, any of these three conditions that the patient has, and the patient is having metabolic syndrome, that you can say the obesity is also one of the thing. So any of these three conditions, and the patient is said to be having metabolic syndrome. Okay, so BP affects metabolic syndrome, is a cause of metabolic syndrome, and metabolic syndrome, any of the things from the metabolic syndrome will affect the BP inversely. Okay, chronic kidney disease, each condition exacerbate the other. BP है, CKD को exacerbate करेगा, CKD BP को exacerbate करेगी, ठीक है, दोनों एक दूसरे को increase करेंगे. Each condition exacerbates the other. Again, same चीज है कि arterial जो small vessels हैं, they start breaking up. Because of this microtubules, plaque formation होगा and arterial nephrosclerosis होगा, ठीक है. Nephrosclerosis will be there, and CKD will start setting in. It will start setting in. Once it sets in, it will cause hypertension. How will it cause? CKD will cause hypertension by the RAS mechanism. Okay, sodium और water को retention करवा देगा and increase करवा देगा BP. Then it can also increase the sympathetic tone. CKD वाले patients का sympathetic tone भी increase हो जाता है, heart rate, BP, वैसी sympathetic activity increase हो जाती है उनकी. So that will also increase blood pressure. There are other things that are there, that is vision loss can be there. There can be hypertensive retinopathy, glaucoma, macular degeneration, optic nerve damage. The place where the optic nerve is entering is the place where the other vessels are also entering. The blood vessels and everything is entering. So if there is any blood pressure changes in the blood vessels, so the optic nerve will also be damaged. Sexual dysfunction can also be there in these patients. Patient can have erectile dysfunction due to damage of the small vessels, which reduces the blood flow, and there can be nerves damaged also, which can again result in sexual dysfunction. There are many other things that can occur because of high blood pressure. That is why we have to keep in mind, we have to think of it, that the patient is accurately measured and managed, blood pressure is there. So I think that is all from my side. Anything that the students need to discuss, or there is anything that has to be done, please tell me.
Thank you so much, ma'am, for detailed presentation.
Thank you.
Continuing this journey of learning, we now invite our brilliant speaker, Dr. Suchna Roy Bhaumik, ma'am, Assistant Professor, PhD Nursing, College of Nursing, KGMU, Lucknow. She will speak on challenges to managing resistant hypertension in India. Right. Important. It is with great honor that we introduce Dr. Suchna ma'am, a highly respected nursing professor and academician with an impressive career spanning more than 2 decades. Dr. Suchna ma'am holds a PhD in nursing 2018 and MSc nursing 2010. She has accumulated over 23 years of teaching and clinical experiences, contributing immensely to the field of nursing education and student development. She currently serves as the Assistant Dean of Student Welfare and Assistant Provost of the Midwifery Hostel at King George Medical University. She is also the Nobel Officer for NAAC at the College of Nursing. She is chairperson of disciplinary committee. She is working KGMU College of Nursing examiner for the UG PG student. Dr. Suchna ma'am plays an active role in academic evaluation as an examiner for both undergraduate and postgraduate nursing programs at KGMU. She also have been an inspector for the University State Council and the Indian Nursing Council INC. In addition, she contributes as an academic counselor for the BPCCHN course. She is an esteemed member of several key institutional committees and is actively associated with prestigious professionals bodies such as Trained Nurses Association for India, TNAI, Critical Care Nursing Society, Nursing Research Society of India, and Asian Cardiac Nursing. Dr. Suchna ma'am has an impressive record of scholarly work with 22 research publications and 4 articles in Sovereigns. She has been a prominent figure in numerous national and international conferences, serving as a resources person, chairperson, delegate paper presenter, and organizer. We are privileged to welcome Dr. Suchna ma'am to this platform and look forward to gain from her expertise and experiences. Over to you, ma'am.
मैं से नहीं हो रहा है। हो गया नाम हो गया। पता नहीं, मैं तो खोल ही नहीं पा रही हूँ। हाँ देखती हूँ नाम अपने। तो तुम मुझे दिख रही हो। एक मिनट। हाँ मैम आपके स्पीकर पे है, आपका हो गया म्यूट। हाँ हाँ, शेयरिंग आप करोगे, मैं कर लूँ पीपीटी। शेयरिंग मैम आपको थॉरलाइज कर दिया गया मैम, आप कर सकती हैं। ओके, जस्ट वन। सुनिए, ये फोन हम ले रहे हैं आपका। आप शेयर कर दीजिए, आपके साइड से थोड़ा सा प्रॉब्लम हो रही है, मुझे ऐसा लग रहा है। बोलो, आप शेयर कर दीजिए। मैम, because of some technical issues, we are unable to share. Same here. Just few seconds, ma'am. We are sharing slide. Are you sharing?
हेलो, हाँ मैडम,
हाँ, यस।
आपका स्क्रीन शेयर किया हुआ है मैम।
क्या हुआ, लेकिन मुझे दिख ही नहीं रहा है। मैं भी वही देख पा रही हूँ, लेकिन मेरा पीपीटी दिख रहा है कि नहीं मुझे नहीं पता।
अच्छा ठीक है, आई विल शेयर, आई विल शेयर।
वेट वेट, मैं जस्ट खोल रही हूँ, एक बार मुझे लेट मी नो।
ओके, हाँ ओपन हो रहा है मैम, इट्स वर्किंग।
ओपन हो रहा है ना?
हाँ हाँ, इट्स वर्किंग।
ओके। इज इट विजिबल?
यस मैम, इट्स विजिबल।
ओके, देन आई कैन
डू
स्टार्ट।
फुल स्क्रीन, हाँ डू फुल स्क्रीन मैम। ओके,
ओके।
इट्स फाइन मैम।
Good morning to all. Thank you very much, the organizing team, to allow me for the speech for today's webinar. And sorry for the little bit technical glitch. So we'll continue with that. I actually don't know who are the candidates of this today's webinar. Participants, are the BSc students, GNM students? Who are they? Based on that, the teaching will be taken place. Can I know that? Is it the GNM students or BSc?
Madam, it's a BSc GNM students also, as well as
It
faculty
is a
members.
mix. Okay,
हाँ,
then the
mix,
language
mix.
mix. Then I will mix the language of Hindi and English. Okay.
Sure,
Okay.
no issue.
Okay, fine. ठीक. As you have already discussed today's and hypertension day, आप लोग का सब सेशंस हो रहे थे बहुत अच्छा से। इससे पहले प्रीवियस स्पीकर्स ने स्पीक किया कि कैसे आपका हार्ट डिजीज होता है हाइपरटेंशन में। टुडे वी विल टॉक, माय टॉपिक इज ऑन मैनेजिंग द रेजिस्टेंस हाइपरटेंशन. Okay, so we'll go what is hypertension and India, what is the problems, all these things will go one by one. So first of all, because मैंने various sources से content दिया है, so I thank to all the authors whose content मैंने आज today's presentation के लिए use किया हुआ है, और purpose only to impart the knowledge to the participants or delegates, keeping in my viewpoints. So hypertension, already the things have been talked. So this is the major public health problem due to high prevalence. If you see worldwide, the hypertension is the major problem और पूरा वर्ल्ड में ये अफेक्टेड है. तो आप देख सकते हो 12.8%. यदि पूरे वर्ल्ड का डेथ रेट देखा जाए तो बहुत मेजर ये आपका डेथ रेट हो रहा है, दैट इज 12.8%. यदि आप देखा जाए मोर देन 1.3 बिलियन पीपल हाइपरटेंशन ग्लोबली अफेक्टेड है, और उसमें से 82% जो लोग हैं, दैट इज मतलब ग्लोबली देखा जाए तो 80% लो एंड मिडिल इनकम कंट्रीज में ये लीव करते हैं. तो हमारी इंडिया जैसे हमारा मिडिल इनकम कंट्री है, सो आवर पॉपुलेशन आल्सो हैविंग हायर प्रेवलेंस ऑफ दिस हाइपरटेंशन. और इंडिया अलोन में देखा जाए तो मोर देन 222 मिलियन पीपल्स हाइपरटेंशन के साथ है. द प्रिवलेंस रेट इफ यू देखा जाए WHO के हिसाब से 2030 तक, मतलब अभी हम लोग जस्ट 5 इयर्स रह गए हैं, 40%, ये 44% इंक्रीज होने वाला है. जबकि WHO बता रहा था कि ये सिर्फ 25% बढ़ना था, लेकिन जो प्रिवेलेंस इतना हायर हो जा रहा है हाइपरटेंशन कि ये 25% से 44% बढ़ रहा है. तो दिस इज सच ए बिग एपिडेमिक, दिस हाइपरटेंशन इज गोइंग टू बी इन द इंडिया. So if you go for hypertension contributes nearly 1.6 million deaths annually in India. Globally ये 12.8 दिखा रहा है, इंडिया में itself 1.6 million deaths हो रहे हैं. और main reason that complication होता है, that is ischemic heart disease and stroke. So this is the little bit brief about the hypertension and it is magnitude of problems in the world and in India. Now we'll come to my topic, that is resistance hypertension. So if you see resistance hypertension, 1 in 5 पेशेंट विथ हाइपरटेंशन, सपोज हमारे इंडिया में हमारी 5 लोग हैं, उसमें से एक को रेजिस्टेंस हाइपरटेंशन के है. और व्हाट इज रेजिस्टेंस हाइपरटेंशन, विल टॉक लेटर ऑन दैट, जस्ट यू नो द फिगर ऑन दैट. सो इतना प्रिवेलेंस हाई है रेजिस्टेंस हाइपरटेंशन का, ठीक है. एंड दिस पीपल नीड मल्टीपल ड्रग्स टू कंट्रोल द ब्लड प्रेशर. तो हाइपरटेंशन कैन बी मैनेज। आपको सबको पता है कि हाइपरटेंशन के यूजुअली कोई ऐसा मैनेजमेंट नहीं है, सिंपल है कि आपको मेडिसिन टाइम पे लेना है और लिटिल बिट एक्सरसाइज करना है, इतना सिंपल मेजर है। इसके बावजूद भी तो आप देख सकते हो हाइपरटेंशन कंट्रोल रेट्स रिमेन द लो, मतलब इतनी सिंपल इनएक्सपेंसिव होने के बावजूद भी हम हाइपरटेंशन को कंट्रोल नहीं कर पा रहे। सो कुछ बेटा रिसर्च शो कर रही है कि 20% हाइपरटेंशन पेशेंट इन इंडिया हैव देयर बीपी अंडर कंट्रोल। तो आप जस्ट इमेजिन 100% में से सिर्फ 20% लोग जो है उनकी बीपी जो है कंट्रोल पे है, अदरवाइज 80% लोग है जो नॉन कंट्रोलेबल है, जबकि ये सिंपल मेजर्स उनको लेना था। सो देयर आर हाइपरटेंशन पेशेंट्स who are not well controlled despite medications, a condition known as hypertension. Now hypertension क्या है? रेजिस्टेंस। यदि आपका मेडिसिन दे रहे हैं स्टिल आपकी बीपी कंट्रोल नहीं हो रहा है, then we call resistance hypertension. Little more detail on that will go. So definition, if you say, actually exactly definition such not given, but many authors have given their own way. Simple बात है, ये रेजिस्टेंस हाइपरटेंशन इज हाई ब्लड प्रेशर दैट डज नॉट रेस्पॉन्ड वेल टू द एग्रेसिव मेडिकल ट्रीटमेंट। मतलब आपको मेडिकेशन चल रहा है स्टिल आप बीपी कंट्रोल नहीं हो पा रहा है, देन वी कॉल एज ए रेजिस्टेंस हाइपरटेंशन। मेनली आप देखा जाए द पेशेंट शुड बी एटलीस्ट मिनिमम 3 हाइपरटेंशन ड्रग्स में पेशेंट हो, तब जाके हम लोग रेजिस्टेंस हाइपरटेंशन कह सकते हैं। सपोज हमारा 4-5 कैटेगरी ड्रग है और पेशेंट 3 ले रहा है या 3 से ऊपर हाइपरटेंसिव ड्रग्स ले रहे हैं, then we called as a resistance hypertension. यदि 2-1 है तो we cannot call them as a resistance hypertension. और in among the 3 anti hypertensive drugs में भी मेनली क्या होना चाहिए? कैल्शियम चैनल ब्लॉकर होना चाहिए या रेनिन एंजियोटेंसिन कन्वर्टर एंजाइम और डायरेटिक। मेजर ये 3 एंटी हाइपरटेंसिव ड्रग यदि पेशेंट ले रहा है और बीपी कंट्रोल में नहीं हो रहा है, देन वी कॉल्ड एज ए रेजिस्टेंस हाइपरटेंशन। सो इट इज, अब कब हम बोलेंगे ये रियली जो रेजिस्टेंस हाइपरटेंशन ट्रू इन नेचर है, मतलब हाँ सही में उनको रेजिस्टेंस हाइपरटेंशन कब बोलेंगे? जब हमने ऑलरेडी डेफिनेशन में कहा एटलीस्ट 3 डिफरेंट ब्लड प्रेशर मेडिकेशन वो ले रहा और वो मैक्सिमम डोज पे, जितना पेशेंट को टॉलरेबल है और या डॉक्टर्स ऑर्डर है उससे ज्यादा वो दे नहीं सकते, डॉक्टर प्रेस्क्राइब नहीं कर सकते, तब हम कहते हैं कि पेशेंट इज ऑन रेजिस्टेंस। सो 3 डिफरेंट ब्लड प्रेशर ड्रग्स, जैसे हमने प्रीवियस मेंशन किया, कुछ 3 ब्लड प्रेशर ड्रग्स में से डायरेटिक शुड बी देयर, then only we can call as a registered hypertension. एंड हमें जैसे पता है कि जब भी कोई पेशेंट हाइपरटेंसिव होते हैं हमारे गोल क्या होता है? मिनिमम 140/80 रखना है, उससे ज्यादा नहीं, बिकॉज उसके ज्यादा हो गया तो पेशेंट तो हाइपरटेंसिव है ही। तो हमारी जो गोल है मिनिमम 130/80 होना चाहिए। जब ये 3 कैरेक्टरिस्टिक्स यदि मीट कर रहा है देन वी कॉल हाइपरटेंशन पेशेंट, देन वी कॉल दिस पेशेंट इज ऑन ट्रू रेजिस्टेंस हाइपरटेंशन। आई होप सो रेजिस्टेंस हाइपरटेंशन क्या है इट इज क्लियर फॉर यू। सो हम लोग आते हैं प्रिविलेंस, बिकॉज प्रिविलेंस रेट ऑलरेडी मैंने पहला स्लाइड में भी कहा था कि 1 in 5 पेशेंट्स हैविंग रेजिस्टेंस हाइपरटेंशन। ओके, सो ग्लोबल बर्डन यदि देखा जाए ये नियरली 100 to 500 मिलियन जो है ग्लोबली ये अफेक्टेड है, इतना कॉमन है। और ये कुछ रिसर्च शो किया कि 91 कोवर्ट स्टडी में देखा है कि प्रिविलेंस रेट ऑफ इज नियरली 10% अमंग विद द हाइपरटेंशन पेशेंट, तो बहुत हाई है आपका रेजिस्टेंस हाइपरटेंशन केसेस इन वर्ल्ड ग्लोबली। सो ग्लोबली यदि देखा जाए रेजिस्टेंस हाइपरटेंशन इज ऑब्जर्व्ड नियरली 3 to 30% इन हाइपरटेंसिव पेशेंट। तो आप जस्ट इमेजिन 3% भी हो सकता है और 30% भी हो सकता है, इतना हाई है। तो ये आपके रेजिस्टेंस हाइपरटेंशन केसेस डाटा इंडिया में शो कर रहा है, तो नियरली 11% और 16% हाइपरटेंसिव पेशेंट में ये रेजिस्टेंस हाइपरटेंशन मिलते हैं। तो यदि 234 मिलियन हाइपरटेंसिव पेशेंट में 1 in 3 adults in India, around 23 million are like to have the RH ड्यू टू नॉन RH। अब हम जो बात कर रहे हैं कि रेजिस्टेंस हाइपरटेंशन क्या है, उसमें से मेन जो कारण है रेजिस्टेंस हाइपरटेंशन दैट इज नॉन एडहेरेंस टू द ट्रीटमेंट और थेरापेटिक इनर्शिया, मतलब कि वो पेशेंट जिसको हाइपरटेंसिव ड्रग्स चल रहे हैं वो टाइमिंगली वो ड्रग्स नहीं ले रहे। मेन कॉज ऑफ दिस रेजिस्टेंस हाइपरटेंशन इज दैट। ओके, और ये देखा जाए रजिस्टर हाइपर मोरली किसी का एज एडवांस, यदि आपका एज जितना बढ़ता है नियरली 60+ में रजिस्टर हाइपरटेंशन ज्यादातर मिलते हैं, और इस किसी को क्रॉनिक क्लिनिक डिजीज है या उसको ओबेसिटी है या ऑब्स्टेट्रिक स्लीप एपनिया है, तो इनमें द रेजिस्टेंस हाइपरटेंशन इंसिडेंसेस आर मोर प्रिविलेज्ड है। और आपकी फीमेल में दैट एज तो है ही 60+ प्लस फीमेल में भी ये जो रेजिस्टेंस हाइपरटेंशन केसेस है ज्यादा देखने को मिलता है प्रेवलेंसी। तो ऑल दिस रिस्क फैक्टर्स आर ऑन राइज ग्लोबली, दे आर लाइक टू इंक्रीज द प्रेवलेंस। सो आप जैसे ओबेसिटी हो गई, सीकेडी हो गई, जैसे जैसे बढ़ रहा है तो रेजिस्टेंस हाइपरटेंशन केसेस भी बढ़ रहे हैं। अदर फैक्टर्स क्या क्या हो सकता है, जैसे जेंडर हमने बता ही दिया था, एक्सेस सोडियम इंटेक, यदि आपका जो डाइट ऑलरेडी हमें पता है कि डायबिटिक सॉरी हाइपरटेंसिव पेशेंट में हमें सॉल्ट इंटेक कम करना है, यदि इसमें ज्यादा सॉल्ट इंटेक ले रहे हैं या कोई भी ड्रग्स जैसे एआईडी ग्रुप है, ग्लूकोकॉर्टिकॉइड्स है या अदर ड्रग्स, मेनी ड्रग कैन कंट्रीब्यूट टू इंक्रीज इन हाइपरटेंशन. These all factors may leading to the increase in resistance hypertension globally or in India. So this is all about the little bit prevalence rate और उसकी मैग्नीट्यूड ऑफ प्रॉब्लम इतना हाई कैसा है ये आपको पता चल गया. अब मेनली हम लोग रेजिस्टेंस हाइपरटेंशन भी वेरियस टाइप्स है, जैसे कि आप देख सकते हो स्लाइड में. ट्रू भी हो सकता है, स्यूडो भी हो सकता है और सेकेंडरी भी हो सकता है. द वर्ड्स इज वेरी मच क्लियर. ट्रू मतलब हमने पहले ही कहा था कुछ क्राइटेरिया है, यदि मीट होता है देन वी कॉल ट्रू रेजिस्टेंस हाइपरटेंशन. सूडो मतलब हो भी सकता है ना भी हो सकता है, और सेकेंडरी मतलब कोई कारण से ये आपको रेजिस्टेंस हाइपरटेंशन हो रहा है, देन वी कॉल एज ए रेजिस्ट. बिकॉज हमने कहा रेजिस्टेंस हाइपर किसको कहते हैं, जिसका पेशेंट का 3 से ज्यादा बीपी सॉरी मेडिकेशन ले रहा है और बीपी कंट्रोल नहीं हो रहा है, तो दैट इज कॉल्ड ट्रू, है ना. तो हम लोग डिफाइन दैट इज बीपी मोर देन 140/90 विथ ए मीन ऑफ एम्बुलेटरी बीपी जो होगा 130/80 होना चाहिए. कंफर्म टू बी टेकन 3 एंटी हाइपरटेंसिव मेडिकेशन 3 और मोर. तो हमने ऑलरेडी ये कैरेक्टरिस्टिक्स पहले भी डिफाइन किया था और अभी भी करें, बार बार आप समझिए. देयर शुड बीपी शुड बी मोर देन 140 एंड मेनली पेशेंट शुड बी ऑन मोर देन 3 एंटी हाइपरटेंसिव मेडिकेशन होने से ही हम कंफर्म कर सकते हैं कि दिस पेशेंट इज ऑन ट्रू रेजिस्टेंस हाइपरटेंशन. कभी कभी क्या होता है, सपोज पेशेंट ओपीडी में आया और हमने बीपी चेक कर लिया और उसके बीपी हाई हुआ और हम देख रहे हैं कि पेशेंट मेडिकेशन चल रहा है, आप उसको डायग्नोस नहीं कर सकते ट्रू जब तक ये कंफर्मेटरी ना हो. Now pseudo the word itself very much clear. जब हमें मे बी पेशेंट मे नॉट हैव रेजिस्टेंस हाइपरटेंशन बट हमें उनको डायग्नोस हो जा रहा है एज ए रेजिस्टर हाइपरटेंशन. कब बोलेंगे, जब ड्यू टू पोर कंप्लायंस विद द प्रेस्क्राइब्ड मेडिकेशन. सपोज नाउ पेशेंट को 3 मेडिकेशन लेना था, वो आपको बता रहा है हाँ हम तो तीनों मेडिकेशन ले रहे हैं, बट जब पता चला रियलिटी में शायद पेशेंट 1 या 2 मेडिकेशन ले रहे हैं, देन वी कैन नॉट कॉल दिस पेशेंट इज ऑन रेजिस्टेंस बिकॉज उन्होंने 3 मेडिकेशन टाइमिंगली नहीं लिया है. तो इट इज कॉल्ड पोर कंप्लायंस विद द प्रेस्क्राइब्ड मेडिकेशन. सो ये कंफर्मेटरी होना जरूरी है आपको कंफर्म करने से पहले रेजिस्टर हाइपरटेंशन वेदर द पेशेंट इज टेकिंग 3 और मोर मेडिकेशन. नेक्स्ट इज व्हाइट कोट इफेक्ट. मतलब हॉस्पिटल में पेशेंट आया और आपको जैसे बीपी चेक करने गया, पेशेंट का बीपी शूट अप हो गया, दैट इज नियरली 20 से 10 इतना आपका पेशेंट का हायर हो जाता है. देन ऑल्सो वी कैन नॉट कॉल एज रेजिस्टेंस हाइपरटेंशन. हो सकता है कि पेशेंट को हॉस्पिटल, बहुत सारे पेशेंट होते हैं हमने भी देखा है हॉस्पिटल आते हैं उनकी बीपी बढ़ जाती है बिकॉज दिस इफेक्ट इज कॉल्ड एज ए व्हाइट कोट इफेक्ट. तो आप इनको भी बोल नहीं सकते कि पेशेंट ऐसा रेजिस्टेंस हाइपरटेंशन. तो पेशेंट को पहले काम डाउन करिए, फिर 2-3 बार रीडिंग करिए, उसके बाद भी होता है देन वी कैन कॉल ऑन दैट. सो दिस इफेक्ट ऑल्सो आपको दिमाग में रखना है कि एक पोर कंप्लायंस, वन इज व्हाइट कोट इफेक्ट, देन नियर नॉर्मल बीपी रीडिंग एट होम. सपोज आपने घर पे बीपी चेक किया तो नॉर्मल आ रहा है, लेकिन जैसे आपने हॉस्पिटल में आ गए, आप हेल्थ केयर सेटिंग में आ रहे हो, बीपी बढ़ जा रहा है, देन ऑल्सो वी कॉल एज ए स्यूडो ट्रीटमेंट. सो बहुत सारे फैक्टर्स आपको चेक करना है बिफोर कंफर्मेटरी डायग्नोसिस करने से पहले कि पेशेंट रेजिस्टेंस हाइपरटेंशन है कि नहीं है. तो एक है आपको मेडिकेशन के साथ कंप्लायंस होनी चाहिए, व्हाइट कट इफेक्ट है कि देखना है, या घर पे नॉर्मल है हॉस्पिटल में ऐसा तो नहीं ज्यादा हो रहा है, ये सब आपको देखना है. ओवर दैट इनकरेक्ट टेक्निक्स. ना सब कुछ तो सही है जो कि हम नॉर्मली हम क्लिनिकल साइड में देखते हैं कि बच्चे को स्टूडेंट्स को खुद भी नहीं आता है और लोगों को भी नहीं आता है, नर्सेस प्रॉपरली बीपी चेक नहीं करते या घर पे वो बीपी नहीं चेक कर रहे प्रॉपरली. तो मेनली इनकरेक्ट टेक्निक ऑफ बीपी. इनकरेक्ट क्या हो सकता है, मे बी आपका कफ साइज बहुत छोटा है या बहुत बड़ा है, या आपका जो भी डिजिटल डिवाइस आपने यूज किया वो कैलिब्रेटेड नहीं है. सो दिस ऑल वेरियस फैक्टर्स जिससे वजह से आप इनकरेक्ट टेक्निक हो सकता है. तो मेनी फैक्टर्स जो कि आपका स्यूडो ट्रीटमेंट के लिए या रेजिस्टेंस हाइपरटेंशन को डायग्नोस करने के लिए वी कैन कॉल एज ए स्यूडो रेजिस्टेंस हाइपरटेंशन. तो ये सब पहले आप कंफर्म कर लीजिए. यदि कंफर्मेटरी हो जाता है तभी जाके आपको उसको ट्रू रेजिस्टेंस हाइपरटेंशन कह सकते हैं. ओके, सो कभी कभी स्यूडो रेजिस्टेंस हाइपरटेंशन मिस्टेकन हो जाता है क्योंकि ट्रीटमेंट रेजिस्टेंस, क्योंकि हमें पता नहीं था रियलिटी, तो हम बताते हैं हाँ मे बी देयर इज ए प्रॉब्लम और ट्रीटमेंट सही नहीं हो रहा है, दैट कैन बी दिस. सो नॉन कंप्लायंस इनएडिक्वेट ड्रग थेरेपी रादर देन इनहेरिटेड रेजिस्टेंस टू ट्रीटमेंट. तो कभी कभी हम बोलते हैं कि हाँ भाई मेडिकेशन ले रहे हैं लेकिन नहीं हो रहा है, और ये लास्ट में पता चलता है ये तो स्यूडो था, मतलब प्रॉपरली नहीं था. तो रेजिस्टेंस हाइपरटेंशन जैसे हमने ऑलरेडी 3 फैक्टर्स मैंने बता ही दिया है. आपका मेडिकेशन इन एडहेरेंस है, दैट इज लाइफस्टाइल एडहेरेंस, मेजरमेंट टेक्निक्स, व्हाइट कोट इफेक्ट मैंने ऑलरेडी कहा, मेडिकेशन इंपैक्टिंग ब्लड प्रेशर रेगुलेशन और सिग्निफिकेंट रोल इन दिस apparent treatment of resistance. Now another condition called as apparent treatment resistance hypertension. जैसे हमने pseudo और true कहा, इस तरह apparent भी होता है. It is term used to epidemiological studies to refer in cases in which patients meet the criteria for registered hypertension but unverified. मतलब आप लोग तो बता ही रहे हो कि हाँ पेशेंट तो रेजिस्टेंस हाइपरटेंशन है, बट हम वेरिफिकेशन कोई नहीं कर रहा है कि वेदर पेशेंट हैड अ मेडिकल. सपोज एग्जांपल माई सेल्फ, सपोज मैं हाइपरटेंसिव पेशेंट हूँ और मैं आपको ये बता रही हूँ कि हाँ मैंने मेडिसिन लिया है, बट कंफर्मेटरी नहीं है. हु विल वेरीफाई दैट वेदर मैं 3 मेडिसिन ले रही हूँ नहीं ले रही. सो ऐसे केसेस में हम अपेरेंट कहते हैं. तो अनवेरीफाइड, द कंडीशन इज नॉट वेरीफाइड बाय एनीथिंग कि एडहेरेंस हुआ था या नहीं हुआ था. ठीक है, सो दैट इज कॉल्ड अपेरेंट ट्रीटमेंट रेजिस्टेंस हाइपरटेंशन. नेक्स्ट इज सेकेंडरी. जैसे हमने कहा है जो मैक्सिमम टाइम डिफरेंट बिकॉज ऑफ डिफरेंट अदर कंडीशंस हमें पेशेंट को रेजिस्टेंस हाइपरटेंशन हो जा रहा है, देन वी कॉल रेजिस्टेंस हाइपरटेंशन. सो मेनली जैसे एंडोक्राइन डिजीज हो गई, रिनल आर्टरी स्टेनोसिस हो गया, या प्राइमरी अल्डोस्टेरोन प्रॉब्लम, या ऑब्स्टेट्रिक स्लीप एपनिया डिसऑल्व, या कुछ ड्रग्स है जैसे कि एनएसआईडी ग्रुप ऑफ और मेनी अदर ड्रग्स आल्सो, ये सब में भी लीडिंग टू रेजिस्टेंस हाइपरटेंशन. तो ये हमारी अभी जानकारी रहनी चाहिए कि हमने कौन सी रेजिस्टेंस हाइपरटेंशन को डायग्नोस कर रहे हैं. वेदर हमारी मेन पर्पस होना चाहिए एज ए नर्स की हम प्रॉपरली ट्रू रेजिस्टेंस हाइपरटेंशन को डायग्नोस कर पाए और उसके हिसाब से मैनेजमेंट या ट्रीटमेंट कर सके. सो दैट इज आवर मेजर रोल इन दैट थिंग्स. नाउ व्हाट इज द चैलेंजेस. नाउ आप जैसे कि हमारी टॉपिक ही यही है, चैलेंजेस इन इंडिया. तो चैलेंजेस तो पहले ही हमने कहा कि ड्रग कंप्लायंस, मेनली आप यदि ड्रग सही से नहीं ले रहे हो, दैट इज आवर बिगेस्ट चैलेंज. सो मेनली आप क्या देख सकते हो, nearly 48% and 43% in urban and rural communities or age group is 18 to 49 years are aware of their disease condition despite underlying hypertension. They know. सबसे बड़ा challenges क्या है, मुझे पता है मैं हाइपरटेंसिव पेशेंट हूँ, मुझे पता है मुझे मेडिकेशन टाइमिंगली लेना है, मुझे पता है मुझे सॉल्ट इंटेक कम करना है, सब कुछ आई एम अवेयर, स्टिल मेरा बीपी इज नॉट कंट्रोल. दिस इज द बिगेस्ट चैलेंज इन इंडिया. और द मेजोरिटी इज द पोर्शन यू कैन सी इन अर्बन में तो ज्यादा नॉलेज है देन द रूरल एरिया, तब भी हमारे हाइपरटेंशन कंट्रोल नहीं हो रहा है. सो दिस इज द बिगेस्ट चैलेंज इन इंडिया. वी नो आवर डिजीज कंडीशन, स्टिल वी कैन नॉट कंट्रोल आवर ब्लड प्रेशर. और अदर फैक्टर्स जैसे कास्ट हो गया, रिलीजन हो गया, लिविंग सिचुएशंस, मंथली पर कैपिटा एक्सपेंडिचर हो गया, लोकेशन, फैमिली हिस्ट्री ऑफ हाइपरटेंशन, एम्प्लॉयमेंट स्टेटस, फिजिकल इनएक्टिविटी, अल्कोहल कंजप्शन, दिस ऑल एज ए मेजर फैक्टर्स कम्स आता है एज ए अनकंट्रोल हाइपरटेंशन. लेकिन कास्ट एक्चुअली डायरेक्टली तो नहीं करता, लेकिन कास्ट में क्या होता है आपका रेस्ट्रिक्शन होता है. कोई धर्म आपको बोलता है ये नहीं करना चाहिए, वो नहीं करना चाहिए, मेडिकेशन नहीं खाना चाहिए, अब योगा करिए. तो दिस ऑल बिलीव्स. एक्चुअली मेन जो कास्ट और रिलीजन मेनली आपका बिलीफ को इतना स्ट्रॉन्ग करता है कि वो आपको मेडिकेशन लेने से हैम्पर करती है. लिविंग सिचुएशन, आप कहाँ रहते हो, आपकी सराउंडिंग कैसी है, आप हो सकता है आपका वॉकिंग की फैसिलिटीज नहीं हो, या आपने पोल्यूटेड एरिया में रह रहे हो, दैट कैन कंट्रीब्यूट टू द हाइपरटेंशन. या आपकी इनकम इतना कम है कि आप मेडिकेशन बाय नहीं कर सकते हो, या लिविंग स्टाइल जो चाहिए हमें एक हेल्दी लाइफ स्टाइल वो आप नहीं अफोर्ड कर पा रहे हो. इन दैट वे मे बी आपका मंथली कैपिटल एक्सपेंडिचर में आप इन. When family history, obviously, if you have a family history of hypertension, we know this is genetic in nature, so that cannot be controlled. फिर employment status, ऐसे तो जॉब नहीं आपकी जहाँ पर sedentary lifestyle हो, mainly businessman हो गया और ऑफिस वर्कर, जहाँ पर आपके employment status ही दिखा रहे हैं कि आपको 10 से 12 घंटा आपको सिटिंग ही करना पड़ा एक जगह पे, that can lead to up challenges. Then physical inactivity indirectly affecting. अल्कोहल कंजप्शन, आजकल तो ये न्यू फैशन है कि भाई अल्कोहल लेना स्टेटस सिंबल हो गई. सो दैट इज द बिगेस्ट प्रॉब्लम. So these all various factors, not only beside that many other factors also can contribute as a challenge in India, जो कि हमें सबको पता है कि ये सब नहीं करना है, still we are facing problems. So that is the biggest challenge again in India. Additionally, कुछ रिसर्च शो करता है prolonged hypertension ड्यूरेशन. यदि कोई पेशेंट बहुत दिन तक अफेक्टेड है, बहुत सपोज किसी को 30 इयर्स में 40 इयर्स में हाइपरटेंशन हो गया और ये पेशेंट लाइफ लॉन्ग मतलब 20-25 साल से मेडिकेशन ले रहा है, तो वो भी पेशेंट बिकम फैटिग हो जाता है मेडिसिन लेते लेते. सो दिस इज ऑल्सो एक बिगेस्ट चैलेंज इन इंडिया कि भाई कितना मेडिसिन ले. ओके, देन ओबेसिटी ऑब्वियसली इज फैक्टर इज दैट. स्लीप डिसऑर्डर हो कुछ, या आपका फास्टिंग ब्लड ग्लूकोज, आपको ऑलरेडी पता है हाइपरटेंसिव और आपका डायबिटिक दोनों ही हम मैं तो हर बिलीव करती हूँ कि दोनों कजिन भाई है, एक आया तो दूसरा को लेके आता है. तो मेनली तो आपको ये भी देखना है कि ब्लड ग्लूकोज फास्टिंग जो है ज्यादातर नहीं होना चाहिए. सो दिस ऑल फैक्टर्स ऑल्सो कैन लीड टू increased risk of resistance hypertension. So overall, if you see this slide is saying that we are aware about our hypertension condition, we are aware about our the risk factors, still हम control नहीं कर पा रहे BP, because of that we are leading to resistance hypertension. सो डायग्नोसिस क्या है, नेक्स्ट चैलेंजेस हमारे डायग्नोसिस में आते हैं। मैंने जैसे कहा है आपको, पहले हमने डिस्कस किया था ट्रू रेजिस्टेंस हाइपरटेंशन स्यूडो। यदि आपने प्रॉपरली डायग्नोस नहीं किया तो पेशेंट में हैव ए स्यूडो रेजिस्टेंस, और आपको गलत तरीके से आपने पेशेंट को ट्रीटमेंट दे दी या कुछ है, तो दैट इज द बिगेस्ट चैलेंज। तो आपको स्यूडो रेजिस्टेंस को प्रॉपरली आइडेंटिफाई करके प्रॉपर डायग्नोसिस, ट्रू डायग्नोसिस करना आपका बिगेस्ट चैलेंज है। तो आपको स्यूडो रेजिस्टेंस क्यों होता है, हमने ऑलरेडी ये सब बातें डिस्कस कर चुके हैं। Because of medication non-adherence, improper blood pressure measurement and white coat effect. So these all mainly आपका pseudo resistance है, so आपको mainly ये भी biggest challenge है diagnosis पे। Now come to the therapeutic। आपने suppose diagnose भी कर लिया, ट्रू है, आपने रिस्क फैक्टर्स भी आइडेंटिफाई कर लिया, नॉलेज भी है, लेकिन आप थेरापेटिक मतलब हाउ ट्रीटमेंट में क्या चैलेंजेस आते हैं। फर्स्ट इज लिमिटेड ट्रीटमेंट ऑप्शन। नाउ हम जितना भी बोल देते हैं रूरल एरिया में क्या होता है, ट्रीटमेंट अफोर्डेबल नहीं होता है, पेशेंट अफोर्ड नहीं कर सकता, हॉस्पिटल नहीं जा सकता, तो मेनली आपका लिमिटेड ट्रीटमेंट ऑप्शन होता है। मेडिकेशन साइड इफेक्ट, कभी कभी क्या होता है, पेशेंट खुद ही कुछ साइड इफेक्ट होता है, पेशेंट खुद ही पेशेंट मेडिसिन बंद कर देता है। तो अब जब मल्टीपल ड्रग रेजिमेंट चल रहा है तो पेशेंट में हैव ए मेजर साइड इफेक्ट्स। For that, maybe patient may stop the medicine or may not go to hospital for the follow-up. Anything can happen. So that is the biggest side effect. Then complexity. अब just imagine patient 3 मेडिसिन ले रहा है और रेजिस्टेंस हाइपरटेंशन हो गया था और आपने ऐड कर दी, मे बी अब अदर कॉम्प्लिकेशन के लिए किसी किडनी डिजीज उसके लिए मेडिसिन ले रहे हैं। तो ये जो कॉम्प्लेक्सिटी है, बहुत सारी मेडिसिन पेशेंट को दे रहे हो, समझा रहे हो भाई ये आपको ये पेशेंट लेना है, ये पेशेंट लेना है। सो दिस कॉम्प्लेक्सिटी ऑल्सो बिकम द बिगेस्ट चैलेंज इन थेराप्यूटिक। एंड ऑब्वियसली मेजर प्रॉब्लम इज कॉस्ट ऑफ मेडिकेशन। यदि आपने हॉस्पिटल जाके गवर्नमेंट हॉस्पिटल में या प्राइमरी हेल्थ सेंटर से नहीं ले रहे हो, प्राइवेटली आप खरीद रहे हो, तो कॉस्ट ऑफ मेडिकेशन बिकॉज हायर और पेशेंट कैन नॉट अफोर्ड। ओके, इवन द प्राइमरी हेल्थ सेंटर में हॉस्पिटल से मिल रहे, स्टिल द मेडिकेशन कॉस्ट फॉर पुअर पीपल इट इज वेरी मच टफ है। सो दिस ऑल वेरियस फैक्टर्स इट कैन चैलेंज टू अस फॉर थेरापेटिक मैनेजमेंट ऑफ पेशेंट विद रेजिस्टेंस हाइपरटेंशन। मेडिकेशन नॉन अडहेरेंस इज हाईली, मैंने आप जैसे कहा थेरापेटिक चैलेंजेस में बिगेस्ट प्रॉब्लम हो गया नॉन अडहेरेंस, बिकॉज पेशेंट मेनली जो इतना लॉन्ग टर्म पेशेंट को मेडिसिन लेना है वो दे कैन नॉट एक्सेप्ट। एंड सबसे बड़ा मेजर चैलेंज हमारी की उनको नॉन अडहेरेंस हो। तो हमारी मेन फोकस होना चाहिए कि पेशेंट को ये समझाना कि भाई मेडिकेशन टाइम पे लेना ही बहुत बड़ी बात है। सो इट इज एस्टिमेटेड दैट नियरली 50 to 80% हाइपरटेंसिव पेशेंट जो है प्रेस्क्राइब है वो नहीं लेते सब ऑप्टिमल एडवांस। अब इमेजिन 100 पेशेंट में से 80 पेशेंट जो है वो आपका मेडिसिन टाइम पे नहीं ले रहे, मतलब सब ऑप्टिमल एडहेरेंस, मतलब जितना चाहिए था उतना वो एडहेरेंस नहीं है। सो दिस इज द बिगेस्ट चैलेंज जो पेशेंट को फेस हो रही है। सो देयर इज, तो आप ऐसे भी बोल भी नहीं सकते देयर इज नो गोल्ड स्टैंडर्ड कि भाई आप कैसे, मैंने जैसे कहा, मैं मुझे आप पूछोगे कि आप मेडिसिन ले रहे हो 3, मैं बोलूंगा हाँ ले रहा हूँ, लेकिन आपके पास कोई गोल्ड स्टैंडर्ड टेक्निक नहीं है ये चेक करने के लिए वेदर आई एम अडहेर टू द मेडिसिन और नॉट। सो देयर इज नो स्टैंडर्ड ऑफ दैट, दैट इज अनदर चैलेंज है जो हमें एज ए नर्स आइडेंटिफाई करना है कि भाई कैसे हम देखें कि पेशेंट टाइम पे मेडिसिन ले रहा है। तो इनडायरेक्ट मेथड क्या हो सकता है, हम यदि गोल्ड स्टैंडर्ड नहीं है तो कुछ तो एज ए नर्स हमें टेक्निक निकालनी पड़ेगी। तो हम यही कर सकते हैं कि भाई पिल काउंट चेक कर लो कि महीने में आपको 30 मेडिसिन लेना था, वेदर आपने 30 में से 30 लिया है कि नहीं। या सेल्फ रिपोर्ट, यही एक चीज रहेगा कि पेशेंट जितना बोलेगा उसमें आपको ऑब्जर्व करना पड़ेगा। या प्रेस्क्रिप्शन रिफिल डाटा, यदि पेशेंट बार बार आपका फॉलोअप में आ रहा है, वो आपका मेडिसिन ले रहा है, आपसे ऑर्डर करवा रहा है या खरीद रहा है, देन वी कैन गो फॉर दैट। हाँ हो सकता है पेशेंट अडहेरेंस कर रहा है इन एक्सपेंस वाइडली। तो आपका ये 3 चीज हो सकता है इनडायरेक्टली आप यूज कर सकते हो टू ओवरकम दिस चैलेंज ऑफ मेडिकेशन नॉन अडहेरेंस। सो ये आप पे एज ए नर्स आप पे डिपेंड करता है कि आप कौन सी मेथड ऑब्जर्व करोगे, सो दैट हम जो 80% पेशेंट नहीं ले रहे मेडिसिन उनको हम लेने के लिए बाध्य कर सके या उनको कंपल्शन कर सके। सो ये हमारी नर्सिंग की पॉइंट ऑफ व्यू होना चाहिए। सो दिस इज द बिगेस्ट चैलेंज जो हमें ओवरकम करना है। ना व्हाट इज द इम्पोर्टेंस ना पेशेंट को, क्योंकि हमें मेनली हमने पूरी ये में डिस्कस किया कि मेनली रेजिस्टेंस हाइपरटेंशन पेशेंट इसलिए डेवलप होते हैं क्योंकि वो नॉन अडहेरेंस होते हैं ट्रीटमेंट में। तो हमारी क्या इंपॉर्टेंस है कंप्लायंस के लिए, पिल बर्डन। बिकॉज यदि जब पेशेंट को बहुत सारे, मैंने कहा ना 3 मेडिसिन लेना है, डेली लेना है, दिन में भी 2 बार 3 बार लेना है, तो दिस इज द पिल बर्डन बिकम द बिगेस्ट प्रॉब्लम विद द नॉन कंप्लायंस। सो आपको ये ध्यान रखना है कि आप रेजिस्टेंस हाइपरटेंशन होने के रीजन मेन है पिल बर्डन। तो एक्सपर्ट जो स्टेट करते हैं ना, पेशेंट शुड 80% जो है आपका ड्रग रेजिमेन में लेना चाहिए। 60% जो रेजिस्टेंस हाइपरटेंशन पेशेंट है वो नॉन कंप्लायंट रहते हैं। और रीजन फॉर द, मैंने बोला एक, अब यदि पेशेंट का पूछे कि क्यों नहीं ले रहे हो भाई, आप मेडिसिन 3 लेना था, तो वो क्या बताएंगे, रीजन ऐसे बताते हैं जैसे कि आप फॉरगेटफुल, मैं भूल गया, ठीक है, मेजर प्रॉब्लम है यदि आप पेशेंट से इंटरेक्ट करो, आप ये सुन पाओगे, देख पाओगे, पेशेंट रियली बताएगा कि ये दे आर फॉरगेट टू टेक द मेडिसिन। फिर साइड इफेक्ट, कुछ पेशेंट बताएगा नहीं मुझे सर चक्कर आ रहा है, मुझे बहुत वीकनेस आता है, मुझे साइड इफेक्ट होते हैं, वो इसलिए बंद कर दिया। कोई ये बोल सकता है कि आपकी मेडिकेशन इतनी कॉस्टली है कि मैं खरीद नहीं पाया या मैं अफोर्ड नहीं कर पाता हूँ। कभी कभी क्या बोलता है, मुझे पता ही नहीं था कि इतना इंपॉर्टेंस था ये इतना मेडिसिन लेना, मुझे लगा एक गोली से हो जाता है इसलिए मैंने नहीं लिया। तो मेनली वो आपको ये बताएंगे कि उनके अंडरस्टैंडिंग नहीं था कि उनको बीपी की जो मेडिसिन थी वो टाइमिंग पे लेना था और उसकी इंपॉर्टेंस। फिर डिफिकल्टी, और कोई ये आपको बताएगा कि बहुत मुश्किल है मेरे लिए कि डेली याद करके दिन के 3 मेडिसिन या 4 मेडिसिन लेना। सो दिस ऑल डिफरेंट रीजंस पेशेंट में से एज ए रीजन फॉर द नॉन कंप्लायंस विद द ट्रीटमेंट रेजिमेंट्स। ठीक है, तो ये हमारा एज ए नर्स ये ध्यान रखना है कि इसको हम कैसे ओवरकम करें, ये हमारा पर्पस होना चाहिए। तो क्या तो अब बिकॉज हमने कहा आपको ये सब प्रॉब्लम्स पेशेंट बता रहे हैं, हम छोड़ नहीं सकते, यदि छोड़ दिया पेशेंट विल डेवलप द रेजिस्टेंस हाइपरटेंशन। तो हमारा मेन होगा जो भी नॉन कंप्लायंस है उसको एड्रेस करना। तो क्या क्या अप्रोच हम कर सकते हैं, जैसे कि एजुकेटिंग। सबसे पहले तो पेशेंट को जब भी कोई मेडिसिन दे, ये तो नर्सिंग की रेस्पॉन्सिबिलिटी मेजर है, हम कोई भी मेडिसिन दे उनको ये समझाना जरूरी है ये मेडिसिन उनको क्यों लेना है, नहीं लेने से क्या होगा और लेने से क्या होगा। तो मेनली आपको एजुकेट पेशेंट को इंपॉर्टेंस की बताना है ट्रीटमेंट का। और बीपी मेडिकेशन तो बताना ही है भाई, बहुत बार मैंने सुना है, आज सुबह ही हमारी बात हो रही थी किसी कोलीग से, वो भी बता रहे थे कि उनके कोई रिलेटिव है वो मेडिसिन बंद कर दे, रीजन ये है कि बीपी उनकी नॉर्मल हो गई। तो मैं उनको भी यही समझा रही थी भाई उनको सिखाना ये जरूरी है कि बीपी नॉर्मल होता है तब भी आपको मेडिसिन कंटिन्यू करना है, अपने हिसाब से बंद नहीं करना है। तो ये आपको एजुकेट करना पेशेंट को बहुत ही जरूरी है कि ट्रीटमेंट रेजिमेंट जो है कितनी इंपॉर्टेंट है टू प्रिवेंट आपकी रेजिस्टेंस हाइपरटेंशन। क्योंकि एक बार रेजिस्टेंस हाइपरटेंशन हो गया तो जितना भी मेडिकेशन लीजिए वो काम नहीं आएगा। और उसकी साइड इफेक्ट भी पहले से बता दीजिए, ऐसा ना हो कि नहीं तो आपके बिना जानकारी वो अपना दवाई बंद कर दे। तो पेशेंट को अब उसकी पोटेंशियल साइड इफेक्ट एवरी ड्रग का, यदि पेशेंट 3 ड्रग ले रहा है, 3 ड्रग का जो मेजर साइड इफेक्ट्स है वो उनको पहले से समझा दें कि आपको ऐसे ऐसे प्रॉब्लम्स आएंगी, पर तब भी आपको मेडिसिन कंटिन्यू करना है, या आपको डॉक्टर्स को सब बार बार कॉन्टेक्ट करना है, ये आपको एजुकेट करना है। फिर रेजिमेंट्स को सिंप्लीफाई करिए। सपोज 3 मेडिसिन पेशेंट ले रहा है या 4 मेडिसिन ले रहा है, या आपकी एज ए नर्स रिस्पॉन्सिबिलिटी होगी उसको सिंप्लीफाई कैसे करें। सपोज जैसे पेशेंट को पहले पूछे कि भाई आपको एट ए टाइम मेडिसिन खाना अच्छा लगेगा कि दिन में मेडिसिन को 3 भाग में डिवाइड कर दिया जाए। जो पेशेंट कंफर्टेबल स्टेज हो, यदि पेशेंट बोलता है नहीं मुझे एक के साथ मेडिसिन दे दीजिए, यदि पेशेंट को एडवाइस कर सकते हैं तब यू कैन डू। मतलब मेन पर्पस से आप सिंप्लीफाई करें कि पेशेंट कब याद रख सकता है। सबसे बेस्ट है मेडिसिन यदि आपको सिंप्लीफाई करना है, पेशेंट के डाइनिंग टेबल या जहां पर वो खाना खाते हैं वहीं पर मेडिसिन रखना चाहिए। इससे क्या होता है पेशेंट भूलता नहीं है कि कैसे लेना है। और रेजिमेंट को डिवाइड कर दीजिए दिन में 2 बार या 3 बार या 1 टाइम एज पर द पेशेंट कन्वीनियंस। देन फाइनेंशियल असिस्टेंस, दिस इज द बिगेस्ट प्रॉब्लम। सी ये तो मैं नहीं बोलूंगी कि एज ए नर्स हम जाके उनको फाइनेंशियल असिस्टेंस दे दे, लेकिन हाँ हम इनको ये सजेस्ट कर सकते हैं दे कैन गो टू द प्राइमरी हेल्थ सेंटर, दे कैन गो टू द गवर्नमेंट सेक्टर्स। नाउडेज आपको पता है प्रधानमंत्री योजना का भी आ चुका है, वो उसमें भी बहुत चिप, ये एक सबसे बड़ा मेजर लोगों का दिमाग में बैठा है कि प्रधानमंत्री जो मेडिसिन देते हैं जो दुकान है वो उसकी मेडिसिन इफेक्टिव नहीं है। ये कॉन्सेप्ट भी निकालना जरूरी है कि दिस इज ऑल सेम मेडिकेशन इज गिवन विद द फार्माकोलॉजिकल नेम। तो हमें डिफरेंट फाइनेंशियल असिस्टेंस का डिफरेंट मेथड उनको अप्रोच को देना है कि पेशेंट को जो कन्वीनियंट है वो एटलीस्ट ही कैन और शी कैन गो एंड अप्रोच। सो ये इशू होना नहीं चाहिए कि पैसे की वजह से हमने मेडिसिन नहीं लिया। फिर ऑल्टरनेटिव फॉर द एक्सपेंसिव मेडिकेशन, ऑलरेडी मैंने कहा है ऑल्टरनेटिव क्या है आपका। तो आजकल सबको सजेस्ट किया जा रहा है कि आप इन एक्सपेंसिव मेडिसिन मत लीजिए, आप हरदम ड्रग रेजिमेंट जो भी लिखा है थेरापेटिक मेडिसिन उसी के हिसाब से लीजिए। फिर ऑफरिंग रिमाइंडर सिस्टम, जैसे अलार्म हो गया, पिल ऑर्गेनाइजर्स है, मेनली अलार्म्स मेनली यदि नहीं कर पाते पिल ऑर्गेनाइजर बहुत जरूरी है। बिकॉज आपका एक बॉक्स आती है जिसमें मंडे टू सैटरडे डब्बे लिखा रहता है और आपको मेडिसिन पहले से वीकेंड में क्या करना रहता है पता है, मंडे से सैटरडे तक डब्बे में ड्रग्स को रख दिया जाता है और पेशेंट को समझा दिया जाता है देखिए मंडे का मेडिसिन है, ट्यूसडे का मेडिसिन है और वेडनेसडे का मेडिसिन है। और यदि ऑर्गेनाइजर चाहिए तो मंडे का भी मॉर्निंग एक डब्बा होना चाहिए, इवनिंग एक होना चाहिए, नाइट होना चाहिए। तो इस तरह डिफरेंट ऑर्गेनाइजर होगा तो पेशेंट वेरी इजीली कैन अंडरस्टैंड। यदि सपोज मॉर्निंग में मेडिसिन भूल गया तो एटलीस्ट सेकंड हाफ में जब खाएगा तो पता चल जाएगा, तो मॉर्निंग के मेडिसिन भी ले सकता है। इस तरह डिफरेंट रिमाइंडर सिस्टम्स आप बना सकते हो जिससे कि पेशेंट कंप्लायंस में बिलीव कर सकता है कि कल ये नहीं बोल सकता कि कोई मतलब आप भी कोई लूप होल ना छोड़े जिससे पेशेंट ये एक्सक्यूज दे कि मैंने ये रीजन से नहीं लिया। तो आपको भी सब एस्पेक्ट को ध्यान रख के उसको ऑर्गेनाइज करना है। फिर फैमिली मेंबर्स बहुत ही जरूरी है, बिकॉज पेशेंट तो सही में टायर्ड हो गया होगा पिल लेते लेते, तो आप फैमिली मेंबर्स को इन्वॉल्व करें और उनको रिमाइंडर दे कि भैया आप याद दिलाइए कि पेशेंट को मेडिसिन लेना है रेगुलर। फिर असेसिंग करिए आप, यदि आपने एज ए नर्स हो या कम्युनिटी हेल्थ नर्स हो, आप फैमिली विजिट करते हो या पेशेंट हॉस्पिटल में आता है, आपको रेगुलरली उनको असेस करना है और एड्रेस करना है बैरियर। यदि तब भी मतलब आपने इतना सारा आइडिया देने के बाद भी वो कुछ अडेरेंस का कुछ नया कुछ रीजन बता रहे हैं, तो आपको ये देखना है कि अडेरेंस के लिए उसके लिए भी रास्ता आप निकाल के पेशेंट के लिए दे, सो दैट यू कैन हैव ए ओपन कम्युनिकेशन। सो ये सब फैक्टर्स है जो आपको चैलेंजेस तो आती है और हमें चैलेंजेस को ओवरकम इस तरह टेक्निक लेके आपको कर सकते हैं, जिससे हम रेजिस्टेंस हाइपरटेंशन को प्रिवेंट कर सकते हैं ना। चैलेंजेस माने जो नॉन स्पेशलिस्ट ना, सपोज जैसे हमने कहा कि कभी कभी क्या होता है, आपका जरूरी नहीं ना आप बड़े हॉस्पिटल में काम कर रहे हो या टर्शियरी केयर हॉस्पिटल पहुंच सकते हैं, हो सकता है आप सिर्फ ऐसे लेवल पे हो जहाँ पर बड़े स्पेशलिटी सेटिंग नहीं है, तो उसमें क्या चैलेंजेस आते हैं, मेनली आपका मॉडिफाइड जो कॉज है उसमें आ गए, जैसे कि आपकी इंडिपेंडेंस रजिस्टर इंक्लूडिंग जैसे ओबेसिटी हो गई, डायट्री सॉल्ट इंटेक हो गया, लो फिजिकल एक्टिविटी हुआ, अल्कोहल इंटेक है, ये सब आपकी नॉन मतलब आपको हॉस्पिटल जरूरत नहीं है, घर के मैनेजमेंट में भी आप कर सकते हो, तो लाइफस्टाइल मेडिकेशन में आप एडहेरेंस नहीं हो। सो ये सब बिगेस्ट चैलेंजेस है जो कि आपकी रेजिस्टेंस हाइपरटेंशन डेवलप के लिए सेकेंडरी फैक्टर है। तो उसको हम कैसे ओवरकम करेंगे, जैसे ओबेसिटी हो गई, इसके लिए आपको कोई क्लिनिकल सेटिंग जाने की जरूरत नहीं, स्पेशल सेटिंग जाने की जरूरत नहीं, मुझे पता है बीएमआई कैलकुलेशन बताइए उनको, ओवरवेट कितना होता है समझाइए, और आपका या पेशेंट खुद ओबेसिटी कंट्रोल कर सकता है। तो यस, इंडिपेंडेंटली एसोसिएटेड, यदि कोई पेशेंट रेजिस्टेंस हाइपरटेंशन है तो आप देखेंगे नील 50% पॉपुलेशन ऑफ दैट पेशेंट विल हैव ए ओबेस, तो हमारी इतनी ज्यादा मेजर फैक्टर है ओबेसिटी। सो ये कुछ न्यूट्रिशन एग्जाम में सर्वे दिखाया कि बीएमआई यदि मोर देन 30 होता है, देन हमें रिस्क ऑफ हाइपरटेंशन जो रेजिस्टेंस हाइपरटेंशन इज मोर डबल हो जाता है। तो आप जस्ट इमेजिन, तो हमें हरदम ये पेशेंट को देखना है कि उसकी बीएमआई 22 to 25 मेंटेन रखना चाहिए। सो पेशेंट को ये समझाइए आपको क्या इंपॉर्टेंस है बीएमआई का मेंटेनेंस, और ओबेसिटी कैसे कम करना है, उसकी स्ट्रेटेजीज क्या है। सबसे बेस्ट और चीपेस्ट मेथड इज वॉकिंग, तो पेशेंट को एनकरेज करिए। पेशेंट बहुत बहाना मारेंगे, हम योगा नहीं जा सकते, हम एक्सरसाइज नहीं कर सकते, हमारे पास पैसा नहीं है, तो उनको सबसे सिंपल जस्ट मेथड बताइए कि भाई वॉकिंग इज द बेस्ट और चीपेस्ट मेथड ऑफ वेट लॉस मेथड, तो आप इनको समझाइए। तो वेट लॉस स्ट्रेटेजीज शुड बी वेरी मच कंबाइंड, तो कैलोरी फैट एंड कार्बोहाइड्रेट रिस्ट्रिक्शन सबको पता है, पहले तो फाइंड आउट करिए उनकी डाइटरी पैटर्न क्या है, यदि पेशेंट कितना खाने में कितना कैलोरी रहता है, कितना फैट, तो आपको जहां पर लगता है कट ऑफ करना चाहिए कट ऑफ करिए, एंड विद द इंक्रीज एक्सरसाइज। तो स्लोली स्लोली, जैसे एक्सरसाइज पेशेंट बोलेगा मैं चल नहीं पाता, मुझे पता नहीं, तो पेशेंट को बोलिए ग्रेजुअली इंक्रीज करे, जैसे 10 के पहले 10 मिनट चल ले, फिर 15 मिनट चल ले, फिर आधा घंटा चल ले। सपोज आधा घंटा एट ए टाइम नहीं कर सकते, तो आधा घंटे को पूरा दिन में ब्रेक कर ले। मतलब यू कैन हैव ए मेनी स्ट्रेटेजीज फॉर वेट लॉस थिंग्स। आप मतलब कोई एक्सक्यूज या लूप होल ना छोड़े कि पेशेंट ये बता रहा है तो भाई हमने छोड़ दिया, नहीं, एज ए नर्स हमें उनका ऑल्टरनेटिव मेथड देना है कि क्या कर सकते हैं। तो यदि ओवरऑल यदि आपने पेशेंट को ये समझा पाए कि आपकी बॉडी वेट से यदि 6 to 8% आपने बॉडी वेट कम कर ली, तो आप सोचो सिस्टोलिक और डायस्टोलिक बीपी में 5 मिलीमीटर ऑफ मर्क्यूरी कम कर सकते हो, तो इतना अच्छा है। तो आप यदि लॉन्ग टर्म करोगे ऑब्वियसली आपकी बॉडी वेट भी रिड्यूस होगा और बीपी भी आपका कम हो सकता है। सो दिस इज द वे ओबेसिटी जो चैलेंज है बड़ी सी, और पेशेंट एक्सरसाइज नहीं कर सकते, हम लोग इसको कम कर सकते हैं। डायट्री सॉल्ट, इट इज द मेजर प्रॉब्लम विद द डायट्री सॉल्ट इंटेक। सबको पता है, हमें पता रहता है कि हम हाइपरटेंसिव है, हमें सॉल्ट नहीं खाना चाहिए, तब भी हम खाते हैं, ठीक है। तो मेनली बहुत स्टडीज शो किया जो आपका रेजिस्टेंस हाइपरटेंशन पेशेंट में एक्सेसिव सॉल्ट इंटेक इज द मेजर प्रिवेलेंस रेट रिस्क फैक्टर है जो आपके पेशेंट को रेजिस्टेंस हाइपरटेंशन डेवलप करवाती है। सो सॉल्ट सेंसिटिविटी से वेरी बहुत ही कॉमन है पेशेंट का बीपी बढ़ने के रीजन। तो आपको क्या करना है, पेशेंट को मेनली समझाना है कि भाई ये 5 से 6 ग्राम पर डे मतलब सॉल्ट इंटेक इतना कम होना चाहिए। यूजुअली यदि आइडियली देखा जाए कोई भी हाइपरटेंसिव पेशेंट का नॉर्मल पेशेंट के साथ खाना नहीं पकता है, आपको सॉल्ट डालने से पहले खाने को निकाल देना चाहिए और पेशेंट बाकी लोगों के लिए खाना पकना चाहिए, और पेशेंट को जितना एडवाइस है दैट इज 5 to, वो अपना टेबल सॉल्ट में रखे और उसी सॉल्ट को पूरा दिन में डिवाइड करे। ये एक्चुअली आइडियली मेथड होता है डायट्री सॉल्ट इंटेक फॉर द हाइपरटेंसिव पेशेंट। लेकिन आपको पता है कितने लोग कर पाते हैं, दैट इज द बिगेस्ट प्रॉब्लम। तो हमें लेकिन एजुकेट तो करना पड़ेगा, हमारा रोल है, और एनकरेज करना है सो दैट पेशेंट इस तरह सॉल्ट इंटेक घर पे ले। और इसके लिए फैमिली सपोर्ट की बहुत ही जरूरत है कि खाना बनाने जब सॉल्ट डाले उससे पहले वो पेशेंट के लिए निकाल लें, देन ओनली वी कैन मैनेज द डायरेक्टरी सॉल्ट। तो कुछ मेटा एनालिसिस शो करता है यदि पेशेंट एंटी हाइपरटेंसिव थेरेपी में रहता है और आपने सॉल्ट इंटेक को 3 ग्राम कर दिया, नॉर्मली तो 5 से 6 ग्राम चाहिए ही बीपी पेशेंट के लिए, लेकिन आपने यदि 3 ग्राम कर लिया तो बीपी देखिए कितना कम हो जाता है, नियरली 3.5 मिलीमीटर मर्क्यूरी डिक्रीज हो जाता है। तो आपने वेरी नाइसली यदि वेट भी कम कर लिया तो आपके रेजिस्टेंस हाइपरटेंशन बच गए। सॉल्ट इंटेक यदि आपने 3 ग्राम कर दिया, आपने आपको मतलब आप मतलब पेशेंट को यदि समझा पाए इतना इंपॉर्टेंस है डायरेक्टरी सॉल्ट रेस्ट्रिक्शन का, तो आप बीपी देखिए कितना अच्छा से आप कम कर सकते हो। सो दिस इज अनदर मेजर फैक्टर और चैलेंजेस जो कि आप ओवरकम कर सकते हो विद प्रॉपर एजुकेशन। नाउ डाइट, आप बहुत कॉमनली सुने होगा, आपका डैश डाइट है, डाइटरी अप्रोच टू स्टॉप द हाइपरटेंशन। ये मेनली डैश डाइट में मेन ध्यान जाता है कि प्रोटीन्स, जो प्रोटीन होंगे वो लीन होनी चाहिए, होल ग्रेन, वेजिटेबल्स, फ्रूट्स एंड लो फैट डाइटरी प्रोडक्ट्स, इस पे ध्यान देखा जाता है डैश डाइट। बट अभी जैसे बीपी डैश डाइट बोला जाता है कि बीपी आपका 11.6% रिड्यूस करता है सिस्टोलिक और आपकी 5.3 में नॉर्मल टेंशन में रहता है, लेकिन प्रूफ नहीं है, कोई आरसीटी ऐसे कोई प्रूफ नहीं दिखाती है कि भाई डैश डाइट एलोन कैन रिड्यूस। जैसे आपने सॉल्ट इंटेक में देखा और ओबेसिटी में देखा कि इतना आपने वेट कम कर लिया तो आपकी बीपी इतना कम हो जाएगा, या सॉल्ट इतना 3 ग्राम ले लिया तो बीपी कम हो जाएगा। बट डैश डाइट पे ऐसे कोई भी रैंडम कंट्रोल ट्रायल नहीं हुआ है जो आपको ये स्पेसिफाई एलोन कर दे कि भाई डैश डाइट से आपका रेजिस्टेंस हाइपरटेंशन कम हो जाएगा। लेकिन हाँ, डैश डाइट आल्सो हैज ए मेजर रोल इन रिड्यूसिंग द ब्लड प्रेशर। नाउ जैसे हमने मेजर कॉज रिस्क फैक्टर डिस्कस किया था, फिजिकल इनएक्टिविटी, दिस इज द मेजर फैक्टर आज के टाइम पे, चाहे रूरल हो या अर्बन पीपल हो, हमारी इनएक्टिविटी बहुत कम हो गई है, तो लोगों को बहुत ज्यादा समझाना जरूरी है कि फिजिकल एक्टिविटी कितनी इंपॉर्टेंट है। तो दैट इज बहुत सारी रिसर्च शो करती है फिजिकल इनएक्टिविटी और रेजिस्टेंस हाइपरटेंशन आर लिमिटेड, प्रिवेलेंस ऑफ सेल्फ रिपोर्टेड फिजिकल इनएक्टिविटी इज हाई पीपल विद दिस। यदि आप पेशेंट को समझे, ऐसे रिसर्च शो कर रहा है कि कोई लिमिटेशन नहीं है, लेकिन आप यदि पेशेंट से पूछे तो पेशेंट मैक्सिमम टाइम डाटा दिखाएगा कि जो पेशेंट बता रहे कि हम फिजिकल इनएक्टिविटी है उनमें रेजिस्टेंस हाइपरटेंशन इतना ज्यादा है, नियरली 40% है। सो गुड एविडेंस सपोर्टिंग दैट यदि आपने एक्सरसाइज थेरेपी करते हैं हाइपरटेंशन पेशेंट के लिए, और बहुत सारी स्टडीज सपोर्ट करती है कि आपने यदि एक्सरसाइज करते हो तो आपका रेजिस्टेंस हाइपरटेंशन जो है वो रिड्यूस हो सकता है या हम प्रिवेंट कर सकते हैं। सो दिस इज द फिजिकल Now, alcohol, जैसे मैंने कहा है, this nowadays become, this is the factor become the alcohol intake। तो बहुत सारी आपकी आरसीटी दिखाया है कि अल्कोहल कंजप्शन यदि लेते हो तो बीपी बढ़ेगा, इसके लिए कोई मतलब प्रूव्ड है, मतलब आरसीटी मतलब इट इज ऑलरेडी रैंडम कंट्रोल ट्रायल हो चुके हैं और ये प्रूव्ड है, यदि आपने अल्कोहल कंजप्शन करोगे बीपी बढ़ेगा ही बढ़ेगा। तो हमारे मेन पर्पज जो दिखा जा रहा है, नियरली वन थर्ड ऑफ द पॉपुलेशन विद रेजिस्टेंस हाइपरटेंशन हैव ए हिस्ट्री ऑफ एक्सेस अल्कोहल इंटेक या जो अल्कोहल ले रहे हैं। तो हमारी मेन पर्पस होनी चाहिए कि पेशेंट को ये समझाना कि हाइपरटेंशन स्टॉप, नॉट लिमिट, ट्राई टू स्टॉप द अल्कोहल, देन ओनली आप रेजिस्टेंस हाइपरटेंशन को प्रिवेंट कर सकते हैं या हम इस चैलेंज को ओवरकम कर सकते हैं। नाउ सेकेंडरी कॉज, हमने ऑलरेडी डिफरेंट फैक्टर्स पे हमने डिस्कस की थी। सेकेंडरी कॉज, यस सेकेंडरी कॉज, बिकॉज सेकेंडरी कॉज को आप कंट्रोल नहीं कर सकते, ये डिफरेंट बीमारियां होती है। तो हमारी मेन पर्पस होगा कि जो सेकेंडरी कंडीशंस है उसको इन टाइम डायग्नोसिस करें और प्रॉपरली उसको ट्रीटमेंट टाइम पे लिए करें, यही चीज यदि कर सकते हो तो सेकेंडरी कॉज ऑफ हाइपरटेंशन कैन बी स्टॉप फॉर द रेजिस्टेंस हाइपरटेंशन। तो चैलेंजेस क्या है, तो कंट्रोलिंग रेजिस्टेंस हाइपर, ऑलरेडी हमने बहुत सारी फैक्टर डिस्कस किए हैं क्या क्या चैलेंजेस है। तो ओवरऑल यदि देखा जाए, मेनली आपका क्लिनिकल कंडीशन प्रॉपरली आइडेंटिफाई करना ही हमारा मेजर फैक्टर्स है। पेशेंट को अवेयरनेस करना है, आपको जो चैलेंजेस जो भी आप रजिस्टर से पेशेंट को अवेयर करना है, पेशेंट से इंटरेक्ट करना है, हेल्थ टीम के साथ इंटरेक्ट करना है, फार्माकोलॉजिकल जो ट्रीटमेंट है, सिलेक्शन है, ये प्रॉपर होनी चाहिए। नॉन फार्माकोलॉजिकल ट्रीटमेंट जैसे अभी हमने कहा एक्सरसाइज और अदर थिंग्स, गुड ट्रीटमेंट एडहेरेंस होना चाहिए और बीपी को कंट्रोल रिडक्शन करना है सो दैट मोर्टालिटी मोर्बिडिटी कैन बी कंट्रोल। ये सब चैलेंजेस है जो हमने बात की और इसको आप यदि मेंटेन कर पा रहे हो देन यू कैन कंट्रोल द रेजिस्टेंस हाइपरटेंशन। तो ओवरऑल आई कैन कम टू द कंक्लूजन इज सेइंग दैट, क्योंकि यदि कोई पेशेंट को बीपी हुआ है या हाइपरटेंशन है तो पेशेंट को ये समझाना बहुत जरूरी है कि भाई आपको इसी के साथ ही जीना है। बीपी ऐसा कोई बीमारी नहीं कि वो कम हो जाएगा, आपको इसके साथ जीना है और एवरी डे एंड एवरी टाइम आपको जीना है, ये पेशेंट को एक्सेप्ट करवाना बहुत ही जरूरत है। ठीक है, तो उसके लिए उनको ये बताना जरूरी है, क्योंकि हमें अभी इसके साथ जैसे हम बोलते हैं नॉर्मली, हम जब जब जीना है तो हमें खाना है, हमें सोना है, हमें एक्सरसाइज करना है, सेम चीज उनको समझाना है कि आपको हाइपरटेंशन का जीना है तो मेडिसिन आपको रेगुलर टाइम पे लेना है, राइट टाइम पे लेना है, राइट डोज पे लेना ही है। ऐसा नहीं कोई एक दिन के मैटर है। सॉल्ट इंटेक, क्योंकि हमें जीना है बीपी के साथ, तो हमारी बीपी, हमें ये मानना भी जरूरी है कि सॉल्ट इंटेक हमें लिमिट करना ही है, अल्कोहल इंटेक लिमिट करना है या स्टॉप करना है। और ये नहीं कि बीपी का मेडिसिन ले रहे तो हम एक बार सही हो गए। एवरी टाइम रेगुलर चेकअप जाना जरूरी है। एक्सरसाइज रेगुलरली करना है, दैट इज मैंने कहा मिनिमम वॉकिंग, सबसे मिनिमम चीजें सबको पेशेंट को समझाइए तो वो आपके साथ एडहरेंट करेंगे। तो एक्सरसाइज रेगुलर करना है, आइडियल वेट मेंटेन करना ही है। ओबेसिटी कैन नॉट बी, नो टू हाइपरटेंशन पेशेंट के लिए ओबेसिटी इज नो। तो आपको उनको बताना है कि आपको आइडियल वेट कैसे मेंटेन करना है। ब्लड प्रेशर घर पे चेक करना ही है, चाहे रिलेटिव चेक करे या पेशेंट खुद चेक करे, ये चेक करना ही। और ओनली बीपी चेक करना नहीं, ये प्रॉपर टेक्निक के साथ बीपी रीडिंग करना है। तो पेशेंट की ये समझाना जरूरी है, यदि आपको बीपी के साथ जीना है तो आपको ये जितना पॉइंट्स हमने अभी डिस्कस किया इनके साथ ही आपको जीना है। यदि ये एक्सेप्ट कर लेते हैं तो पेशेंट हम रेजिस्टेंस हाइपरटेंशन कंट्रोल भी कर सकते हैं और बीपी भी कंट्रोल कर सकते हैं। सो दिस ऑल अबाउट टुडेज टॉपिक, और I hope so it is clear about the resistance hypertension, its magnitude of problems, what are the various risk factors, and how we can overcome this resistance hypertensions. Anything is the doubt, you can ask me. Thank you very much. Madam, over to you.
Ma'am, there are some questions student are asking.
Okay. Then thank you very much for the session and to the organizer again.
Why blood pressure is higher in women only?
This is a gender. Gender has a no reason to specify. Research has shown that female having the higher risk of the hypertensive resistance hypertension cases. Not we are not talking about hypertension. We are talking about resistance hypertension. So the research shows that the female has a higher tendency in the resistance hypertension. Don't get confused with the hypertension and resistance hypertension. Both are different things.
Thank you, ma'am, for your wonderful insight.
Now, we have present in videos another fantastic speaker, Mrs. Malati ma'am, Assistant Professor,
GITAM Institute of Nursing, Visakhapatnam. She will enlighten us on impact of environment and blood pressure impact on population health. Mrs. Malati ma'am is a PhD scholar. Mrs. Malati ma'am is a PhD scholar from Sri Balaji Vidyapeeth, Pondicherry, and MSc and recent degrees. She has more than 10 years of experience in teaching. Currently, she is serving as an assistant professor at Geetham Institute of Nursing. She holds lifeline membership with TNI and the Christian Medical Association of India. She has served as a university question paper setter. She has guided and co-guided several research projects. Mrs. Malathi ma'am has published more than 10 research articles as a resource person. Over to you, ma'am.
Yeah, very good morning. Actually, I was waiting for the mic to unmute. I was not able to unmute, so sorry for the delay of a minute or so. And yeah, today we are, having a webinar on the occasion of Hypertensive Day, and we are observing this. And Ruma Institute of Medical Sciences has given us this opportunity to participate in a webinar and learn more, things about hypertension and the recent advancements being taken place in this particular, condition of hypertension. And past two speakers have been speaking about various things which are really, really important. Sometimes we might take it for granted that patient can be, recorded a BP on a lying down position or whatever it might be. So that can cause inaccurate blood pressure measurement and then inaccurate management of blood pressure, which is very, very important for the, nurses or the student nurses to be aware of. So I just wanted to congratulate again Ruma Institute of Medical Sciences for taking up this particular, topic and observing this particular day. So I'm just, as already introduced,
Thank you, ma'am.
I'm Tota Malati, working as an assistant professor at Geetham Institute of Medical Sciences. And then now, today we are going to talk about something which is called as, yeah, can you move to the next slide? Yeah, first of all, let me welcome you all to my presentation. Whatever I'm going to talk, for the next couple of minutes, I'm not going to take so long. I'll just make my presentation very, crisp and short so that it will be easy for the students to absorb. So I just wanted you to go to the next slide, please. Can you move to the next slide?
Yes, ma'am. Yes.
Yeah, sure. Okay, so the topic we are going to talk about today is environment and hypertension, and what is the impact, of the environment on the population health, or what is the impact of environment on basically people living with hypertension. So that is the topic we are going to talk about, and I feel, it is very important for us to discuss about these topics because environment significantly plays a major role basically in causing this particular condition of hypertension. We which we might think they don't add up to this particular condition, but they do so much, to these patients with hypertension. So that is what basically we are going to talk about in today's session. Okay, so what is my basic objective? So I just wanted to be clear about what you are expected out of my presentation today. Is basically I just wanted to you all to understand and also to explore the relationship between environmental factors and hypertension and their combined impact on population health. And the second objective of my presentation would be understanding these relationships, which is very crucial for developing targeted interventions and public health strategies to mitigate adverse effects. So there is a crucial relationship which is existing between the environment and the hypertension. Can somebody unmute I think your mic is on, I could hear some noise. Organizers. Okay, so the second objective would be to understand these relationships, which is basically existing between the environment and the hypertension, so that we will be able to have a positive attitude in taking care of the hypertensive patients. That is the major goal. Ultimately, we learn everything and we incorporate in our education, we incorporate in our practice, and we incorporate in our administration in order to bring out the policies and also protocols related to taking care of these patients, which is the major primary objective of this particular presentation. And before going into can you move to the next slide? Organizers, can you please change the PPT? Next slide, please. Next slide, please. Can you hear me? Yeah, next slide, please.
I think there is a net issue, madam.
Net issue.
Can you please, I will give you authority to share your slide.
Yeah, sure.
Recording in
Yes, ma'am. Do ma'am. Please share. Please.
Can you all see my PPT?
No, ma'am.
Just a second, I'm trying.
Madam, no issue, madam. I will share. We will share.
Sir, are you sharing, sir? Yeah. Yeah. Yeah, the previous one. Sir, the previous one.
Okay.
Okay, yeah. Can you click on that link, please? I just want everybody of you to understand what do you mean by the blood pressure. I just wanted you to look into your video so that it will be, little out of the box, because we have been hearing so many things and students' attendance can be, um, can be taken. Is the video being played? Can you please click on the link, sir? Can you please click on the link?
Just a second, ma'am.
The first one, what is blood pressure? The slide.
Actually, YouTube's screen is not sharing.
Okay, okay. Okay, fine. Then you can show it later. Okay. So I'll just go ahead. Yeah, thank you. Okay. So let us discuss what do you mean by the blood pressure. Actually, all of you might have a basic understanding about the blood pressure. So it is the amount of pressure which is exerted by the blood on the walls of the arteries. So when it is flowing in the arteries, the amount of pressure with which the blood is flowing through the arteries is basically called as the blood pressure. So there tend to be high blood pressure and low blood pressure depending upon the volume of blood and the pressure which is exerted by this blood on the walls of the arteries. Okay, so blood pressure is the force of circulating blood against the walls of the arteries, and this particular blood pressure measurement is a very critical measure of measuring the cardiovascular health. So basically, depending upon our regular monitoring of blood pressure, we can determine what are the factors that could be affecting the cardiovascular health, and it is an important sign. All of us know that it is a very, very important vital sign. Okay, so high blood pressure, which is also termed as hypertension, increases the risk of heart diseases, stroke, kidney failure, and other serious disease conditions. So all of you know, and maybe you can connect it with the mechanism. What is the mechanism between heart and renin, angiotensin, aldosterone system? So basically, the kidneys, heart, all these together, these two organs help in maintaining the blood pressure. So if it is increased, then you call that particular condition as hypertension. And increased amount of hypertension which is not managed properly at the at a particular time could also lead to a condition which is also called as stroke. Okay, it can be heart stroke or it can be a brain stroke also. Okay, so environmental exposures like pollution, noise, and climate factors are increasingly recognized as key influencers of blood pressure. So I already told you in the beginning that a lot of other factors which we have read theoretically. Obesity could be one factor, and consumption of high saturated fatty diet could be another reason. So many other reasons are likewise so many other reasons are there for people to develop hypertension. But actually, when you talk about the environmental exposures, even the things which we don't consider as important factors for developing this condition of hypertension are also playing a significant role, basically, like pollution, noise, and climatic factors also, like previous speaker also has described. In the winter seasons, basically the blood pressure seems to be little higher than compared to the warmer seasons. So likewise. So coming to the next one, please. Yeah, blood pressure overview. So these are the blood pressure categories, and here are the recordings of the systolic and diastolic, blood pressures. So coming to the healthy individual, suppose the a person is basically healthy. So when you call that person as healthy is when the patient is physically, psychologically, emotionally, spiritually, all the domains of the patients are correct. The patient is not having any problem in all these domains, then you call that particular patient as healthy patients. We can correlate with that. So the diastolic the systolic bp in such cases is less than 120 mm of hg, and diastolic is less than 80. Suppose the patient bp is little elevated. So when do you call it as elevated category is when the systolic bp is 120 to 129 and diastolic bp is less than 80. And similarly, stage 1 hypertension, the systolic BP is 130 to 139, and diastolic BP is 80 to 89 mm of Hg. And when we call it as stage 2 hypertension, when the systolic blood pressure is 140 or higher, and the diastolic blood pressure is 90 or higher. And we also call a condition, we also term this as a condition which is called as hypertension crisis. So hypertension crisis is a very important, life-threatening condition where, the patient's systolic blood pressure is over 180 mm of Hg and diastolic blood pressure is more than 120 mm of Hg. Then this condition is termed to be called as the hypertension crisis, where the patient need to be immediately paid medical attention with, or otherwise the patient can fall fatal. Okay, so this is the basic things about the blood pressure overview. Can we move to the next one? Okay, so coming to the global statistics, over 1.28 billion adults aged 30 to 79 have hypertension. Nowadays, you might be seeing in the articles, paper, news, print media, and everything, where, there is no particular age for a patient to develop blood pressure. Quite some time back, we used to think it is an elderly problem where the patient who reaches the middle adolescent stage or so will be affected with these conditions like diabetes, hypertension, and all that. But nowadays, it is very very significant in even adolescents also, like according to the WHO statistics, which is in 2021, many of them, this is an interesting point where many of them are unaware that they are suffering with this particular condition of hypertension. So now when do they recognize this? Basically when they have certain symptoms, or when they fall out, blackout, these particular symptoms, when they visit a hospital for a regular checkup, or checkup related to these particular symptoms, then they will be diagnosed with the condition of hypertension. So that is the major thing. And the key risk factors which basically contribute for developing this global hypertension are basically poor diet, lack of exercise, obesity, smoking, alcohol use, and environmental exposure. So these are basically believed to be the key risk factors for developing the condition of hypertension. Poor diet means which includes not a balanced meal or a healthy meal basically. So which includes a lot of high saturated fats, or lack of good nutrition, like vitamins, minerals, fiber especially. So all these should contribute in our plate when we eat. So when we are maintaining a poor diet and lack of exercise, so no physical activity, okay, so lack of physical exercise, lack of not maintaining a healthy BMI, that is body mass index. So when the patient is obese, and these two things are contributors of every particular condition possible, that is smoking and alcohol exposure and environmental exposure, so which I'll be talking in the further slides. Can we move to the next one? Okay, so what hypertension, a global health crisis. So hypertension or high blood pressure affects over 1 billion people worldwide and 65 million Americans, posing a significant global health challenge. Uncontrolled hypertension increases the risk of heart attacks, stroke, kidney failure, and other severe cardiovascular complications, leading to morbidity. That is nothing but the disease. So I already told you, as the previous speakers were also talking about importance of maintaining or intake of medications regularly is very very important. So which helps to keep our blood pressure in certain terms. If it is not maintained, or if it is uncontrolled, then it causes so many other fatal conditions, which could be heart attack, stroke, kidney failure, and so on. So in order to avoid all these complications, basically early detection and management of hypertension through lifestyle modifications and medication are essential for preventing these adverse outcomes. So early the the early you detect, the early you manage, the longevity is basically there. So that is the understanding of this particular and importance of this particular early detection and management of hypertension. Can we move to the next one, please?
Yes, ma'am.
Next slide, please.
Just a minute, ma'am.
Yeah.
Actually, ma'am, there is some problem. Just wait for a few minutes?
Yeah, yeah, sure.
It's
Yeah, it's fine. It's fine. Yeah. So adopting a healthy, heart healthy diet, engaging in regular physical activity, and managing stress can effectively lower blood pressure and reduce cardiovascular risk. Heart healthy diets, are basically a kind of dash diet, which the previous speaker was also talking about. That is dietary approaches to, prevent hypertension, like including high fiber in the diet and including a lot of vegetables and lean meat if somebody wants to really eat. So, these things basically will help in maintaining a heart health and reduce the cardiovascular risks. So public health initiatives focused on raising awareness about hypertension and promoting regular blood pressure screenings are vital for early diagnosis. So it is very important that people should know that hypertension can be caused once irrespective of the age. So people should be really regulate regularly monitoring their blood pressure, and also have an awareness about how to manage the hypertension and how to prevent the hypertension is very very important. And adapting a healthy lifestyle basically is very very important in order to basically reduce the condition. So these are some of the public health strategies which can be taken. Okay, so the next one please. Okay. So the environmental factors, which is the key element in my presentation today, would be environmental factors that are affecting the blood pressure of an individual. So let's take, I just wanted to segregate the environmental factors into five, which is basically called air pollution. So fine particulate matter, which is basically shortly called as PM. PM is particulate matter, which is less than 2.5 mm. Okay, and nitrogen dioxide and ozone increases blood pressure and causes vascular inflammation. Suppose we are living in a polluted area. I just want all of you to imagine this particular condition. How do one want to wake up in the morning, or how do you want to sleep? What kind of environment you prefer? you know just do you prefer sleeping in a very noisy and polluted environment? Sometimes we cannot tolerate if it is some bad breath, or bad air is being circulated in the room. Even we cannot tolerate that. Everybody wishes, and everybody wants something which is very clean, and which is very calm and quiet. So these are the preferences generally we wanted to take when we are about to sleep, or we wanted to get up early in the morning. Imagine yourself you know looking for houses. Okay, basically when you wanted to rent out a house, or when you want to buy a house, you generally prefer little interior places. Not everybody prefers on the road, beside a highway, or on the road where you could hear vehicles continuously moving. So that is not a pleasant environment. Do you think, or do you think it is indirectly or directly contributing to the blood pressure? Yes, definitely, because lot of articles, a lot of research articles have proven that these particular what do you call elements such as noise, light, pollution, all these are basically heat. So all these are basically some kinds of what do you call some kinds of elements which basically have an impact on the blood pressure. So even the air pollution, which is less than the particulate matters which are circulating in the air. All of air contains so much of pollution these days, and a lot of metro cities are facing this continuous problem. So where the particulate matter is less than 2.5, all these are contributing factors for affecting the blood pressure of an individual. Next one, noise pollution. Chronic exposure to traffic or industrial noise activates stress hormones and raises BP. Sometimes we close our windows. We wanted to have a plug in our ear, so that we will not be able to absorb any noise during the resting period or when we are sleeping. Why? Because it is indirectly going to disturb your circadian rhythm, and indirectly contributing for your blood pressure increase. So even the temperature extremes also, both hot and cold weather strains the cardiovascular system, affecting the blood pressure. So high humid climates or high heat, a lot of heat and lot of cold also can have fluctuations in the blood pressure of an individual. Next one, chemical exposures. So chemicals, when an individual is exposed to these particular chemicals like lead, bisphenol A, which is shortly called as BPA, and other endocrine disrupting chemicals can increase the blood pressure. And green space deficiency, lack of access to parks and nature reduces opportunities for stress relief and physical activity. It is very important for us to choose an area where we have a lot of access to these particular, what do you call, distractors. Basically it could be a park where we can quietly sit and do our yoga, meditate, or have fresh air to breathe, carry out our breathing exercises, or simply get exposed to sunlight, or limit the noise, or perform a physical activity. So there can be, simply sitting at a beach and watching the waves sometimes could be very very important. Sometimes looking at an aquarium constantly, it is also a research proven fact that people extremely having hypertension should have aquariums at home, so that taking care of them, or should have pets at home, so that while taking care of them or observing them basically can lead to a balanced blood pressure. So all these basically contribute to the blood pressure, okay, of an individual. So that is what these are the contributing factors. The next one, please. Yeah. Environmental conditions, including air quality, noise pollution, and access to green spaces significantly influence the blood pressure regulation. Exposure to chronic noise pollution can elevate blood pressure and heart rate, increasing the risk of hypertension and cardiovascular diseases. So access to these green spaces, which I already told you, that is nothing but the natural environment, promotes relaxation and reduces the stress, leading to lower blood pressure and improved cardiovascular health. That is the major importance of having green spaces. Next one, please. Yeah, living in socioeconomically disadvantaged areas with limited access to healthy food options and safe environments can exacerbate hypertension risk. So, living in a socioeconomically compromised areas with where you have limited access to these green spaces like parks or water reservoirs or whatever it might be, and also having limited access to, taking healthy food, or making healthy choices, basically where you are having a lack of these opportunities will increase the risk of your hypertension. Addressing environmental inequities and promoting healthier living environments is crucial for reducing the burden of hypertension in vulnerable populations. So this is very very important for us to address. The next one, please. I also want to discuss about another contributing factor for hypertension, that is genetic and environmental interactions in hypertension. How genetic? Genetic is basically the hereditary, composition which is inherited from one generation, or which is passed on from one generation to the other generation. We all know that many of the disease conditions, our primary etiological causes are basically genetic, which is hereditary in nature. Okay, so environmental interactions in hypertension. Genetic predispositions can increase susceptibility to hypertension, but environmental factors play a crucial role in triggering and exacerbating the condition. Lifestyle choices such as diet and exercise can modify the effects of genetic factors and influence the blood pressure regulation throughout the life. So the choices what we take, basically in terms of food what we eat, or the lifestyle that we lead, or exercise what we do, sleep and rest pattern which we follow, all these are basically the choices which is basically affecting the or having an influence on the blood pressure. So personalized medicines approaches that consider both genetic and environmental risk factors are promising for preventing and managing the hypertension. Okay, so these are some of the things. How genetics is basically impacting and having an effect on the blood pressure. Next, we would talk about the impact of water quality. Did anybody, think before you read, or if you're not a medical, student, basically? So can you imagine that water basically can cause gastrointestinal issues or can cause some other things, but it is indirectly contributing to the condition of hypertension also. So maintaining water quality protects against harmful health effects to sensitive populations and the general public, ensuring lifetime exposure safety. Contaminated water sources can expose individuals to heavy metals and other pollutants that can increase blood pressure and cardiovascular risk. So, if the water is contaminated, it is not only contaminated with bacteria or it is not only contaminated with parasites, but it can also be contaminated with high, loads of heavy metals and other pollutants that can increase the chances of developing the blood pressure and also chances of risk which is related to the cardiovascular health. So, access to clean and safe drinking water is essential for maintaining hydration and supporting optimal blood pressure regulation, especially in arid regions where you are not having a facility of good water supply or a clean water supply. Then, those area, people living in those affected areas, there are a lot of research articles which are available online. You can browse it and you can know how water is indirectly contributing to the condition of hypertension. So people living in these areas where you don't have access nowadays, I think everybody is having access to clean water. But similarly, if somebody has no access to these particular clean and safe drinking water, then people in those particular regions are basically having a risk of developing hypertension. So you can see a lot of incidents in these, areas. Next one, please. Yeah, investing in water treatment infrastructure and implementing strict water quality standards are crucial for protecting public health and preventing hypertension. So, it is very important that, especially in the panchayats or especially in the rural areas or especially in the hilly areas. So, investing in water treatment plants and making sure the public are having a facility of having safe water, drinking water basically, is very important. And the government has taken, from its side, has taken a lot of initiatives, and we are fortunate enough in that particular. But it should reach the unreached. Safe drinking water is a right for everybody and it should reach the unreached. That is the main, that should be the main important thing, a strategical thing, related to administration in order to reduce the risk of developing hypertension. So individuals can use water filters and bottled water to reduce their exposure to contaminants, and ensure that they are having a safe drinking water supply. So that is what is the contribution of water in the condition of hypertension. Next one. Yeah, mechanisms of environmental impact. So these are the mechanisms of environmental impact. That is, what all damages it can do to the body. How environment can damage your body and can cause hypertension is explained in these mechanisms. So the first one is inflammation and oxidative stress. So pollutants increase reactive oxygen species, damaging the blood vessels in our body. And endothelial dysfunction also can take place. Exposure to toxins impairs the inner lining of blood vessels. So the lining of blood vessels can be, damaged when a patient is exposed to the toxins which are present in the environment. It could be air toxins, or it could be food toxins, or it could be basically water toxins, or it could be, hereditary related or any other things. And the next one could be autonomic nervous system imbalance. Environmental stressors trigger fight or flight responses that can increase the blood pressure. So, all of you know this fight or flight mechanism which our body does whenever our body is encountering with an antigen or basically a stressor. So generally either it fights with that particular stressor or antigen, and or generally it bends down and basically allows the body to be affected. So that can also increase the blood pressure. Next one is hormonal disruption. Chemicals like BPA which I have already discussed in the previous slide. Chemicals like BPA mimic hormones and interfere with the BP regulation. All of you, if you correlate with your renin, angiotensin, aldosterone system, so you know that chemicals like BPA can mimic the hormones basically, and they can interfere with the BP regulation. So however, how much ever the kidney is trying to produce renin and angiotensin 1, angiotensin 2 is being converted, and these are all important things in the regulation of BP. So when a person is exposed to these kinds of environmental stresses, basically hormonal disruption also can take place, and the renin, angiotensin, aldosterone system is totally collapsed, and the body will be affected with high blood pressure. So that is what is the hormonal disruption. Next one, we look at a case study which is called air pollution. The key findings are basically studies show a significant link between long-term particulate matter, which is less than 2.5 mm exposure, and elevated blood pressure. And who is at risk of these particular, hypertension cases? Basically, people who are urban dwellers, that is living in the urban areas, industrial zone residents, people who are living in the industrial zone areas, people, children and elderly are more vulnerable because of the immature immune system functioning what they have. So these people are at high risk basically of developing hypertension, which is related to the environment. So urban areas, I need not to explain. We when there are so much advantages, and there are so much disadvantages also of living in an urban area, and one such disadvantage could be hypertension. And health outcomes, basically higher risk of hypertension, heart attacks and strokes with prolonged pollution exposure. Obviously, people will tend to develop conditions such as hypertension, heart attacks, and the condition of stroke, when they have a prolonged pollution exposure. I want all of you to understand this particular thing. See, we might all think that one insult with an agent will not immediately cause a disease condition. Repeated insult of the body with these particular toxins, or when the body is continuously exposed to these particular conditions, basically will lead to the condition of hypertension. So that is very, very important. I've also displayed it in a video. If your institute is being delivering this PPT, I request all of you to please click on these two videos, where one video explains about the blood pressure, and the next video explains about the scenario of how these environmental factors have a direct impact on the condition of hypertension. Next one, please. Yeah, this video, if you're not able to play it, then obviously you can please share it with your students so that they'll be able to see. And I tell you that highly populated countries like India, China, basically where the population is high, the more the population, obviously the more is the pollution. So can have an impact on the blood pressure. Climatic change and hypertension. Okay, so how does climatic change basically affect your hypertension? Okay, so climatic change and hypertension, extreme heat events, basically heat waves increase cardiovascular strain, dehydration and blood pressure levels. And the next one is natural disasters, displacement and trauma from floods, hurricanes and fires spike stress related BP issues. And infrastructure stress can be, these are some of the stressors. Disrupted healthcare access and medication availability during climate events worsen BP control. So this is the impact of climate change on the hypertension. So extreme heat can cause cardio strain on your heart. It can lead to high dehydration, and can also lead to BP level fluctuation. Either the BP can go down or the BP can increase. So likewise, so these are various climate related changes which can have an impact on the blood pressure. The next one, please. Urban versus rural setting. So I already told you, urban area, high exposure to pollution, noise, and psychological stress, better healthcare access. So basically, it is having the advantages like better healthcare access, and also having the disadvantages like high exposure to pollution, noise, and psychological or psychosocial stress can be an impact on the blood pressure. And the rural areas, we find cleaner air, but often poorer healthcare access and fewer health education opportunities. And the disparities between the two are socioeconomic and racial. Ethnic disparities lead to unequal exposure and outcomes. So even though in the rural areas we have cleaner air, but we have less access to the healthcare facilities. We might not have a district hospital in the rural area, so we might have some health centers will be definitely available. So all of us are aware of that. Like you have sub centers, you have community health centers, you have primary health centers, urban health centers, which might be taking place. But district hospitals where the patient, if the patient is having some sort of complications, it will be really difficult for them to have a better treatment. So that is what is urban versus rural setting impact on the blood pressure. The previous one, please. Okay. Impact on the population health, cardiovascular diseases. So, hypertension is the leading modifiable risk factor for cardiovascular diseases and stroke. Modifiable risk factor is something which can change. So, if we lead a better lifestyle, obviously we reduce the risk of developing hypertension and stroke. So, healthcare burden, billions spent globally on treatment, medications, and hospitalization. That is a very much healthcare burden which we have basically on developing hypertension. And inequities, basically disadvantaged communities face double burden, higher environmental risk, and limited care. So this is about the impact on population health. What could be the public health strategies? Next one, please. What could be the public health strategies? Basically, people, administrators can develop policy interventions such as emission regulations, urban noise ordinances, and green infrastructure. Students might be correlating with that. People with loud silences are not allowed to mobilize. Basically, they're not allowed to roam with loud noises. Loud silences basically. So that can lead to noise pollution. And basically you should have a pollution certificate of your vehicle when you wanted to take them on the road, because the more amount of pollution is released by the vehicle, those type of restrictions are there laid by the government just to prevent these kinds of pollution exposure. Okay, so these are one of the public health strategies. Urban planning, promote active transport, reduce traffic congestion, and create more green spaces. That is why the central government and the state governments are taking effort in order to what you call create a space for park or something like that, where the people can be having different recreational activities. It helps them to have what you call decrease such health risks, and one such risk can be hypertension. Health education, community awareness, lifestyle promotion, and early screening programs is very important. And climate resilience, prepare healthcare systems for extreme weather and displacement effects. So this is very important. Public health strategies, what we can maintain or what we can do. Next one, please. Yeah. Environmental risk assessment and hypertension prevention. Environmental risk assessment identifies potential hazards that influence health, enabling targeted interventions to mitigate the risk and prevent hypertension. There are three types of environmental risks that need consideration. One is chemical, the second one is physical, and the next one is biological hazards that have an impact on the health. So, promoting access to green spaces, healthy food options, and safe living environment can improve overall cardiovascular health and prevent hypertension. So I have already laid so much of stress on importance of green spaces, making healthy choices related to food, and having a what you call a healthy lifestyle basically can improve your cardiovascular health and can prevent the condition of hypertension. The next one, please. So collaborative efforts involving healthcare providers, policymakers, and community organizations are essential for creating healthier environments and preventing hypertension. So the recommendations could be cross-sector collaboration between the health, environment, transportation, and housing. And focus should always be on the early intervention through environment-aware primary health care. Equity in action, special attention should be given to the vulnerable and high-risk communities. And I wanted to conclude my presentation saying that environmental exposures are powerful, modifiable factors in the development of high blood pressure. And call to action can be related to public policies, and individual behaviors must be prioritizing the environmental health to reduce the hypertension. And our most important vision should be a healthier, more resilient, and equitable future for all. Okay, so basically we have seen, we have enjoyed our childhood. Now we are living in a particular environment where our role is to protect the environment, so that basically it can affect, or it can create a positive impact on our health. So we must all pledge together, we take care of the environment in turn takes care of us, so that we will not land up in having a lot of health related issues. And I wanted to stress on this point, very important point: the costliest bed in the whole world is the hospital bed. You, all of you, can relate to this. So the minute people scared to get even go for a hospital checkup, because the minute you enter, the charges are very very high. And basically, so that is what is important. So we should all be healthy by leading a healthy lifestyle and taking care of the environment, which is very very important. So thank you all for your patient listening. And I would also like to thank Ruma Institute of Medical Sciences principal for giving me an opportunity to share my thoughts on this particular topic, which is given to me, that is environment and hypertension. What is the impact of environment on the hypertension? I hope everybody understood and has some takeaway from this presentation. Thank you all so much.
Thank you so much, ma'am, for your insight section. We have received few questions from our participants. With your permission, may I now present them to you
Yeah,
for your
sure.
response?
Sure.
First question is there genetic testing for hypertension?
Actually, genetic testing might not be possible, but if there is a positive family history, if some grandparents or parents are suffering with this particular condition, we might also be at risk. So the one which we can do is prevent. So in order to prevent hypertension, we can lead a better lifestyle, so that we will not be able to have this particular condition.
Thank you so much, ma'am. And the next question is how many generations STN travel? For how many generations STN travel?
Yeah, okay. Hypertension travels in how many generations? That is totally unclear. So we cannot tell that it travels only for one generation. If you learnt genetics in detail, the students can understand that, there is something which is called as dominant gene, and there is something which is called as recessive gene. So when it is being transmitted from one generation to the other generation, so there can be an absence in one generation and there can be a presence in another generation. So that is totally, we cannot predict the relationship, or which generation could be affected, or how many generations can it transfer. So like that, there is no particular research proven evidence as such. And I don't think there is some time limit for the condition to. Yeah.
Okay, thank you so much, ma'am, for your wonderful insights.
Thank you so much. Thank you, everybody. Thank you so much.
Okay. It's time to welcome a speaker whose expertise in the field is truly admirable, Dr. I. Clement, sir, Dean cum Professor, Department of MSN, St. Benedict's Group of Institutions, Bangalore. He will discuss on imaging and biomarks hypertension meditate target organ damage. Dr. I. Clement, sir, is Dean and Professor in St. Benedict's Institute of Nursing, College, Bangalore. Dr. I. Clement, sir, is distinguished academician and healthcare professional with an exceptional educational background, holding a PhD in nursing, 2 MSc degrees in nursing, and 3 master's degree in arts. He is presently serving as the Dean and Professor at St. Benedict's Institute of Nursing College, Bangalore, with over 14 years of postgraduate experience and a professional journey spanning 32 years from auxiliary nurse to doctorate in nursing 1986 to 2018. Dr. Clemens sir has made significant contributions to nursing education and research. He has mentored numerous postgraduate and doctoral students, serving as a PhD guide, co-guide, examiner, and thesis evaluator in addition to his involvement in tool variation and thesis assessment. Dr. Sir is the author of 70 textbooks in nursing and paramedical sciences, many of which include solved question papers and serve as essential academic resources. He has also published 60 scientific research articles in reputed national and international journals. He is actively engaged in academic publishing as an editor and member of various national and international editors board. His professional affiliations include membership in respect organizations such as the Trained Nursing Association of India, Indian Society of Psychiatric Nurses, Christian Medical Association of India, Nursing Research Society of India, Red Cross St. John's Ambulance, Society of India Neurosciences, Nurses, and the PhD Society of Nursing. In recognition of his outstanding service, Dr. Clemens Sir was honored with the prestigious Florence Nightingale Award for Best Principal during the International Nurses Day celebration at Raj Bhavan, Bangalore. Actually, Dr. Clemens Sir's achievements are so vast and inspiring that if I start listening them all, we had still be here by evening. So, with great respect and administration, I'll stop here for now. Over to you, sir.
Thank you, madam. Thanks for your introduction. Can you share my PPT?
Yes, sure, sir.
You need
Just-
to
We are sharing, sir.
just one second, madam. One second.
Yes.
Can you all can see this ma'am screen?
Yes, sir.
I'm just making it. Very good afternoon to one and all. I really take opportunity to congratulate Ruma Institute of Medical Sciences, Uttar Pradesh. The director,
Thank you so much, sir.
the principal, vice principal, and the faculty members, and the organizing committee for organizing this very important day, World Hypertension Day, 17th of today. The worldwide people are recognizing Hypertension Day, and it's a good day. You have taken a right topic. So that WHO theme, you have just taken it. Measure your blood pressure accurately, control it, and live longer. So it's a right appropriate topic today, which is most important for general public and as well as nursing students and each and everybody. They are the ambassadors to take this message to every place, every corner of this rural and urban places. Controlling BP is most important. That you have done it actually. And I'll come to the topic today, imaging and biomarkers, hypertension mediated target organ damage, which is most important because we have learned about hypertension, the various aspects of hypertension. The previous three speakers spoke about various perspectives of hypertension. But here, how to diagnose of getting the organs, the very important target organs or damages, how it is identified and screened by imaging and biomarker techniques. So let us go. I'll just make it very simple. So hypertension mediated target organs damage, it refers to the structural and functional changes in various organs. You can see in the picture, it's mainly affect the heart, brain, blood vessels, and the eyes. And these are kidney. These are the vital organs which will be getting damaged because of the increased blood pressure. So here, the mediated target organ damage, which is happening in a cardiac, which is mainly like heart muscle thickening is happening. Left ventricular hypertrophy, impaired functions, and enlarged upper chamber, and increased heart failure and arrhythmias are the risk factors which is happening because of the increased hypertension. Next, cardiovascular complications, we can see the brain blood vessel damage and increased chances of getting a stroke, trans-ischemic attacks, and the small vessel diseases, that is in a white matter lesion and Lucina infarcts, and potential cognitive issues are happening because of increased hypertension. And the renal problems, kidney damage, early protein in the urine, that is micro or proteinuria, and reduced kidney function and chronic kidney diseases are the complications, means the organ damages will be happening in the renal system. And the vascular complications are the blood vessel damage, stiffness in the arteries, that is increased stiffness, and thickened walls, atherosclerosis, and reduced limb blood flow. And the retinal complications or damages which is happening because of the increased hypertension or high blood vessel damages, that is hypertensive retinopathy, potential vision changes, and marker of microvascular damages. So these are the 5 important organ damages which is happening. You can see here in this slide. So brain, arteries, we call it as BRCA, brain, arteries, or for retina and kidney and the heart. So uncontrolled or severe uncontrolled blood pressures, which is causes damages to the organs, that is in the brain, stroke, ischemic or hemorrhagic attacks, hypertensive encephalopathy. In the arteries, acute aortic syndrome, preeclamptic syndromes are occurring it. In the retina, grade 3 to 4, Kent, Wagner's, Barker retinopathy is occurring. In the kidney, acute renal insufficiency and thromboangiopathy is occurring. In the heart, acute heart failure, pulmonary edemas are occurring. So this is a hypertensive emergencies which needs to be reduced immediately. And I just briefly say about the statistical informations about globally. Hypertension prevalence is 1.3 billion adults globally. It is projected to rise 1.5 million in the year 2030. So controlled rates are, it remains low globally. It is less than 1 in 5 is controlled. And hypertension mediated organ damages, the burden is substantial due to the high prevalence and poor control. It is common problems are arterial stiffness and most prevalent is happening it. So next statistics in India, It estimates for 2024, the hypertension prevalence is more than 30% of adults, rising according to the trend. The control rate, alarmingly, it is low, and many undiagnosed, untreated. Hypertension mediated organ damages burden is 40 to 60%. It is very high of hypertensive with damages. The common conditions are left ventricular hypertrophy, retinopathy, microalbuminuria, and increase CIMT, that is carotid intima media thickness. And the trend is likely to increase hypertension mediated organ disorders, burden with the rising hypertension and poor control. So this is a very brief information about the statistics in India. And there are now my topic given to me, the imaging and the biomarkers. The imaging techniques for hypertensive mediated organ damages. The heart damages will be identified with ECG, electrocardiography, echocardiography, and cardiovascular magnetic resonance, that is CMR. So these are the three very important imaging tools which is used for identify the complications of cardiac or heart. Coming to the brain, there are very important three diagnostic or imaging techniques which is used to rule out the problems of cerebral or brain complications. The first one is MRI, magnetic resonance imaging. The second one is computerized tomography and carotid ultrasound. So we'll be seeing one by one in detail. And the third major area is kidney, that is renal ultrasound can help to rule out the problems. And the fourth major criteria is blood vessels, that is pulse wave velocity imaging and ankle brachial index. And for ophthalmic eyes, we do a fundoscopy or retinal examinations are used to identify the papilledema or problems in the retinal nerve, retinal vessels. And also retinal photography and quantitative analysis are the imaging test commonly done for identifying the HMOD, that is hypertensive mediated organ damages. Coming to the biomarkers, it's only an outline I'm giving you. And also we are going to discuss in little bit detail. So biomarkers for this hypertensive mediated organ damages, the first one is naturalistic peptide, that is we call it as BNP. The normal range is less than 100 picograms per milliliter. The second cardiac biomarker is cardiac tamponine, that is high sensitive assays. The normal of cardiac tamponate is 0.0 to 0.1 nanogram. There's a full stop is not there. 0 to 0.4 nanogram per ml. And also growth differentiation factor 15, GDF 15. The normal range of GDF 15 is 0.15 to 1.5 nanogram per ml. And these are the very important three biomarkers which is commonly used here to identify the cardiac complications because of the increased hypertension. And renal biomarkers, that is albuminuria or microalbuminuria, it's supposed to be less than 30 milligram per deciliter. And second one is neutrophil gelatinase associated lipocalin. It is called NGAL. The normal value is less than 50 nanogram per ml. And the third biomarker in a renal biomarkers, that is uromodulin. The normal value is 30 to 540 nanogram per ml. And vascular biomarkers. There are very important 3 biomarkers to identify the vascular complications. The marker of endothelial dysfunction, we call it as CTNL. It is supposed to be less than 10 to 20 picogram by ml. The second one is the marker of inflammation. Commonly 2 tests are conducted for this. ESR. Here the normal value of ESR is 0 to 22 millimeter per hour. And CPR, creatine reactive protein. It's supposed to be less than 3 milligram per liter. And the third one is the marker of oxidase stress. There are 2 types, very important 2 types of 8-oxido-G and 8-OHDG. So these are the 2 common tests. The normal value is 0.24 to 2.47 nanomole per millimole per liter. And the fourth one, vascular biomarker, is matrix metalloproteinase. We call it as MMPS, that is 14.3 to 34.6 nanogram per ml. The other potential biomarkers for identifying the hypertensive mediated organ damages are: number 1, homocysteine. The normal value is 5 to 15 A nanomol per liter. The second, uric acid, that is 3.5 to 7.2 mg by dl. So these are the brief outline about the biomarkers and the imaging. And we just go little detail about the imaging techniques for hypertensive mediated organ damages in the heart. The first one is ECG. ECG, as we all know, that it's a non-invasive test to detect the dysfunction of the heart. Here it is mainly in a hypertensive. Left ventricular hypertrophy is measured or examined. It's a common cardiac consequences hypertension. The QRS changes which is happening here in this: increased QRS voltage in left leads and deep S wave in the right leads. And septal Q waves, deeper, narrow, and Q waves in the lateral and sometimes in the inferior leads also. You can see in the ECG. And ST changes and non-specific ST depression and the T wave inversion often in a lateral leads. Left axis deviation, possible shift in the heart's electrical axis. And commonly we can see some of the arrhythmias, that is atrial fibrillation, supraventricular tachycardia, premature ventricular tachycardia, and other sustained ventricular tachycardia may be occurring it. And the second techniques we use to examine or check the cardiac problems or cardiac complications, that is echocardiography. It is the other level of advanced to identify the problems by imaging. It is an ultrasound-based imaging technique that is commonly used to provide detailed information about the heart structure and the function. It detects the left ventricular mass and diastolic function. It is the more sensitive than the ECG. It is detecting left ventricular hypertrophy and also identify the left atrial enlargement, and the other abnormalities can be identified with the help of echocardiography. And the third test to examine the heart, that is cardiovascular magnetic resonance, CMR. It is considered as the gold standard for assessing the cardiac structure and the function, and it gives high accuracy. CMR can precisely quantify left ventricular mass and detect myocardial fibrosis, that is nothing but scarring, and evaluate the diagnostic diastolic function of the heart. And next we are moving into the cerebral or brain. The first imaging technique we use here, MRI, magnetic resonance imaging. It is highly sensitive in detecting the various form of hypertensive brain damages. It detects the white matter lesions, Lucina means infarcts. It's a small strokes which is happening in the brain can be identified, and the microbleeds, and which may be asymptomatic. And the second test, which or the radiographical or imaging technique, we use a computerized tomography, primarily used to identify the macroscopic brain lesions like large infarcts or hemorrhages can be identified in CT scan. And the third technique we use here to identify the complications of brain, that is carotid ultrasound. It helps to assess the carotid arteries for the atherosclerosis, that is opaque buildup, a marker of systemic vascular damage associated with the hypertension and increased stroke risk. And also carotid intima media thickness, CIMT, can also be measured as the early indicator of vascular changes. And coming to the third important vital organ, that is kidney, renal ultrasound is used to identify the complications and the problems of primarily it is used to assess the kidney size and detect the structural abnormalities. And Doppler ultrasound can be used to evaluate the renal blood flow, while not directly imaging the damage, estimate the glomerular filtration rate, and the albuminuria, means detected in the urine samples, are crucial indicators for hypertensive kidney diseases. And coming to the fourth area, blood vessels. Hypertension causes damages in the blood vessels. So yearly we identify with the help of diagnostic by radiography or by imaging technique, which we can be, the further damage and complications can be prevented. The first test in blood vessels, that is pulse wave velocity, PWV, a non-invasive measure of atrial stiffness, a key component for the hypertensive mediated organ damage. An increase PWV indicates stiffer arteries, and it is a strong predicator for the cardiovascular events. And the second technique or second radiological method or technique we use here, the angle brachial index, ABI. It compresses the blood vessels, compares the blood pressure in the ankles and the arms to assess the peripheral artery diseases, and often associated with the hypertension. And the fifth area of imaging, that is fundoscopy, retinal examination. We commonly identify the papilledema. So direct visualization of retinal blood vessels, which can show signs of hypertensive retinopathy, including arteriolar narrowing, hemorrhages, microaneurysms, and exudates. Retinal changes reflect the microvascular damage and the other associated, which increased cardiovascular risk. And the second very important technique, imaging technique we use to identify the ophthalmic complications, that is retinal photography and quantitative analysis. So digital imaging allows for more objective assessment and the measurement of retinal vessel diameters, which can serve as a marker for the microvascular health. And next, we move on to the second topic, that is called biomarkers of the hypertensive mediated organ damages. So here the specific blood test or specific test conducted to identify the complications, and we can accordingly we can prevent or any other further treatment can be done. And the first biomarker for the cardiac biomarker, which is natriuretic peptide, BNP, and also TN-proBNP, primarily used for heart failure diagnosis and prognosis, and elevated levels can also indicate the hypertensive cardiac strain and left ventricular dysfunction. And the second biomarker test commonly used to identify the heart or cardiac problems, that is cardiac troponins, highly sensitive assay test which commonly done to identify it may be elevated in the hypertensive heart diseases. It indicating the myocardial injury even in the absence of the acute coronary events. And the third test, the third biomarker for cardiac problems, the third one is growth differentiation factor 15, GDF 15, a marker of cellular stress shown to be associated with the left ventricular hypertrophy and adverse cardiovascular outcomes in the hypertensive patients. And identifying the renal biomarkers, the first one is albuminuria, microalbuminuria, the early indicator for kidney damage due to the hypertension and reflecting glomerular endothelial dysfunctions. And the second renal biomarker, that is neutrophil gelatinase associated lipocalin, commonly called as NGAL test. It is a marker of kidney tubular injury. Levels may be elevated in the hypertensive kidney diseases. And the third biomarker for the renal problems, that is uromodulin. The lower levels have been associated with the increased risk of hypertension and kidney diseases. And the vascular biomarkers, the first vascular biomarker is marker of endothelial dysfunction. We can see endothelial 1 and nitric oxide metabolites and Van Willebrand factor, that is VWF, and soluble adhesion molecules, example ICAM1, VCAM1. It reflects the damage of the inner lining of the blood vessels. And second biomarker in the vascular damages can be identified with the help of markers of inflammation. Here, highly sensitive C-reactive protein, that is HSCRP, interleukin 6, IL-6, and tumor necrosis factor, that is alpha TNFA. It indicates a systemic inflammation which contributes to the vascular damage in hypertension. And third biomarker, vascular biomarker, that is markers of oxidative stress. So the commonly isoprostans and other biomarkers reflect the increased reactive oxygen species production. It is a key mechanism in the hypertensive mediated organ damage. And the fourth biomarker for vascular complications, we call it as MMPS, matrix metalloproteinase. It is an enzyme involved in the extracellular matrix remodeling, and altered levels may indicate the vascular and cardiac damages. And next comes here some of the potential biomarkers for identifying hypertensive mediated organ damages that is elevated. The first one is homocysteine, that elevates elevated level have been seen in associated with the increased cardiovascular risk and hypertensive mediated organ damages. And the second very important biomarker for identifying the other potential biomarkers of the complications, the hyperuremic uremia. It is frequently observed in the hypertension, and the many contribute to the kidney and cardiovascular damages. So concluding, so both imaging techniques and biomarkers provide complementary information for the detecting the and monitoring the hypertension mediated organ damages. Their use allows for the better risk assessment and the more personalized management strategies to improve the outcomes in the hypertensive patients. So these are we have very briefly seen about the radiological or imaging techniques, which is commonly used for identifying the hypertensive mediated organ damages, and also some of the very, very important biomarkers also we have seen right now. So with this, once again, I just overview or take home message. The common imaging techniques which is used for hypertensive mediated organ damages for the cardiac or heart complications can be identified with electrocardiography, ECG. And second one is echocardiography. And cardiovascular imaging means some magnetic resonance for the brain or cerebral dysfunctions or complications due to hypertensions can be diagnosed with the help of MRI, magnetic resonance imaging, computerized tomography, and carotid ultrasound. And the kidney problems can be identified with renal ultrasound. The blood vessels can be identified with the imaging technique of pulse wave velocity. And second one is angle brachial index. And the eye ophthalmic complications can be identified with the help of fundoscopy or retinal examination. And the second test is retinal photography or quantitative analysis. And biomarkers, very briefly, natriuretic peptide is the first test. And second one is cardiac troponins. And third one is GFT, that is growth differentiation factor 15. And renal biomarkers are albuminuria or microalbuminuria. And the second one is neutrophil gelatinase associated lipocalin. And third test is uromodulin. And vascular biomarkers are marker of endothelial dysfunctions. And second test is marker of inflammations, that is ESR and CRP test are commonly used here. And markers of oxidative stress is commonly used in vascular problems to identify. And the fourth test in the vascular biomarker is matrix metalloproteinase, that is MMPS. The other potential biomarkers to identify the hypertensive mediated organ damages are homocysteine and uric acid. These are the very brief informations about the imaging and the biomarker test, which is commonly used to identify hypertensive mediated organ damages. I once again thanks the organizers for giving me the opportunity to share few informations with you all. Thank you, ma'am. Over to you.
Thank you so much, sir, for your enlightening session. We now welcome our distinguished academic leader, Dr. Dipti Shukla, ma'am, Principal SINPS Lucknow, Vice Principal TNAI UP State Branch. She will present on pathophysiology and hemodynamics, genetics, epigenetics, and phenotype. Dr. Dipti ma'am is the principal of Samarpan Institute of Nursing and Paramedical Sciences, Lucknow, Uttar Pradesh. She has over 20 years of experience in the field of nursing and paramedical education. She holds a PhD in nursing. She completed a postdoctoral fellowship program. She is associated with ERU USA and ERC USA. She is a Diamond Fellow at the Eudoxia Research Center USA. She has earned multiple postgraduate diplomas in
lecture
various
लेने जा रहे हैं. I will call you back. हाँ.
forensic science and forensic photography, forensic science, medicine and human identification, forensic chemistry and forensic toxicology, forensic fingerprint identification, collection, preservation, and guiding of forensic samples. She is a vice president of TNAI UP Uttar Pradesh branch. She served as the general secretary of the Indo-Pacific Academic of Forensic Nursing Science, India. She is an executive member of the Education Board, UPSMF. She is also an executive member of the steering committee of the Bioethics Center at APPMU and the UNESCO Chair, Melbourne, Australia. She holds an executive member position at SACTEM sector. She is a certified NQUAS assessor and external assessor. She is a board member at ABVMU Lucknow and DMIMS Nagpur, Maharashtra. She has developed 11 inventions and hold 6 copyrights. She received the first innovator
Beta, we can
award
start.
in
Beta, we can
2019
start.
for the PD vaginal reflector, which is registered with the Patient Cell of India. She received the second Invader Award in 2020 for the postpartum abdominal binder. She received the third Invader Award in 2022 for the cervical scalp pen. She registered the fourth invasion in 2022, the multi-layered sanitary napkin. She received the fifth Innovators Award in 2023 for the orofacial cleft diaper. She registered the sixth innovation in 2023, the vaginal medicine delivered device. She registered the seventh innovation in 2023, the DS Pulse Ox device. Dr. I. Clemens, sir.
I'm unmuted.
He has so many achievements.
So he's not listening me. Allow her to listen. Hello, Beta. Thank you so much for your introduction. As I am scheduled with the next session afterwards, I request you, please allow me to start the lecture.
Sure,
Thank
ma'am.
you so much for all your good words about me. Jai Hind, a very good afternoon to one and all present here with this national webinar. I really thankful to the management of Ruma and the lovely principal of Ruma College of Nursing and the entire faculty who did the hard work behind this picture to be present on floor. Thank you so much for inviting me and making me a part of this galaxy of experts. Thank you so much. I feel really proud to be part of this. And I am very sorry because I already told to principal sir of you that we have scheduled, this is previous schedule 1 month before. So I will finish my lecture. If anything is there, please let me know in my mail. I will put it there. Thank you so much. Please allow me to share my slides so that I can start. And Jai Hind to all. I think maximums are from Uttar Pradesh. Thank you so much for joining. I know that you all are now tired because back-to-back classes. You can raise your hands. You can move in your room. You can laugh loudly for 1 minute and then I will finish within 20 to 25 minutes. A very small topic I do have. Thank you so much. Jai Hind to everyone. Yes, thank you so much for giving response in the chat box. Anything you want to tell me, you can put me directly in the chat box. I will definitely attend that. Thank you.
So, is it visible to everyone? I will make it slide share. Sir, is it visible?
Yes, ma'am. It's fine. Visible.
Thank you so much. Thank you so much. So my topic is pathophysiology and hemodynamics, genetics, epigenetics, phenotypes in hypertension. It looks very long, but it is very small. Thank you. So we'll start. Hypertension is a silent force and that is unnoticed until damage is done. Control today, prevent crisis for tomorrow. This is beautiful quote for the hypertension and everyone must follow it because when it is going to be give you a picture that you are suffering with hypertension, the damage is already there. Thank you so much. My slide is not moving. So these are the outlines we'll go through with the hypertension. What is the pathophysiology? What are the hemodynamics means? How they together are connected? What is genetics, epigenetics, and phenotypes? So if I talk about the hypertension as introduction, since morning you are listening, hypertension is a condition of high blood pressure and where this condition is going to force the blood against the wall of the arteries and it is going to be increased. That is reading by 140 by 90 mmHg in the higher sections and it is also known as a silent killer. So as a nursing professional, we must understand the risk factor of such a genetic obesity, sedentary lifestyles, high salt intake, stress, smoking. These are all the risk factors. Those are going to be increase the hypertension. They are giving the hypertension. They are going to increase our blood pressure. So, as a definition, we can say that hypertension is a condition where the systolic blood pressure is more than 140 mmHg, diastolic is less than more than 90 mmHg, or at least two separate occasions. Okay. So here both the things. Systolic, that is the top number. What is that? The pressure when the heart beats. And diastolic is the bottom number, where the pressure when the heart rests. So बहुत simple है. सिस्टोलिक क्या है? ये टॉप नंबर है, ऊपर की तरफ आता है और इसमें क्या होता है? व्हेन आवर हार्ट इज गोइंग टू बी beat and diastolic when our heart is resting. So yes, already you understand, you all are intelligent. So this is the hypertension and here who is going to control the hypertension? So heart, how hard or fast it pumps, that is the cardiac output. Blood vessels, how tight or relaxed they are. They are also known as peripheral resistance. So we have to know about our blood vessels. They are constant. That means the flow is not good. When the flow is not good, that can be the cardiac output may be high. So the next one is kidney. How much fluids they keep or get rid of the blood volume. So here is one formula. BP is equal to cardiac output. Then is equal to peripheral resistance that we need to understand. Okay. Then we have to go through with next slide. So how blood pressure control already you understood. Okay. So cardiac output, that is how much blood the heart is pumping, and peripheral resistance, how tight or relaxed the blood vessels are. So these can be increased, that can be decreased. The next is very important. Means what does pathophysiology means and what does this hemodynamics means. So here it is mentioned that pathophysiology refers to the study of functional changes in the body that occurs as a result of a disease or abnormal conditions. For example, so it can explain like how and why normal physiological processes are altered in the disease condition. It is very simple terms. That is pathophysiology. Answer the question what happened inside the body when someone has a disease.
So that is the pathophysiology. If I talk about the hemodynamics, so it is the study of blood flow and the forces involved in the circulation. That is hemodynamics. That you understood. Pathology means what is going to happen in our body, and hemodynamics, how our blood flow is going inside the body and how the forces are involved in that circulation. So it focuses on the how the heart pumps, how the blood and the blood flows take place in the arteries, veins, and capillaries. So what is the key notes for the hemodynamics? These are the parameters that includes the blood pressure, heart rate, cardiac output, stroke volume, and vascular resistance. These are coming together to the high hemodynamics. So when in hypertension, these factors become imbalanced, and that is going to be cause hypertension. So this is the relation between the pathophysiology and hemodynamics. We'll go one by one. So here, if as a keynotes, we can go with the parameters of hypertension. So you can see cardiac output. Okay. So what is that? This is the amount of blood pump. Okay. In the heart per minutes. So you know that normal role is maintain the tissue perfusion. If it is changed in hypertension, what is going to due to the any stimulation, it is going to be changed. It can be rise. Stroke volume the same times. If there are any changes, what is the normal load? It is depend on the preload, afterload, and contractivity. So what is that? It must be okay. If it is not normalized, then again hypertension will take place. Then third one is heartbeats. So what are the heartbeats? Beats per minutes. That is going to affect cardiac output. Yes, that is all again often increase due to the sympathetic activities. If I talk about the peripheral vascular resistance, that is PVR, then what is their resistance blood encounters in the vessels? And that is what is their normal role? They regulate the blood pressure. And when it is not there, it is going to be increase in the hypertension. The last one, that is blood pressure. That is cardiac output is equal to peripheral vascular resistance. What they are together doing? Keeps all the organs good blood supply. If it is going to be disturbed, again the persistent height in the hypertension is going to take place. So these are the key terms which we must know about the hypertension. Then we have to know about the hemodynamic changes in the hypertension. What is there? The first one is increased peripheral resistance. What is that exactly? Excuse me, sir. The increased peripheral resistance, the arterioles, what they're doing, they're constrict and they becomes narrow. Okay. So due to that, there is the increased symptomatic nervous activities will be there, and endocortical dysfunctions will be there. Agitation second will be affected. That is leading to the higher BP. If I talk about the increased blood volume, what is there? It is also caused by excess sodium and water retention by kidneys. That is also known as RAS. You must understand from morning to till now what is RAS exactly. Okay. Then aldosterone overproduction will be then what is going to be happen? More fluid, then more pressure on the artery walls, and it is going to be increased preload. That is again increasing cardiac output, and BP is going to be increased. The third one is increased cardiac output. This is the early phase, we must say. What is going to happen? Especially in the younger hypertensive patient means जो यंग एज में है उनके साथ में ये ज्यादा होते हैं कार्डियक आउटपुट का, एंड ओवर टाइम the resistance takes over and the main problem arises, that is high BP. If we talk about the arterial stiffness, what is that? It is about the aging factors. Okay, diabetes and other disease condition, other inflammatory causes, loss of elasticity, these all coming together. In that case, the arteries are going to be stiffness, blood supply is not good, and again cardiac output going to be increased, and BP is going to be increased. So these are the causes. These are the processes where the blood pressure is going to be increased. Here is a hemodynamic formula. You can see that BP is equal to cardiac output is equal to peripheral vascular resistance, that is PVR, and CO stroke volume and heart rate. So this is how the process takes place. This is the same what I just explained, increased sympathetic nervous system activity. So stress or any chronic stimulation that is going to be increase the heart rate, that is going to be give the uncontrolled constricts of blood vessels, and the supply is going to be narrowing, and the narrowing supply is going to be leading with the high blood pressure. Again, if we talk about RAS, so these hormones, this is again increasing the sodium and water retention in the body, in the kidneys, then the narrowing the blood vessel again, then the raising blood pressure will be there. If we talk about the kidney dysfunction, again impaired kidney they retain more and more salt and water, and that is also going to be increased blood pressure. Okay. Then the next one is endothelial dysfunction. They damage the blood vessel lining, they reduce the nitric oxide, and they are again leading to the stiffness of the or narrowing of the blood vessels, capillaries, and then again it is leading to the blood pressure. If we talk about the genetic and environmental factors, definitely this diet, obesity, smoking, genetics are playing a very good role to be having a high blood pressure. So this is about the pathophysiology and the hemodynamic. Excuse me. I am audible, Rahul sir?
Yes, ma'am. Yes, ma'am.
Because I'm not able to see anyone. I'm only speaking and speaking. If anything is going wrong, please let me know in between.
Sure, ma'am.
दिस इज द पैथोफिजियोलॉजी. ये हम लोग बहुत अच्छे अच्छे से समझते हैं. So what is that? What is the trigger? Trigger are the causes. What can be the causes? They can be age, that can be stress, that can be genetic, that can be cold environment, that can be dietary things, that can be any type of disease. What is going to be do? It is changing in the arteriolar bed. What is this arteriolar bed? This is a systematic bed. What is bed? This is a smoothing of all the arteries, lining of the all the arteries and capillaries. Then what they are going to do? Systematic vascular resistance. Okay, what they are going to do? Systematic vascular resistance. When we talk about the changes in the arterial bed, so what is there? They are going to be weaken the arteries lining, and they are going to lose the elasticity. They are going to be constrict, and then again it is leading with the systematic vascular resistance. What happened with the systematic vascular resistance? Then these vessels increase the resistance in they become the narrow due to death. So when the capillaries bed are going to be decrease their capacity, again same thing is that the vascular resistance is going to be increased, and then the cardiac output is going to be increased. In that, when the cardiac output will also increase due to their system, then systolic and diastolic blood pressures will increase. So here this is one reason when we are getting the blood pressure. So what is that? The first one is when there is any cause and trigger behind that, then all the arteries and vessels are going to be constrict, and they are going to constrict, then systematic vascular resistance takes place, and it is increase the cardiac output, and the cardiac output lead to the high blood pressure. This is one thing. The second thing is peripheral resistance. When we talk about the peripheral resistance, due to the peripheral resistance, what is going? Then the same thing, narrowing of the blood vessels, and they are leading with the high BP. What is that? They decrease the blood flow. When they decrease the blood flow, they directly affect to all the organs, mainly to the kidney. When they are affecting to the kidney, what is happening over there? JJ cells, that is juxtaglomerular cells, they are going to secrete and stimulate the renin, and renin is going to be secrete RAS, and going to activate the RAS. When the RAS is going to be activated, what is going to be happen? RAS, from where RAS is secreted, please put in the chat box. Okay. So when it is going to be activate the RAS, then the RAS is going to be activate adenosine first, and that is going to be convert into adenosine second, and then it is going to be thinning of the arteries, directly constructing of the arteries and vessels, and then again increase aldosterone, and then it will be increasing the sodium and water retention, and the blood volume is going to be increased. In that case, peripheral resistance takes place, narrowing of the arteries and capillaries again takes place, and it is going to be increased blood pressure. So there are the two ways where our blood pressure is going to be increased. The first one is it is going to directly change the arterial blood and systematic vascular resistance, and the second one is it is going to be another part, that is peripheral resistance. So these are the pathologies of hypertension. It is same. The next one is genotype hypertension. Anyone can put what do you mean by genotype? Just till that I will take a sip of water. My slide is moving. Yes.
No, ma'am. Yes, yes. Just move.
Let me check by my side, please. Give me 1 second. From my side, it is not looking that it is moving. From your side, it is looking that it is moving, please.
Ma'am, it's moving.
Okay. So it is genotype and of hypertension is in this slide, yes? Rahul sir.
Hello. Yes, ma'am.
Sir, the slide is showing as a genotype or not?
Genotype is showing, ma'am.
Okay, okay. Thank you so much. So what is that genotypes? Genotypes are the variation of in our DNA and that can influence how our body regulate the blood pressure. And these variation affect our key system. What is that? They are affecting to RAS, they are affected to sympathetic nervous system, they are going to affect the kidney sodium handling, they are also affecting the vascular tone and the endothelial functions. So what are the major things? We'll see one by one. So yes, so there are the key genotypes, means genes variants which are directly linking to the hypertension. We talked about the first one, that is ACE gene. Okay, what is the role? The role is convert angiotensin 1 to the 2, and where it is located? Anyone in the chat box? Where it is located? Okay, chromosome 17. Okay, what they are controlling? They control the conversion of angiotensin 1 to the angiotensin 2. Okay, and then what they are doing? They are going to polymorphize the insertion of the delestrin and into the intron 16. So this is their work. So DD genotypes is liked with the higher AC level and it is leading to the vasoconstriction and salt retention, which is directly raising to the blood pressure. So what is the clinical relevance? You can see that they are going, these DD individuals may benefit more from the AC inhibitors and they interfere with the leoprsil. So these are the things which is related with the ACE genes. The next one is AGT genes. Then kindly put where it is located, anyone in the group. So what is the role? Produces antigenotensins, that is a part of the RAS pathway, and the variant is M2350. So what is that variant? That variant leads to the higher angiotensin level that increasing the blood pressure. What is that here? Then this TT genotypes is again adding in that, and this is going to be high rated the overactivation of the RAS, and that is strongly linked with the essential hypertensions, particularly in the females and black population. So that is also very much important. If it is not put it, this AGT gene is located on chromosome 1. The next one is alpha gene. So alpha gene adduction, the role is affect sodium transport in the kidney cells, that you can say that regulate sodium reabsorption in renal troubles. The morpholism is gly 460 TRP. Okay, so what is that? They are leading with the increased sodium reabsorption, that is the higher blood volume in the hypertension. What are the clinical sides? These patients benefit from the diuretics. So this is about the AD1 gene. If I talk about the fourth number, that is CYP11B2 gene, that is aldosterone synthase. What is the role? The products aldosterone which control the sodium and potassium balance. Okay, what is the morphology? 344C by T, that is the parametric variants. What they are doing? They increase the aldosterone, then they are going to be increased sodium and water retention, then it is increasing to the high blood pressure. And that also may predispose to primary aldosterone and resistance of the hypertension, we must say. If I talk about the fifth number, that is beta 2, what they are doing, beta 2 genes, what they are doing, they are involved with the vascular tone regulation of the via the epinephrine, and they are the variant that affect the response to the beta blockers. Then there are certain morphologisms are associated with the impaired vasodilation, so they are also very much important. The sixth one, if we talk about, that is GNB3 gene, that is G protein beta 3 subunit. What they are doing, they are going to affect the single transmission in the blood pressure control pathway, and they may also affect the diuretic response. So these are the things which are adapt. These are the key genes which are connected with the hypertension. Okay, kindly put why these genes are need to be understand in the nursing. So we'll discuss after this. So these are the summary of those genes. So ACE, what is their function? They are going to increase vasoconstriction. If we talk about AGT, what is their function? They also increase BP via RAS. They are giving effect, and they are clinically importance. What is that? They are linked with the essential hypertension. We talk about ADD1. So alpha adduction, increased sodium reabsorption is the effect, and the clinical importance is salt sensitive hypertension. If we talk about CYP11B2, so what they're affecting again the aldosterone, and they increase the fluid retention. And the last one, that is beta 2 adrenaline, they are going to be beta blocker sensitivity. So yes, this is the key points for the nurses, why we need to know about this gene system. So yes, as we are going with the history section, we are going with the family history. We have to know about the patients, their hypertension with the relatives, and what can be the risk for them. We have to go with the personalized treatment, such as specific drugs related with that, such as diuretics. We have to go with the salt sensitivity, education and prevention regarding the hypertension. So it was all about the genotypes. I hope you understood up to this. Next, we have to know about the epigenetics. Anyone, what is epigenetics in the chat box? Chat box, anything is coming? Let me check once. Good afternoon. Due to genes, very good. Caused heredity, very good. Very good, very good. Thank you. So answers are very less. Now we have to go with the epigenetics. What exactly this epigenetics is? Ma'am, आप ये paper ले लीजिए. After the class, I will. So we'll go with the epigenetics. Epigenetics is the study of how exactly the gene's activities is controlled without changing the DNA sequences. Okay. Or if we talk about in nursing, why it is important? So in nursing, it is helping us to how we just know how to understand the lifestyles factors can affect. So like diet, stress, smoking, and the environment, they are going to be turn on, turn on, turn off, turn off. So certain genes influencing disease development. That's why we need to know about the genes. So in that, I can say the hypertension, then epigenetic changes can affect the genes that are directly going to be involved with the blood pressure. Or if I talk about an example, so we can say that poor diet or stress may lead to the chemical changes like DNA methylation. What is that? That increase the blood pressure risk. And a nurse, being a nurse, we must understand that epigenetics is to promote healthy behavior, to educate to the patient, support to the preventive care, especially if I talk that those with the family history of chronic disease like hypertension, we need to support them. Okay, so this is about the epigenetics. So here, while genetics provides the blueprint, you can say the blueprint of epigenetic modifiers, how the blueprints read, often based on the environmental exposure. So yes, the environment and the genetics both are leading with our hypertension situation. So this is the definition, the study of reversible heritable changes in gene expressions, and that do not involve changes in the DNA sequences. The next one is that is DNA methylation. What is this DNA methylation? Anyone? in the chat box? No answer in the chat box. It is little bit tough topic. Rules are given. I think students are not also interested, so no answer is there. So what is that DNA methylation? And this is the lunch time also. That repress gene expression by adding methyl group to the, what is that? Cytosine residues. Okay, that is known as DNA methylation. If I talk about the histone modification, what they are doing? They are altering the, yes, they are altering the chromatin structure. Okay, and the non-coding RNA, what they are doing? They are such a mirror of RNAs which regulate mRNA stability and translation. So this is all about the mechanisms where it is going to take place. So here there are 4-5 points that are very important to understand. That epigenetics, this is a breeze between the genes and environment, very important, plays a very important key role in the blood pressure regulation. That epigenetics, okay. The lifestyle changes can reverse harmful epigenetics modification. And yes, we, the nurses, are playing a very vital role by providing and prevention of this hypertension, education, and the patient care. So these are the things we must know. If I talk about the modified risk factors. So what are the modified risk factors? Is still in the chat box, anyone? Yes. Modified risk factors can be, the first one is nutrition, my dear. Okay, in the nutrition, high fat, high salt diet we can reduce, so that we can, that is modifies. You can modify. So nutrition is the first one. The second one is psychological stress. Okay, so what is that here? You can control the psychological stress. The counseling can be there. Obesity, smoking, very good. Yes, obesity can be reduced. Smoking can be stopped. Very good, Jyoti. Sakshi Maurya lifestyle, fantastic. Yes, so these are the modifications, risk factors. We can modify. What is modification? That means what we, that the things which are in our control and we can modify it. So those are coming in the modified risk factors. Very important. Stress is there, psychological impacts are there, environmental exposure. Yes. Who will tell about the environmental exposure to me in the chat box? How you can modify? Along with the food restrictions, we will modify lifestyle. Very good, Chitranjan. Very good. So here, if we talk about the environment exposure, that also can be modified. So air pollution you can avoid, smoking you can avoid, endocrine disruption, chemicals areas you can avoid. So much of cool environment you can avoid. So you just go through with the what things you can modify. That will come in the modified. Okay. For example, epigenetic silencing of that's NOS genes reduce the nitric acid and production, and that is going to be dysfunction of the endothelial, then again the BP is going to be down. The next one is, if you talk about transgenerational effect. Anyone, what is that transgenerational effect? In the chat box. So I will understand people are with me. 50% went for food, along with food restricts. Yes, yes, yes. Direct message? No direct message. Okay, if you talk about the transgenerational effects, so what is that? Parental hypertension and lifestyle choices can affect the offspring's risk factor. Okay, so that is coming in the transgeneration effect. हम लोग बोलते हैं ना, हमारी दादी को डायबिटीज थी, बाबा को ब्लड प्रेशर था, वहां से चले आ रहे हैं, लाइक दिस है ना, हम लोग बात करते हैं आपस घर में. So like this transgeneration effects. What will be the nursing action on this? Anyone in the chat box? हम क्या कर सकते हैं being a nurse? What we can do in the clinical practice and in the education side? Anyone? So yes, in the clinical practice, we could have assess how we can tell them use of genomic info. We can inform them what about their histories. We can find out. We can screen them. We can tell them about the environmental factor. We can tell them about the modification factors. Due to masses, yes, educate about prevention. Dash diet, fantastic. Whoever answered, very good. Namrata Singh. Then patient education, we must clarify about the genetic and their own destiny in this hypertension. है ना, genetics के बारे में भी हमें जो जीन्स है ना उनका पर्टिकुलर फंक्शन भी हमें explain करना चाहिए. You know that maximum patients are well known about the things. You can explain very well. So lifestyle can be modified. Yes, empower self-care practices. Very important. You need to promote to the patient that how they can go with the self-care. This is also one thing nurses can do. Okay. Then we are just go with the individual risk factor. See, each and every individual is different. They have different risk factors. So along with that, you have to go with the individual risk profile. That can be also comes in the educational point of view. Yes, if we talk about the collaboration from the nurses, we can have some genomics, nutrition, and behavioral therapy sections with the patient, and we can modify the things, and we can prevent, we can minimize. Both things will come in the collaboration section. It, along with that, we must know about the ethical consideration, my dear nursing professionals. So confidentiality in genetic information is very important. That cannot be discussed openly, and that cannot be discussed without any high authority permission. So genetic is a biggest thing where you can go with the ethical issues. So please take care of that. If you are telling anything related with the genes, you must understand to whom, how, and where you are telling about this. And without permission, no need to explain about the genes. Non-discrimination in care of any type of delivery. See, if the things are taking places, delivery sections are there, and you started telling about genes, so problem will be there. बच्चा क्या हो रहा है उस पे फर्क नहीं पड़ेगा. Then genes के ऊपर there will be issues. So my dear professionals, when we talk, we must understand about the ethics whenever we are talking. So genes are the one very important part. So it was all about the epigenetic. I hope so. Yes. Though my last topic is phenotypes. Anyone in the chat box? What do you mean by phenotypes? See, why I'm talking about chat box? So I understood you are with me. I'm not alone. And please don't go with Google, because we are one-to-one interaction. There is no need of Google in between us. Yes. Phenotypes. Very nice. Someone given something to me. 3. Very good. Very good. Ruchi Gupta, physical characteristic, fantastic. Namrata Singh, physical appearance. You all are very intelligent. Then why are we are sitting here? Physical characteristics are same. Fantastic, my dear lovely professionals who joined today, and you are giving interaction to me. Thank you so much. Keep rocking and putting answer in between. Okay, thank you so much. Next, we'll move to the phenotypes. Exactly what is this phenotype? So that is the observable traits or characteristics. Yes. If we talk specially about the hypertension, it is referring to the clinical presentation, progression, and response to the treatment. And why it is important? It is important for the diagnosis, prognosis, and therapy section. Very good. Mainly maximum told me about the phenotype. So you understood what is phenotypes. It is based on the characteristics. If it is related with the hypertension, this phenotypes is definitely going to help and to understand different clinical patterns. What are the causes? What are the risk factors? How it is going to respond to the treatment among the individuals? About the along with the high blood pressure. So this all is coming in the phenotype. So I can say this is a really very important topic, that is phenotype. So here are some common hypertension phenotypes. The first one is essential, that is primary hypertension. So how many cases you can see in this section primary hypertension में कितना लोग आपको लगता है होना चाहिए? Phenotype means observed physical traits. Very nice. Tanya Singh, Divya Singh, physical appearance of genes, fantastic. Vibha Chaudhary means a like height, hair color. Oh, very good. हम तो भाई हाइपरटेंशन की बात कर रहे हैं, आप खूबसूरती की बात कर रहे हैं. Anyway, yes, all are correct answers. So primary maximum we are seeing 90 to 95% cases they are coming in the essential hypertension, and there is no identification needed. Okay, so identification is okay. Primary can be any cause हो सकता है. But if it is about the secondary, what can be the cause? There can be underlying causes such as renal disease, endocrine disorder. Okay, these can be associated with the secondary hypertension. The third one is white coat hypertension. How many knows about white coat hypertension? White coat hypertension. Doctors dear. Doctors dear, doctors fear. Okay, doctors fear. And cause. Okay, okay, very good. So white coat hypertension elevate BP in the clinical setting. हम लोग को भी देखते होता है. Why you are saying about doctors, nurses are also sometimes very dangerous. पहले से इतना सड़ा सा मुंह बना के आएंगे वार्ड में अपना दुखड़ा लेकर के कि पेशेंट को उसी से हाई बीपी बढ़ जाएगा. आज सिस्टर का मूड खराब है, आज मेडिसिन टाइम पे मिलेगा कि नहीं मिलेगा, खाने को आएगा कि नहीं आएगा. So, my dear professionals, see, whatever the tension and problems are the personal we are having with us, we need to keep those things when we are crossing our gate, means house gate. Everything inside the house can come with a smiley face to the clients because they are waiting for your care, and they are having lots of faith. They are fully depends upon you, that the nurses are really the heartbeat, the breath of the medical section, and we are the breath of the medical section. If we are going wrong, we are not giving proper instruction or proper response to the patient, where the patient will go. Okay, so not only doctors, nurses are also going playing a very vital role where they are giving the, yes, white coat, high BP. The next one is masked hypertension. Masked hypertension. How many knows about that? Masked hypertension. You also paying the two faces. If the senior doctor is coming, whether you are very angry, then also you will smile, isn't it? When the JRs are coming, then you are okay also, then you are playing a rude role. कि मुझे सर कुछ काम बता के ना चला जाए. That is masked hypertension. So what is exactly the masked hypertension, my dear listeners? In the clinic, the normal BP in the clinic. Okay. When they are going home, elevated BP is there. So that is masked hypertension. Mass hypertension is major. Doctor office BP is normal. Doctor office BP is normal. Okay, okay. See, don't go with Google. I'm telling you, हाँ. आपको जो समझ में आ रहा है वही आंसर करने का. Then it is very much the interaction will be very good. Okay. So yes, in the clinic the BP is normal. In the home the BP is high. The next one is resistance hypertension. What is that? BP remains high despite 3-4 medication देते जा रहा है, ट्रीटमेंट करते जा रहे हैं, but the BP is still there in the higher section. That is resistance. मतलब हिल नहीं रहे वहां से. The next one is isolated systolic hypertension. Okay, this is mainly common in the adults. So these are the common hypertension phenotypes you can see in the clinical settings, and I really sure that now you are going to be enjoy. And while seeing the hypertension, you will start thinking which type of hypertension, which type of phenotype hypertension is that. RH hypertension, it is a patient take 3 medication. Yes, okay. Very good, very good. You all are very intelligent. The next one we have to talk about the hemodynamic phenotypes. What is that? High cardiac output hypertension. This is often in the younger patients. Either you can say in the early stage of our life. If we talk about the high peripheral resistance hypertension, it is very common in the chronic disease. Okay, ma'am, you keep there. The volume dependent hypertension is often salt sensitive and it is directly related to the kidney. Easy to understand in a one line, I hope. The next one is epigenetic. कहाँ चले गए हम? Epigenetics and hypertension. So what is that? In the epigenetic, there are some modification. They are directly going to impact to the genes. And they are going to regulate vascular tone, renal sodium handling, hormonal system, that is a RAS. Okay. Then again, environmental stimulus, they are again causing to the epigenetic changes. And what they are going to do? They are again activating the vasoconstriction to the genes. They are again going to be the silence vasodilator, or sometimes it is saying that anti-inflammatory genes. So here it is the methylation of hypertension. ये मैं अभी आपको पहले भी explain कर चुकी हूँ, I think. Okay. So what is that here? So hypermethylation, what is that? ENOS genes, that is going to be decreased nitric oxide, that is going to be vasoconstriction, and this methylation of renal sodium transport genes, that is going with the salt retention. Again, together they are going to be increased blood pressure. So here you can see these my major. Let me shift this screen to here to there. Okay. So major phenotypes hypertension. It is a short summarized. You can say a picture. The phenotype is essential. The primary hypertension. What are the key features? There is no identification causes. What that is most common in the 90 to 95% cases. Secondary, it is treating the cause of can be resolved the BP. That can be any type of disease condition such as kidney, endocrine, like this. White coat hypertension, it is in the clinical setting, marked hypertension, resistance, malignant, isolated systolic. Then nocturnal hypertension, ये and salt sensitive आपको समझ में आ गया. Nocturnal hypertension is a higher BP at the night. ये छूट गया. So it is associated with the cardiovascular complication. This is a one screen picture where you just understand the phenotype of hypertension. And I hope you understand. You can put in the chat box if anything is missing in these phenotypes. Yes, anyone? And if you understood that, thank you so much. I will be very happy. So yes, at the last point of view, we must know the nursing implication of hypertension phenotype. So we need to assess. Assess is there. Okay. So assess blood BP patterns in various settings, clinical and home. We need to monitor the therapies, especially to the resistance and secondary cases of hypertension. We must educate to the patient, their family member about their lifestyle, how the impact of BP can go with the gene expressions. That also you need to be explained. You can be a very good advocate for the early screening of personalized intervention if the patient is there and you have an interest to explain and educate the person about the hypertension. And then if this phenotyping has to classify the hypertension for the better treatment. Yes, you understood with this type of this much of slided that it is really important. This phenotyping is very much important and it can provide a better treatment. And the link with environment hypertension, the prognosis, the pathogenesis can be differ. And we, the nurses, the professionals are having a keen role in the assessment of hypertension, prevention, education, and providing the holistic care. We are there and we are really playing an important role in the healthcare sector with this hypertension. So yes, nurses are always. If I summarize this so you all understand, the hypertension involved increase the vascular resistance, fluid resistance, then sodium increase, especially to the vasoconstrictions. They takes the increase the cardiac output. Again, the RAS activation is there, and finally they are going to be increase the blood pressure. And with the help of understanding the gene pattern, their risk factor and the modifications, the nurses can help to the patient or the clients in this clinical setting and nearby their society. So thank you so much for having patience. If you have any query, you can put in my mail ID because I am going to the next section. Thank you so much, my dear participants, my colleagues, my students, my fantastic professionals for being the part of such wonderful day. Today is a hypertension day. And please balance your BP. Don't increase your BP in any type of situation in environment. And we the nurses, we need to be numb, we need to be calm, we need to be associated with the all healthcare worker. So we are the collaborate, we are working as a collaboration. We do a collaborative work. So when you are working with different type of personalities in the clinical setting and other community area, the workplace can be anything. You can be in community area, you can be in the clinic, you can be in the foreign, you can be in Indian, you can be central government, you can be a private hospitals, but the peoples are like same. Okay, the associations are like same. So we need to be very calm and understanding. We need to manage our understanding. We need to understand the situation of the person who is standing in front of me, either the patient who came are having lots of faith on the nursing personals, and you are having a high BP. So we need to also maintain our BP with the love and regards. Thank you so much, everyone, for joining me. Thank you, the Ruma management, to inviting me, and I really feel good to be part of this. Thank you. Take care. Bye bye. May I stop the sharing, Rahul sir?
Yes, yes, ma'am. Thank you so much, ma'am. Very nice presented, ma'am, this topic. It was really good, ma'am.
Thank you so much, ma'am, for the insightful session. Now we are excited to the next part of our program, featuring more knowledgeable speakers to enlighten us with their. We now move forward with our panel session led by a highly professional in the field of neuronursing and public health. We are truly honored to welcome Dr. Gopi Chandran sir, PhD nursing assistant professor and consultant in neuronursing NIMHANS, Bangalore, whose extensive expertise and contributions in hypertension management are widely recognized. Sir is accompanying with Mrs. Latasha ma'am. She is PhD scholar, Department of Nursing, NIMHANS, Bangalore, known for her research-driven approach and commitment to advising healthcare practices. Dr. Gopi Chandan sir has over 20 years of experience in nursing education, research, and clinical practice, having served in esteemed institutions such as AIMS, New Delhi, and TAIF University in Saudi Arabia. He has led pioneering work in nurse-led management of neuropsychiatric disorder, digital health, including AI-based apps and telenursing, trauma care, and quality management in healthcare. He is former president of the TNAI Delhi branch and the founder president of Society of Cardiac Nurses India. He also served as a NABH assessor. Dr. Gopi Chandan sir has developed mobile applications such as Dhadkan 2 to support heart failure management and improve palliative care perception adherence. His contribution has been recognized internationally and nationally. He received honors from National Association of Indian Nurses of America and the National E-Governments Award from Government of India. He has authored over 60 publications, including 43 in indexed journals. Contributed chapters to Investigator. He has led 17 research projects, including ICMR funded studies on palliative care and the mental health impact of COVID-19. Dr. Gopi Chandan sir has provided academic mentorship, having guided more than 60 MSc nursing theses. His areas of focus also include nursing leadership and healthcare qualities improvement. Additionally, he is certificately trainer of BLS, ACLS, and advanced trauma care nursing. Please share slide of Mrs. Natasha ma'am. We welcome you, sir. Over to you, sir.
Yeah, thank you very much. I think Ruma, thanks for the invitations from Ruma, and am I audible?
Yes, sir. Yes, you are
Yeah,
audible,
yeah.
sir.
It's a really great to connect with you all today. But first of all, I congratulate the Ruma Institute for organizing this such a wonderful topic, which will be it's going to be sensitize the nurses and many of them who are attending it on the control of the hypertension. I'm just to go small intro about this topic, but Latasha, my PhD scholar, who is be the coordinator of this our stroke management program. She'll be the forwarding this, continue with this session. I think I worked a lot in in this cardiac area, especially in at AIMS Delhi, which will be in mostly I was worked in heart failure patient management. I developed the app, which I understood that today the patient is not with only chronic diseases, which we are already discussed or we are already aware about it, so either cardiac or a renal problem or a hepatic problem. They mostly go with multiple comorbidities, especially with hypertension and diabetic and lipid problems. But the hypertension is still it is well masked as compared with any other disease. We rule out very late stages. Sometimes we may not aware that when the patient admitted with a cardiac disease like MI or stroke, that time we come to know the patient maybe have be known care, maybe the it was hypertension was reported, or patient sometime maybe not managed the hypertensions, may not due to the improper or poor medication adherence, they may landed into this cardiac problem or neurological problem like stroke. So that way we understood that it's not only the the disease which will be suffering with the elderly people. It is even with the children's, even early hypertension is very possible. And also uncontrolled hypertensions or mismanagement is really, it's great worries. That's why the heart initiative is the one by WHO, it was initiated to sensitize that how early diagnosis, early management, and early preventions and control the hypertension is the really today the key, or maybe the the very important goal or objective to manage the hypertension. For that, how to strengthen our policies, especially low middle income countries. That's very very important, because we are not developed countries, we are developing countries. India is the fourth strongest country. Today we are emerging as a developed country, but GDP still individually is comparatively less. That's why we have become 132 country. By in economically is individually how we are economically sounded, but in overall GDP India is growing very well. But that what means that we are economically not is coming up, same like our healthcare is coming up. In that way, primary healthcare is the most important, where equally accessible healthcare for everyone. The equal accessible is not only the managing the the emergency situations, especially for chronic diseases, especially for the diseases which killing the disease, populations. If you say MI is the killing disease, comparatively number one disease which is the highest mortality and morbidities, and next you can say stroke or many other diseases. In that way, these diseases commonly happen is compared to any other problems, other etiologies. Most common etiology is a comorbidities, is a hypertension and diabetic, where the patients may get into MI or maybe the stroke. So for that, we need to be yearly access, means yearly diagnosis by it is called primary, secondary, tertiary preventions. Yearly diagnosis or yearly symptom or yearly awareness, means recognition of the disease, that really make the differences in the patient's outcome, especially mortality, morbidities, and also the quality of life, and also the patients they prevent the many complications, and that you all aware about it. So for that, it's not only the managing by the patients, by the medical professionals, and also it's a multidisciplinary approach where the nurses, everybody involved, and public health is a very great concern. So that's what we nurses need to be today aware about this, how important to understand this early diagnosis of hypertension and manage the patients. This webinar definitely going to be give eye opening for everyone across the India, where they can understand today overall, and and especially the heart initiative by WHO, we are really going to be sensitized to everyone. And with that, I would like to congratulate the team, and also continue with the Latasha her presentations. And I will possible I can be also conclude if anything be required. Thank you once again for the team. I over to Latasha to continue. Thank you, Latasha. Latasha, are you there? I hope.
Yes, sir. Yes.
Thank you so much, sir. Thank you.
Thank you, sir. Just give me a moment to share my slides. Now we have Mrs. Latasha Ma'am, PhD Scholar, Department of Nursing, NIMHANS, Bangalore. She will be coordinating Dr. Gopichandran Sir. Ma'am is known for her research-driven approach and commitment to advancing health care practices. Mrs. Latasha Ma'am is currently pursuing a PhD in neuropsychiatric nursing at the Department of Nursing, NIMHANS. She has completed her MSc Nursing in Psychiatric Nursing from NIMHANS. She has previously worked as a nursing officer in the Orthopedic Operation Theatre at AIIMS, New Delhi. She has a total of 3 years and 8 months of professional experience in the nursing field. Over to you, ma'am.
Thank you. So my topic is hypertension control, the heart initiative given by the WHO and the CDC. So there are a lot of non-communicable diseases. Then anybody can tell me why we have chosen hypertension for the control and why the WHO is paying so much attention for the hypertension. Can anybody answer for that? Apart from all the non-communicable diseases, why we are focusing more on the hypertension? No one? Okay. You all know about the mortality ratio in our country or worldwide. So what are the health condition which is contributing more to the mortality? Which group of conditions are contributing to more to the mortality rates of our country? Anyone? Am I audible? Am I audible?
Yes, ma'am. Yes, ma'am.
Okay. So I think I am only going to answer my questions because nobody is answering. So when it comes to hypertension, yeah, somebody has answered that the cardiac cases mostly. So the most fatality, or we can say the most mortality, it is contributing by the cardiovascular diseases. And what is the risk factor for most of the cardiovascular diseases is hypertension. That's why we are more focused on the hypertension. So this is the answer what I wanted to listen from you. So I'm going to start my topic, which is hypertension control given by the heart initiative. So 1 minute. Okay, so what is hypertension? I know everybody knows about it, but I will just give a small introduction about it. So in general public, when we are talking what is hypertension, so high blood pressure, which is also known as hypertension, occurs when the force of blood flowing through the blood vessel is consistently too high. So this definition does not give the actual meaning of how much should be too high or too low. So the next definition given by the WHO 2024, they told that hypertension is defined as having systolic blood pressure more than or equal to 140 mm of Hg or diastolic blood pressure more than or equal to 90 mm of Hg, which is given by WHO. Apart from that, the AHA, that is American Heart Association 2023, defined as hypertension is diagnosed when systolic and diastolic blood pressure is consistently more than or equal to 130 and more than or equal to 90 mm of Hg. When this is the hypertension ratio, we can say that it is hypertension, which is given by AHA 2023. AHA also have classified the hypertension into different categories. So sometimes we are confused that if a person is having a blood pressure of 135, as per the definition, it is high blood pressure. But as per the definition of WHO, it is 140. So can we say that 135 by 85 mm of Hg is hypertension or not? Can anybody answer that? If a person is having a blood pressure of 135 by 85 mm of Hg, either it is hypertension or not, pre-hypertensive stage, or we can say that it is elevated, but it not complete the criteria of high blood pressure. And that too, it's not even in the single reading. Whenever you are taking the blood pressure, it should, how many readings are required to diagnose as hypertension? How many readings? 3 readings. Okay, whenever we are diagnosing the hypertension, 3 constant readings should be higher than the given value. Then we can say it is hypertension. So as per the AHA, it is given in 2023 that if a blood pressure, systolic blood pressure is less than 120 mg or equal to 120 mm of Hg, and diastolic is less than 80 mmHg or equal to 80 mm of Hg, we will say it is normal. But in some conditions, like what we are doing exercises, or we may be stressed or something, then that time also our heart rate increases, our BP increases, but that time we cannot say it is high blood pressure. So it is called elevated. So how much it can be considered in the category of elevated, which is 120 to 129 mm of Fg systolic, and diastolic less than 80 mm of Hg. So when high blood pressure, there are three stages: hypertension stage 1, stage 2, and stage 3, which is hypertensive crisis. So when it is stage 1, we are talking about, it is 130 to 139, but less than 140. You can see here. So in diastolic, which is 80 to 89 mm of Hg, but not 90. So when we will say high blood pressure, stage 2, 140 or higher, which will be calling us in the first stage, and then 90 or higher, the diastolic blood pressure. So what is the difference between the stage 1 and stage 2? In the stage 1, with minimum intervention, it can be controlled. Suppose the person is resting, or low doses of drug is required. But when the person enters into the stage 2, the person requires the regular drug therapy. And hypertensive crisis, you all know that it's a life-threatening condition. So when it is called hypertensive crisis, when the BP is more than 180 mm of Hg in the systolic, and then the diastolic more than 120 mm of Hg. Okay, then what is we will be seeing some ratio. I think it is like eye-opening ratio. You will be seeing that what is the statistics of hypertension in India or worldwide. So WHO Global Report of Hypertension in 2023 estimated that the number of hypertensive adults almost doubled globally. So you can see that during the last 3 decades, from 650 million in 1990, now it became 1.3 billion adults by 2019. Still it is 2019. But we will see the impact of that. The health impact of increasing trends of high blood pressure translate to 10.8 million. You can see that how whatever I did in the different color, which is important to remember. So 10.8 million avoidable deaths annually, and 235 million years of life lost or lived with disability. You can see that either the prevalence of hypertension is very high. Apart from that, how it is affecting your life, you will not be able to be as much as active or can live your life or enjoy your life as you were pre-morbidly enjoying. So that you can see that lost the life or lived with the disability. In India it is more. In India, the estimated incidence of hypertension in 2024 is around 30.7, meaning that every third adult is hypertensive. Despite the high prevalence awareness, this is the research done by Mohammed and Bansoor 2025. It's a recent research which is showing this eye-opening stats, which is they also find out that despite the high prevalence, the awareness and treatment rates are relatively very low. So you all know that the iceberg phenomena, which is very famous, and it is exactly fits for the hypertension. So we all can say that whenever it comes to the iceberg phenomena, you will be seeing that very less people will come with the complaint of hypertension and taking regular therapy. Most of them will not be diagnosed for their life, and they will be living with that. So and sometimes the heart attacks are nowadays, it is very common. This is the reason, because people are not taking proper treatment, because the awareness is very less. So why this is more in India? Can anybody tell me what kind of obesity is found in India? Like different kind of obesities are there, no? So you will be seeing in India that truncal obesity are more, or central obesity is more. Okay, can anybody tell me what is central obesity? Anyone? What is central obesity? Okay, so central obesity, you will be seeing mostly Indian people, in male most commonly. You will be seeing that the belly fat is there, but if you will seeing that their hands and legs are thin. So that is called central obesity, where the belly fat is there, and that is more the cholesterol is collecting. All this is more important for most risk factor for the hypertension. That's why in Indian people, we are having more type of problem. Then what are the risk factors for hypertension? If we are talking about the controlling hypertension, then we should be aware about the risk factor of the hypertension. So there are two types of risk factor, modifiable risk factor and non-modifiable risk factor. That's why the control is important. If there are only non-modifiable risk factor, means we cannot control it. Only prevention was possible. But here we can prevent also and we can control also by focusing on this risk factors. So what are the modifiable risk factors? Body weight. Can anybody tell me how the body weight is contributing to or obesity is contributing to hypertension? What is the reason?
Students are giving answer in chat box.
But I'm not able to see. Last answer I'm able to see is belly fat.
Belly fat. Yes.
Okay, so body weight, how it is contributing. So everybody knows that that our body, like heart pumps the blood and it reaches to all part of the body. Okay, based on the oxygen and nutrient requirement of our body parts. So when it comes to the obesity, a person who is obese means the body tissues are more. Body tissues are more means the oxygen demand will be more. So when the oxygen demand will be more, so heart has to work more and pump more blood, which will be increasing pressure on the walls of the arteries. And continuously, if it goes like this, means the artery walls will become weakened, and sometimes that it will dilate also. So sorry, it will become the stiffen, and because of the stiffness, the vasoconstriction will be there. Consistent vasoconstriction can lead to high blood pressure. So that is the reason that why obesity is a risk factor for the diabetes, or why the obese people are mostly having the diabetes, cardiovascular disorders and hypertension. Then it comes to the salt intake. So everybody knows that the salt has the function of restoring water in our body. Okay, so whenever the salt is more, but it means like one molecule of sodium contains 4 molecules of water. Okay, so you can see that if you are eating more salty products or more salty food, so 4 times more, how much amount of salt you are eating, 4 times more than the water will be collected in your body. So if more water is in the body, means the more fluid will be there in the bloodstream. And that much fluid in the bloodstream is there means the body has to work more to flow, like smoothly flowing that blood or fluid volume. So that way also it is putting a lot of pressure on the walls of arteries or heart, which will be activating the RAS system and increasing the blood pressure. So that is why the salt intake we have to limit. Okay, later on I will be talking how much we need to take and how much we need to avoid. Then smoking in any condition, it is it is harming only, but still people are smoking, and it's increasing nowadays. Even the women's are smoking. Previously it was only for the males this risk factor is responsible. Nowadays we can see that the females are also doing that. So how the smoking is affecting your blood vessels. So whenever the person is smoking, so due to the smoke, that blood vessels become constrict and the vascular resistance increases, which will put again the pressure on the blood vessels and increasing the blood pressure. And for the prolonged time, if you are using it, it will be affecting the walls of the arteries, and again it is affecting the heart also. And if you know that if the person who is smoking, the lung capacity will be less compared to the person who is not smoking, the lung capacity will be less. So oxygen already less, which will be again increasing the oxygen demand also. So it will be increasing the blood pressure. Exercise, here I am not telling to not to do the exercise here I mean this physical inactivity, the person those who are not doing the exercises. Okay, so physical inactivity, sedentary life makes the blood vessels weaker or our heart weaker, because the person is sitting only and that not doing workout or anything. So later on the obesity increases because of the not exercising, then it later increase to the blood pressure. Then non-modifiable risk factor, so which we cannot modify and which cannot work on, but we should be aware about it. If we should take necessary precaution on the time. That's why the non-modifiable, because you may be thinking that modifiable is important as we can change or prevent or control, but why non-modifiable factors are important when we cannot modify the factors. We cannot modify the factors, but we can reduce the risk if we are taking the necessary precaution at the time. So age. So it's called that as the age increases, the blood pressure also increases. The problem of hypertension is also increases with the age, because with the age the elasticity of the blood vessels is lost, and because of that it becomes stiff. And again, if the stiffness is there, vasoconstriction is there, the pressure for blood to flow will be more. That is blood pressure. So with the age it is increasing. Genetics. Already ma'am has talked, Dr. Dipti ma'am has talked a lot about the genetics, so I'm not going to deal more about it, but genetics is a factor. If one or other parent is having the genetic traits of having the blood pressure, or one or both parent are having the hypertension, the history of hypertension, then the offspring also has a chance of having the hypertension. So there are the different type of genes involved in this, like alpha abducin. Okay, then nitriuretic peptide genes. All these genes are, and aldosterone synthetase genes. All these genes are for what they are doing. They are present in your blood and making you more prone to get the hypertension. And then ethnicity. So mostly the black Caribbean people are more susceptible to get the hypertension. And sex, if we are talking about the sex, so if we are comparing through the age, so more the males have more chances of having the early onset of hypertension. So we can see in males that after 40 to 45 years of age, male will start having the more cases of hypertension. We can see in males by around 40 to 45 years of age. But when it comes to the female, we will be seeing that around the menopause, they will be we are seeing more cases of hypertension. So that it differs from the sex. Next is, what is heart initiative? So I have given a brief intro about the hypertension and what are the risk factor of hypertension. So whenever it comes to the hypertension, what the heart initiative has thought about it. Okay. What the heart initiative has thought about it. So when the risk factors are there, whenever we are talking about the hypertension, we need to focus on the risk factor. So we identified that WHO has identified that if we are focusing on the modifiable risk factor, we can prevent and also we can control, reduce the prevalence of hypertension. So they have given an initiative keeping in mind that by 2030, the cases of hypertension will be reduced by 1/3. So this is the heart initiative. The full form of the heart initiative is not a traditional acronym where each word means something, but here that each word has each component, the key component of the heart initiative which is the form of the foundation of the cardiovascular diseases management and packages. So here I'm going to ask you later, so you just pay attention. So here that HEARTS, the letter stand for a key component, which is H is healthy lifestyle counseling. In healthy lifestyle, a lot of things will come like smoking cessation, like that dietary management, that DASH diet and other things. We can enjoy salt intake. We have to limit alcohol in moderation, exercising regularly. So all these things will come in the healthy lifestyle counseling. We will be seeing in the detail. Evidence-based treatment protocol. Every field people, the researchers are doing some researches and they are finding some evidence. Based on that only, our day-to-day practice, clinical practice is changing. So there are they are doing continuous research and they find out something, some protocol, some evidence-based practices. Okay, so based on that, the treatment protocols are made, which we need to follow as a nurses. Access to essential medicines and technologies. So okay, the protocols are there that with this medication we need to give, but the medication should be there. If the medicine we do not have, or the technologies need to diagnose the blood pressure, like BP apparatus should be there, and also BP monitor should be there. All these things are not there. Sometimes we do invasive BP monitoring also. So all these technologies we need. Okay, so all these technologies we need. So here the essential medicine, it should be accessible. Okay, mostly in the rural area it is there, but it's not accessible to them. Okay, so that we have to see. risk-based CVT management. So cardiovascular disease management we should be doing on the risk-based. All of you know, I think, about the triages. Okay, so when the emergency situation happens or disaster situation happens, we will do triaging based on the colors. Okay, here also similar to that, risk-based CVD management means we will be identifying, suppose one person is the risk of less than 10%, another person is risk of more than 40%. So we will be focusing on the person who is more on the risk. Like that, the risk-based CVD management, there are different protocols will be there. We need to focus on that. Next is the team-based care. Team-based care means, suppose many PH sometimes doctors are not coming, sometimes nurses are not available there, enough staff is not there. Because of that, they are not able to provide the proper care. So that team based care need to be given. Okay, each team member has different role in healthcare team. So what that we will see. And systems for monitoring. Okay, so different systems for monitoring are there. Like we have to apply implement at the PHC level, we have to start at PHC, and higher level we have to. So what are the monitoring levels we have to see here? So what is the goal, or we can say that generalized aim for like introducing this heart initiative? Okay, together these pillars aim to improve cardiovascular health through comprehensive, standardized, and scalable intervention. Scalable means measurable. Okay, so if you have worked from here to here, we can say that okay, 30% work is done, or we are able to control this much. Means scalable means the mortality rate with due to the CVD was 100%. Okay, but after doing all this intervention, we are able to bring it to 50%. Okay, so that 50% difference is scalable. So like that, we need to provide the scalable intervention in primary healthcare setting. The most target population is we have to start from the primary healthcare. Okay, so when the heart initiative was launched globally, okay, it is globally launched by the WHO and CDC. Okay, so the WHO has launched in the Global Heart Initiative was officially launched on September 15, 2016. Okay, by the World Health Organization and US Centers for Disease Control and Prevention to support the government in strengthening the prevention and control of cardiovascular diseases. It is not only talking about the control of cardiovascular diseases, but also the prevention. That's why we are more focusing on the risk factors. The initiative aimed to reduce the premature deaths. Okay, because I told many times the hypertension is not diagnosed, it becomes in a like cardiovascular disease and the patient dies. So we need to reduce the premature death from heart attacks and stroke by promoting evidence-based intervention for both the prevention and management of the CVDs. This is the aim. I'm going to ask question like at the end of my session. So listen carefully. Okay, then what is the heart initiative in India? Okay, that we have seen globally, it is like introduced. So when is there something like that in India? In India, no, officially it is not heart initiative. The part of that package is introduced in India. So a key component of the heart initiative in India is the India Hypertension Control Initiative, that is IHCI, which is launched in November 2017. After the Global Heart Initiative in November, after 1 year, November 2017, the IHCI introduced in India. This program aimed to strengthen hypertension management and control in public sector health facilities by adopting the WHO's heart technical packages. Then what is the focus of this IHCI? Okay, as you all can understand that mainly we want to reduce the prevalence of hypertension. Then what we need to do is implementing standardized treatment protocol for hypertension. For there are some SOPs. SOPs is standard operating protocols which will be need to be done. Suppose you know that in the situation of code blue, what we are doing, when to initiate the CPR, till how many minutes we have to do, it's globally. It is globally same. Okay, like that for hypertension control also, there are some SOPs are there that we need to follow. Ensuring a regular and uninterrupted supply of medications and validated blood pressure monitors, that I have told you that sometimes that the government is providing the drug supply or medication supply, but it is not reaching to the patients. Promoting team-based care and task sharing among healthcare providers. Sometimes what happens is that due to the lack of staff, okay, so sometimes it is not manageable. Okay, so we have to promote the team-based care, and task sharing should be there. If the ASHA worker is not there, then whoever is there, we need to take charge of their work. So if that way we are doing it, we are trying to do task sharing, then the better care can be provided to the patient. Providing patient-centered care. Okay, mostly what people are doing nowadays, that a patient is coming, okay, we are treating them on the symptom based, but the symptom based treatment doesn't give the satisfaction to the patient or to the treating doctor. But due to the huge number of patients standing in a queue, we will be treating them like that. But we need to focus on patient-centered care, how a patient is feeling. Suppose two patients of hypertension are coming to you, one may be having different symptom and another having different symptoms, okay, but you cannot say that both are not having hypertension, they are having something else. Sometimes it is true, but we need to focus individually. So that's called individualized treatment or patient centered care. And we always say in nursing that we need to focus on the patient, not on the symptoms. Establishing information system for continuous real time monitoring. There are some app available, okay, and that nowadays the health records are digitalizing. So based on that, we need to do the real time monitoring. These efforts, why we are doing that IHCI in India is, these efforts are integrated into India's broader public health framework, including health and wellness center, sub-center, to enhance the accessibility and continuity of care. If you will be seeing in rural areas, there is still now nobody is knowing about what is hypertension. If you are asking, that much awareness they are lacking. So that's why it is starting from the ground level. So what are the components of the heart packages? Okay, so as I have shown you the 6 component, in each one we will be seeing in detail. So first is the healthy lifestyle counseling. So it provides the guidance on promoting healthy behavior such as tobacco cessation, balanced diets, regular physical activity, and moderation in alcohol consumption. All these things we have to tell. In detail we will be seeing. It will that reduce the modifiable risk factor. What is the objective of focusing on healthy lifestyle counseling, which is the first letter of the heart initiative? Reduce modifiable risk factor like tobacco use, poor diet, physical inactivity, and harmful alcohol uses, which this we have to focus. So the key component is tobacco cessation. So if you will go and tell there and to the patient, don't do smoking or don't cheap tobacco, will they listen to you? Have you tried in community doing that? You are telling them not to cheap tobacco or don't do smoking. Will they listen to you? Okay, so you are going to good people, they are listening to you. But what I have faced is many times if we are talking to them, they will say in front of us that, okay, we will do like that, because in IMHANS we have de-addiction center also. So a lot of patient comes here, they will be stopping all this tobacco and alcohol when they are here, because they will be getting the anti-craving medications and other things. They will be stopping at the time. But within 2 or 3 months, the relapse happen and they will come here again. Why? Because there is no one to motivate them, and no one is there to teach them how to manage the stress. Okay, so only few people will start doing the smoking and other things for the like enjoyment or the pleasure. Okay, many people start taking in the pleasure for the pleasure or enjoyment, and end up having all those things in the time of stress also. And they will say that if we are not smoking, I will not feel the stress is so much stress is there. That's why I had alcohol. So that is not the solution. That is a maladaptive coping. So in the healthy lifestyle, we have to teach them what are the healthy techniques, like physical activity. You need to focus on the gym. Okay, exercises you can do, regular exercises, which will help you to maintain the manage with your stress. That we have to tell them. So that is tobacco cessation. Diet counseling. What kind of diet we need to give in hypertension? Somebody has mentioned DASH diet. Can anybody elaborate on it? What is DASH diet? Full form of it, DASH diet. What is DASH diet? DASH. Somebody has written in the last session I have seen. Okay, that is on you only. DASH diet. It is given for hypertensive people, but I want to know the full form from you people. If you can write, it's good. So, okay, the diet approach to stop hypertension. Okay, so we will be giving this diet to different peoples. Okay, the people with hypertension. So how our diet should be? I have given a picture. You can see here that a food pyramid is there. Whenever we are giving a diet, okay, if a person is having hypertension, then we will be giving the dash diet. If a person is not having hypertension, but he is in a risk of having hypertension, then we have to tell the food pyramid how much amount of food should be there in the like balanced diet of diet to a person. So based on the calorie requirement, carbs should be the 70% of the food. Okay, that we have to tell. That you can say the broader part of the triangle is carbs. Okay, nowadays a lot of people are doing keto diet and other things, and they are leaving the carbs. But carbs are more important, but which is giving you energy. And then fiber. Fiber you need to have for the vitamins, fruits and vegetables you have to take for the vitamins or other essential nutrients and fibers. Protein is also important for our body, and fat need to be taken in very little amount, and that to be good fat, not like what is showing in the picture, like french fries and cheese. Not all those things. We have to take the good fat, like that vegetable oils we can take, and also like regular oils what we are taking. We can take in limited amount ghee. All these things we need to take. So like that we have to explain to the dietary counseling to the patient. Physical activity, we have to tell alcohol in moderation. Why I'm not telling to stop the alcohol? Okay, but smoking I am telling to stop immediately. Smoking is affecting in various way. I am not saying that alcohol is not affecting, but when we are focusing on the alcohol, compared to this, alcohol moderation is okay. Like in once in a year they are having or like that, it is okay. But need to be taken. That can be considered, but tobacco cessation need to be done immediately. And a stress reduction. Why they are using all this tobacco, alcohol, and other substance abuse? Because of not able to manage their stress. So like some exercises are their meditation, we have to tell them. Mindfulness, we have to focus on. Mindfulness is like whatever you are doing, you need to focus on that. Like if you're doing a deep breathing exercises, you need to focus on your breathing pattern. That is called mindfulness. Okay, so that mindfulness therapies and other things we can tell patient. So what is the approach? How you will achieve it? How you will implement it? So it should be the counseling or the lifestyle counseling point need to be delivered during the patient visit. When you are working in a PHC, like as a CHO you are working, patient coming to you, that time while patient are coming for the visits, you need to explain all those things. If the patient in the risk of hypertension or already having a hypertension, then group session we need to conduct as a ASHA worker. They can conduct the group session through community outreach by ASHA and nurses. So these are the thing we need to do to achieve the first heart initiative point, which is healthy lifestyle. Okay. Then we come to the second thing, which is evidence-based treatment protocols. So when it comes to the evidence-based treatment protocol, why we are focusing, with what objective we are working on it? Ensure consistent, safe, and effective treatment of hypertension and related condition using simplified, standardized protocol. Okay, like we have to focus on. Suppose what happens is in the villages and all, the people are working. Sometimes they don't follow the standard protocol, so we are not able to monitor them. So because of that, if each globally or like nationally we are following, nationwide we are following the same methods, mean it is easy for everybody to adapt it. Okay, so that's what we are focusing on, evidence-based nursing care or evidence-based treatment protocols. So standardized regimens. Okay, standardized regimens means if a patient with hypertension is coming to you, what are the immediate drug you are going to give? So what is the first line treatment for hypertensive patient? Can anybody tell me? What is the first line treatment for hypertensive patient? What kind of drug, what kind of antihypertensive drug you will be giving as a first line treatment, and why? Anybody knows that? Not a diuretic, but a good try. Vasodilators, metoprolol. Okay. So this is the right answer. Amlodipine, calcium channel blockers. Okay, so what are the drugs we are giving? Calcium channel blockers. What is the reason behind it? Calcium channel blockers are the drug which will give the most immediate effect. And in among calcium channel blocker is also amlodipine is useful. As per the WHO guidelines, amlodipine is most useful drug which will be showing the immediate action. Okay, so that's why we are giving the calcium channel blocker. Other reasons are it is suitable for the older age people also. When the person are with hypertension are coming to you with old age patient, you cannot give any like other drugs like ARBs and ACEs. That time you will be preferring calcium channel blockers. Okay, apart from that, what is the most common side effect of calcium channel blocker, which will be most commonly seen? Calcium channel blocker, most common side effect you will be seeing in clinical conditions. Dry cough. Okay, dry cough is the most common condition. That's why in giving in COPD patient is difficult. Calcium channel blockers. Okay, so in that condition, sorry, ACE. Sorry, I asked the wrong question. AC inhibitors. Most common side effect is dry cough. So that's why when the person is not tolerable to ACE, we can give calcium channel blockers. Okay, so that is the standardized regimen, first line treatment. What is the second line treatment? Second line treatment is ACE and ARBs. In the combination, we will be giving, along with the calcium channel blockers, we will be giving ACE and ARB. That is the second line treatment. So everybody, if we are making it a standardized regimen, so everybody need to like able to provide the same kind of treatment at the same level. Combination therapies. Why we need the combination therapy? Sometimes what we are giving, so we are giving one drug, only talmisartan we are giving. Okay, other drugs we are not giving. So person's BP is, it's not uncontrolled BP is there. So in that condition, sometimes some patient requires the drug to be given in more than one hypertensive drug is required. In that condition, what we will do, we will be giving the combination therapies. Why? Because if the person is having like severe hypertension, in that condition, what happens is, if you are giving single drug, it is not controllable. And if you are increasing the dose, you can see the side effects. So here what we will do, 2 or 3 drugs we are giving in lower doses so that blood pressure is also controlled and no much side effect can be seen. That is called combination therapies, which is suggested by the researchers that if we are doing like that, we can see more like consistent and safe like hypertensive outcome we are able to see. Next is the clear clinical pathways. Clear clinical pathways are that picture should be given that what kind of like treatment we need to give. I have given the explanation of standardized regimen, that how to focus on that. And apart from that, if the patient with hypertensive crisis has come to you, that time you are not going to give the amlodipine or some other drug, metoprolol and labetalol, all these drugs given in the condition of this one hypertensive crisis. So that clear guideline should be there, so nobody need to be confused between the drugs or what is the immediate treatment to be given. Training for frontline workers. How the all people like A&M nurses, GNM, BSc, and all levels, they will be having this knowledge because we need to train them. Okay, so training is most important. How we can achieve this using the approach of local adaptation of WHO protocols. Usually, you will be seeing at the level of tertiary hospital, we are adopting the protocols. But if we will start adopting from the primary healthcare level only, then it will be easy for everywhere to be introduce the same kind of treatment. Next is integrated into India's NPCDCS program. So what is that? That is the national program for national program and control program for prevention and control of cancer, diabetes, cardiovascular and stroke diseases. All these non-communicable diseases need to be controlled. That is a program which is going on in India. So in that also we can integrate and achieve this objective. Next is the access to essential medicine and technology. So ensure continuous availability of key medicine. Okay, I have told you that these are the medication you need to give if this condition of patient comes to you. Okay, but if you don't have medication, you can't do anything. And if you are not having the diagnostic tool, you will not come to know that what is the level of hypertension patient is having. So that's why the supplies of medication and diagnostic tools are very important at the PHC level or any level. So anybody has seen a web series came now, Gram Chikitsalaya on Amazon Prime? Anyone? Which is related to this point. So I'm asking. It is in Hindi. Gram Chikitsalaya. Anybody has seen? So I will suggest you after going from here, you just watch it. You will understand that how the rural area people, those who are not opening the PHC, not running the PHCs, so what they are doing. Nowadays, if you will see that CHOs are there. Okay. So CHOs, if you will be seeing that what they are doing nowadays, from the time I am seeing, I think if I am right, from 2018, the CHO posting has started. Okay, from that time only PSCs are regularly opening and maintaining well. Okay, so in that series, it is shown as point. It will be it has shown that compounder of that PHC, he will sell all the medication given to them. Even after third day of receiving. Today he received, after 3 days he used to sell all the medications, and when the new MO came, there was nothing. Okay, so this can happen if we are not maintaining the records of everything. So that's the condition. The medication is given by the government, but it is not reaching to the people. That we have to see that are the essential medicine. Diagnostic equipment should be there, and supply chain management. We have to see that each drug record we need to maintain. Suppose 100 supply of amlodipine came to you. Out of that, one you have prescribed to this person. That register need to be maintained. That we have to check. So that way we can ensure that the medication which is given by the government is reaching to the people. So how it can be done? Supported by the government initiative like the free drugs and diagnostic program under NHM. Next is risk-based cardiovascular disease management. Okay, how we can do this? And first you need to identify the risk-based approach, what it is. So shift from isolated risk factor treatment to a comprehensive and risk-based approach for long-term CVD prevention. So whenever we are talking about the cardiovascular diseases, there is only not one factor involved in that. You will be seeing the multiple factor. So we have to focus the patient as a comprehensive. Suppose a patient is telling that my father had hypertension, so that's why I'm having. May not be true. The father has hypertension, because of that the the offspring has the traits. But if he has maintained a healthy lifestyle, he may not be having the hypertension, but he had. So we have to focus on a comprehensive picture of the hypertension using the long-term CVD prevention approach. So what are the key components under this? CVD risk assessment tool. There are the WHO used to give a lot of tools which can be used freely. It is available freely in the public domain. We can just take the permission of the WHO, and any hospitals we can use all those checklists and charts and other things. So WHO 2023 CVD risk charts are there, which has described the risk of the people based on their risk factor. Suppose it is given like including age. High, like more than 40-45 years of age. Sex, maybe male is more prone to get the hypertension in early age. Systolic BP, only systolic BP is raising. And smoking status, what is the smoking status of the, suppose if like in India, the ratio of male and female compared to females are less smokers compared to male. That we have to see. Diabetes and cholesterol is available. Based on that, you have find out that suppose one person you find out only 2 risk factors. A person you find out 10 risk factors. So who is in more risk of having hypertension? Who is having the all 10 risk factors? So based on that, we have to do the risk stratification, like low. Less than 10%, moderate will come to 10 to 20% in high. Based on the risk factor availability, you need to classify them or stratify them in the different categories. And then now the high risk factor, you need to give more attention. So that way we'll be giving the tailored intervention. They are the different interventions are there. Suppose like low risk, a person is only having low risk. So what are the intervention we need to give? Only lifestyle modification will be work for him. Then high risk immediate pharmacological therapy plus lifestyle counseling could be given. That will be helping them better to prevent the hypertension. So these way we need to work. Next is team-based care. That's what I have told, that if no complete people are not there, so that we have to take a charge. In front of you, one patient is going to the hypertensive crisis. At that time, you are in charge of doing the immediate treatment. If doctor is not available, you know that what are the drugs need to be given, you can give. And on the asking, if the emergency duty doctor on call, you can ask and you can take the charge. Okay, these are the steps you need to follow. But you are not like, until the doctor will not write and give it to me, I can't do it. So that way the task shifting we need to do. Then improved follow-up. After that, sometimes what that in our nursing, the home care visits by the community mental health nurses are, the community nurses are very important. So here what we have to do, when we have did the follow-up, nowadays we used to do the tele follow-up. We will not be going home, but on call we can ask them. The patient will also feel more attached, and if they are seeing the single symptoms also, they become aware about their health and they will contact to you. So, based on the principle of Ayushman Bharat, Health and Wellness Center, HWCs, we can achieve this team-based care. Last is the S, which is stand for the system for monitoring. So, what are the systems are there and how we can monitor the status of the hypertension? Objective: establish data-driven system for monitoring performance and improving the quality of care. So you can see that the key component of this part is patient registries, that I have told that there are some apps we can through which we can see that. Nowadays we are using the UHIDs. With that also you can track how many patients are taking treatment for hypertension and all. So maintain list of patients with hypertension or diabetes, track treatment progress and BP control. The key performance indicators, what are the indicators we need to focus for the hypertension is percentage of patient with controlled BP, drug availability rate, what is their follow-up adherence rate. There is one scale, ARMS scale it is called, which is for the checking the adherence. Okay, one more scale is there, Mars scale is there. Okay, which we will be using for adherence. So this type of standardized tool we can use to check the whether the person is adherent to that particular regimen we have given or not. Next is the digital tools are also there. Now everything is digitalized. Why not the health follow-ups and other things? So India Hypertension Control Initiative app, IHCI app is also there, which is freely available on Google. You can go download, and with that also, like, we can be using Abha digital health records that as per the hospital availability it is there, that we can use. Feedback mechanism is like regular review meetings at the PHC, district, state levels we can conduct as a nurses. Use of dashboards for real-time time tracking. What are the approaches is integrated with NPCDCS program and the other National Digital Health Mission. This program has just launched, I think, in National Digital Health Mission. If I'm not wrong, it is launched in 2024. So that I'm not sure about it, but this is launched. So that also we can, which is digitalizing all the health records. Next is the what is the conclusion? So we can see that till now I have discussed about the heart initiative. Can anybody write in the chat box what is the full form of heart? I have told you hearts, actually hearts. Can anybody write? Okay, so the HEART initiative offers a structured, scalable framework to address the rising challenges of cardiovascular diseases, especially hypertension, in low and middle income countries like India. So that's why that IHCI is introduced in India, because the more prevalence of hypertension is very high in India, and this kind of intervention, which is mostly cost effective, will be useful in a low and middle income countries like India. So by combining lifestyle interventions, simplified clinical protocols, essential medicine, access and risk-based treatment, team collaboration, and data-driven monitoring, the initiative promotes effective patient care at the primary healthcare level. So we are focusing on the ground root level. So from there, if we are focusing, so on the tertiary level, it already come in the like a organized manner. Adopting the HEART package aligned with the global goals like WHO Global Action Plan for NCDs and contributes toward achieving the Sustainable Developmental Goal 3.4 of reducing premature mortality from NCDs by 1/3 by 2030. This is the actual goal for this program. The HEART packages, what they have initiated. This is the goal, that we have to reduce the premature death by the non-communicable diseases by 2030. Somebody has given, good. Next is that what is the take-home messages for the students? Okay, as a nurses, as a nursing professionals, what we need to know, or what is the take-home message for from this session is, hypertension is a major risk factor for heart diseases and stroke, but can be effectively controlled. it's a bad thing that hypertension is a risk factor for a lot of disorders. But the good thing is that it can be effectively controlled if we have started. We all know that the 3 level of prevention, primary, now it is 4: primordial, primary, secondary, and tertiary. So if we are start focusing from primordial only, so we can prevent the prevalence of hypertension. So it is effectively controlled. If you know the ways, you can manage it. Promoting healthy lifestyle habits like reducing salt, quitting tobacco, and staying active is a key. Can anybody tell me what is the amount of salt we need to take regularly? Don't use Google or ChatGPT. Okay, 5 to 6 grams. So we can use which is equal to a tablespoon. So each tablespoon of salt for each person. That is enough for our body requirement. More than that, if we are using, we are like inviting the hypertension for us. Okay, so that we have to see. So salt intake, I have told, quitting tobacco and staying active is the key of being healthy. Following standardized treatment protocol help provide safe and effective care. And as a nurses, we play a very vital role in counseling, monitoring, supporting patient in controlling blood pressure. And each and every step, we play a very important role. So you should take a like front step, and we need to follow all these for controlling the hypertension. So if you have any question, I'm open to that. You can ask me. I'll be happy to answer. Or otherwise, you can take my mail ID from your teachers and you can ask me, as there is one more session, I think, after my session. So I'm stopping here. So a lot of thank you to patiently listening to me, and like you are answering also. So I appreciate your responses also. Thank you.
Thank you.
Thank you so much, ma'am, for that informative
Okay,
session.
somebody asked me
Next,
that.
we are excited to.
Okay. I'll be happy to answer your questions on my mail. You can put it into my mail ID. I'll answer your questions. Thank you.
Thank you, ma'am. Next, we are excited to hear from Mr. Abhishek Singh, Sir, MSc Nursing to the Government Institute of Medical Sciences, as he presents on blood pressure by 80 mmHg. What's the plan? Mr. Abhishek Sir is a specialist in mental health nursing with a dedication focus on stress management and adolescents' mental health. He has an extensive research background, having authored over 20 publications in UGC Care, Scopus, and Web of Science Index journals. Mr. Abhishek Sir holds multiple patients in mental health innovation, including tools for emotional intelligence development and smart patient care system. He has served as a guest speaker at esteemed institutions such as DPS, Jammu Kalavati Saran Hospital, and SGT University, where he addressed topics on mental health awareness and resilience. An award-winning educator, Mr. Abhishek Sir received the Special Appreciation Faculty Award in 2025 and has over 5 years of teaching experience at premier nursing institutes. He is certified in evidence-based practice from Johns Hopkins Forensic Nursing and Professional Resilience Building from Deakin University. Over to you, sir.
A very good afternoon to one and all, the management, principal of Ruma Institute, faculty, and all those who are present. This is Abhishek. Thank you so much, ma'am, for introducing me. So today we are observing the World Hypertension Day. So am I audible to everybody? Because I could see my...
Yes, sir, audible.
Okay. So can you able to see the screen? Is this screen visible? All right. So my sincere
Yes, sir.
appreciation and the congratulations goes to the entire team of Ruma Institute for organizing such kind of webinars where we will be inculcating some of the knowledge based related to the hypertension, cardiac problems and other things which are really required outside of the classrooms. So to start with, I have a topic which is given by as an hypothetical case, I believe, which is BP 200 by 80 mm of Hg and what's the plan. So before we begin, so what are the aim of our today's session? We are going to just review basics of blood pressure, understanding hypertension, isolated systolic hypertension, and then what is the major thing which is hypertensive crisis, and there is a case, then the management plan, and the last with the discussions and the conclusion. So what I'm observing is that since morning you all must be listening to the back-to-back sessions by the esteemed and the renowned persons. But to start begin with, I want to have to make you understand some of the facts which are there related to the the hypertension. So it is an estimated that 1.28 billion adults which age from 30 years to 79 worldwide have hypertension, and most two-thirds live in low and middle income countries. An estimated 46 of adults with hypertension are unaware that they have this condition. So 46 of the population, percentage of the population, they are, being estimated that they do not know whether they have this hypertension or not. Less than half of adults, again with 42% with hypertension, are diagnosed and treated. Approximately 1 in 5 adults, which is contributes to 21% with hypertension, have it under control. Now, since this is the World Hypertension Day, and we be observing it throughout the week. Some of the institutions are observing it throughout the weeks, and there are a lot of the mass sensitization activities running across the the institutions, hospitals, clinics, and the other settings. But the hypertension is also known as the silent clear. By this time you must have been tagged with this line. But the hypertension is the major cause of premature death worldwide. Why? Because you can see here it is just should I find this pointer? Okay. So this particular 30 to 79 years of age is the targeted age group where the major of the cases are being found. One of the global targets for non-communicable disease is to reduce the prevalence of hypertension by 33% between 2010 to 2030. So we are just 5 years in a row to reach this target, 33%, but it seems an impossible task because the conditions and the the prevalence of hypertension in different age groups are increasing day by day. Then again, this is the source data by WHO. There are again alarming figures which are coming from the the media persons also, and the media surveys also, and the government websites also. So hypertension is soon turn out to be the most lethal disease in India. Why? Because 29% in people in India are hypertensive. As I told you, 41% out of them are really unaware whether they have this or not. 1.5 million people die due to hypertension in South Asia each year, and 214 million people in India with hypertension by 2025, which is the year we are living in. Worldwide, 1 in 3 has high blood pressure, and 33% of urban Indians have hypertension because of the the passive lifestyles we are living into. Right now also we are discussing about hypertension, but you are bound with the screen. We are sitting in a confined space with less physical activities. Though we are mentally active, we are listening, and we are just understanding, comprehending. But the thing is that how about having a area where we could work, where we could walk, where we could have come up, and where we could have done some of the things to manage our energy outputs. Now the 25% of rural Indias are hypertensive. Again, I told you, Indian men are suffering from hypertension, which accounts for 21%. And Indian women, again, our leading figure is 22%. So out of the 19 crore adults between 30 to 79 years were 37 only diagnosed, 30% treat, and the control were 15% only. 213 million hypertensives in India by 2025. Literally, I was when looking out the data last past years, it have increased by 20% each year in India only. So, and this is the data which has been given by WHO. So one another task which I want to make you sure that the use of just a second, what is it? Yeah, antihypertensive market, have increased in the last 10 years. So it was $36.66 billion in 2024, but now surprisingly it has come up to $37.5 billion in 2025, and with at an annual compound growth rate of 2.3%. So you can see the figure how it is rising, and it is expected that 2029 we are going to have this particular industry blooming out with the $40 billion industry just to control hypertension. That means the supply is for the medication is there in the market, and we have people who have this again this hypertension being diagnosed and treated. And how about those who haven't felt they ever had this hypertension, or they have this condition springing out in them throughout the ages? So I'll not take much of the things into the basics of blood pressures. So the one thing we all know, the blood pressure is a numerical, quantitative data which we have in terms of systolic and diastolic, and the other thing is there. So understanding hypertension. So hypertension, understanding of hypertension, I'm pretty sure the the people who have taken the sessions before me must have clarified all these things. But to begin with, and to have a the basis foundation of what we are going to study in upcoming things. So the basic goes as it is. The majority thing is hypertension is called as when you have the systolic being raised above 140 and the diastolic above 90 mm of Hg or higher. It is known as the blood pressure or the hypertension. It is common but can be serious if not treated. Now, blood pressure categories according to AHA and ASA. It is if you have less than systolic 120, it is normal. It is elevated when you have 120 between the 130, and high blood pressure if it is 130 to 139. This is stage 1. Majority of Indians falls into the stage 1 category as of now, and because of our the ethnicity, and you call it as the life passivity of the lifestyles, because we live in a environment where the kind of where we are not much more health conscious. Nowadays you can see people are health conscious, but that too only have physical health, toning of the body, and the shaping body in, but they're not really concerned about the internal organs and how they are working upon. And the next, the stage three, and the second stage which we are going to read today is hypertensive crisis, where we needs to find an immediate attention, and if it is higher than 180, right? So there comes a terms which is isolated systolic hypertension. ISH, which is isolated systolic hypertension, is the condition in which your only systolic top number is high when you check your blood pressure. Like the diastolic is not increasing higher, it is in the normal ranges, but within the systolic pressure, it is only increasing the top number. With this condition, your systolic number can be higher than 130 millimeters of mercury, while your diastolic bottom is lower than 90 millimeters of mercury. But but how this particular ISH has been caused? With age, your arteries become very stiff and less elastic. And if you remember, I have given you the data for the age group which is there. So it is 30 to 79. So majority of the people in India, the younger generations falls into this category only, because we've been called as the younger nation in the entire world. So the India has the maximum number of younger adults who are there. So we all fall into the majority of this category only. So with this, our age, the arteries become very stiff and less elastic. They can't expand and contract as well as they did at the younger age. When this happens, pulse pressure and systolic pulse pressures goes up. Meanwhile, your diastolic blood pressures goes down because of the less elasticity. So again, there are things if we'll not manage the isolated systolic hypertension, it could be leading to some of the fatal things like the heart failure, the heart attack, the stroke, chronic kidney diseases. It could be acute kidney failures also, peripheral artery diseases, and of course the aneurysm. So if we look at the figure which has been there, if we have pulsicity being increased and cerebral blood flow being decreased, we have a cognitive dysfunction coming up. So mostly it has been seen when the people have this high BP, rising up, and when they have this systolic pressure being increased above than 180, so they tend to have the dizziness, they tend to have a confusion kind of a stage. So this leads to, because of the increase of the pulsability and the less of the cerebral blood flow. And what happens if you have just only the stiffness and pulse pressure being increasing up? It is going to affect the kidneys, and it is going to, call up a stage where you can land up into chronic kidney diseases as well. Okay. The next is hypertensive crisis. So we got to know about isolated systolic, the hypertension, and now we're going to learn about the hypertensive crisis. So we have been given with a hypothetical case of BP with 200 mm of Hg by 80 mm of Hg diastolic, and what could be the plan? The hypertensive crisis is when your blood pressure rises quickly and severely, the readings of 180 by 120 mm of Hg or greater. When it is, achieving 180 or above 180, or the diastolic being minimum at 120 or above the 120, it's going to lead at the hypertensive crisis. Now, if you look at the pathophysiology of hypertensive crisis, so blood pressure, if it is increasing, it generates regulation failures, and there is a resistance in the arteries and the vein, and that leads to the vasoconstrictions. And if it is prothrombic state, it leads to ischemia, and it also creates, when the pressure is released higher inside the blood vessels with less elasticity and resistance, it is going to harm the endothelial layer and have an endothelial injury also. Once the pressure is increasing again, it leads to the RAS activations, and it going to affect the target organ damage. So there is a case of, a hypothetical case being there. So it is Mr. Rajesh Kumar, a 8 years old male, has an hypertension for 10 years, not well controlled, and type 2 diabetes mellitus for 5 years, a smokers for 20 years, and obesity of BMI 32. A typical Indian case, we can just think of the people who are coming to the, we have a hypertension clinic in our facility, and the other people are coming with this kind of one unnoticed history, where they have not been noticed about the diabetes, where they're not noticed about the hypertension, when they actually started to develop some of the symptoms which are very severe, and now they have come up to the tertiary care settings. So the medications he was on in the lisinopril for 20 mg per day, metmorphin 1000 mg twice a day. There were no allergies presenting, sudden onset of severe headache, blurred visions, and chest pain. The initial assessment signs up as a blood pressure being 200 by 80 mm of Hg, which again defines the hypertensive crisis. Heart rate of 98 beats per minute with decades, the tachycardia and respiratory rates of 18 breaths per minute. Temperature lies as 98.6, which is natural, and the oxygen saturation for 97% on room air. Upon the physical examination, patient appears very anxious, sweating, and in distress. Cardiovascular examination reveals S1 and S2 are normal, no murmurs. Respiratory clear, lung feels, neurological alert oriented, but complaints of severe headache and blurred vision. Okay, no focal neurological deficiencies were still noticed. Fundoscopy released the bilateral retinal hemorrhages and the papilledema, suggesting possible hypertensive retinopathy. child chesting, gives a suggestion that mild tenderness on the left side. No signs of myocardial infarctions are there. So, so the differential diagnosis, it could be the hypertensive emergency or the hypertensive crisis. The BP looks okay, but wait a minute. You can see the figures are coming and the alarming figures are there. So diagnosis could be given severely elevated blood pressure and organ damage because retinal hemorrhage and chest pain were there. There could be chances this could lead, exaggerate to the myocardial infarctions there, but the ECG changes has to be there, diaphoresis and severe left-sided chest pain towards the MI. There could be chances of developing strokes, headache, disturbances, possible papilledema could suggest a hypertensive encephalopathy, but there are no focal neurological deficiencies on examinations have been found. So there could be chances of, acute kidney injury, as I told you, because of the RAS system activation, it could lead to the excessive pressure. The actual diagnosis upon finding could be suggestive of the hypertensive crisis because the systolic is higher than 180 and the diastolic BP is 120 by mmH with a sign of end organ damage, retinopathy, chest pain, and headache. Possible hypertensive encephalopathy, headaches, blood visions, confusion, though no focal neurological deficiency has been noticed. But if you look at the picture given at the bottom of the right hand, you can see the blot hemorrhages, cotton wool spot, arteriolar narrowing, dysedema, copper veining, exudates, and AV nicking. These are the some classical symptoms which can be found in the people who have this hypertensive crisis and has lead to the, the yeah, it leads to the hypertensive retinopathy. Okay, so if you look at this, there are no neurological signs. Fundoscopy suggests of grade 2 hypertensive retinopathy with no papilledema noted. Then the next is there are severe dyspnea, respiratory rate with 28, the respirations per minute. Then there are third heart sign, gallop rhythm, apex heartbeat, the lungs bilateral fine crackles up to the mid zones. Then the BP again is rising and the pulse is 120 beats per minute. And then the peripheral pulses are also normal. So I'm so sorry. I think there are some issues with the Zoom. It is not, the slides are not moving. Okay, so we have been given a case of 200 by 80 mm of HEG or BP. So there could be, the criteria for assessment goes if there are some, the changes which could be observed through the ECG, through the radio diagnosis and other things that could be suggested of anything which could lead to the organ failure, we'll name it as hypertensive emergency. But if the thing is the high BP is there, but there are no inputs or there are no shadowing of organ failures are being found, we call it as hypertensive emergency urgency. The management includes his immediate attention and the patient stabilizations comes in the first priority because placing a person in a comfortable position, sitting or semi-recumbent and administering oxygen if respiratory distress or low oxygen saturations develop. Then IV lines for medication administrations, fluid monitoring, continuous BP monitoring with a cuff every 5 to 10 minutes needs to be needed because the hypertensive emergency will look at this protocol in the upcoming slides. According to AHA, every third minute you have to take this BP in order to find out and to call it as if you have 3 concurrent readings coming up, other systolic BP higher than 200 mm of Hg, it is a suggestion of hypertensive emergency. Continuous BP monitoring for 5 to 10 minutes, heart rates, respiratory rates, oxygen saturation, and ECGs for regular arrhythmias and ischemic changes must be noted out in order to prevent the myocardial infarctions and the heart failures. The goal of, this particular management starts with the gradual reduction of BP, not more than 25% within first 1 to 1/2 hours to avoid cerebral hypoperfusions. Because I told you the pressure is increasing and that's how it is going to affect the end organs, and the end organs must be, given a chance or a time to just come back to the normal. So our goal is not to reduce the BP fully, but rather to reduce it gradually with going the rule of 25% for the first 1 to 2 hours. And then we are going to start with the IV lines for the antihypertensive drugs, fast testing. Nitroprusside is the drug of choice, can be given, and ideal for rapid BP reduction. Labetalol 20 mg IV bolus can also be given. Then, of course, monitor potential side effects like hypotension, cyanide toxicity with nitroprusside, and bradycardia with labetalol. Other medications, if it is suspected of MI, aspirin could be a choice, and anticoagulation if signs or strokes are present. For pain management, in severe cases, morphine would be the choice for that. The diagnostic workup to do this particular end organ failures or the changes in the end organ systems physiology, we need to go for ECG for any ischemia and arrhythmias, checks, X-rays. Then there could be CBC, CMPs, and UAs, cardiac biomarkers. Troponin is must. Fundoscopy, repeat to monitor for worsening hypertensive retinopathy, because hypertensive retinopathy is one of the the pathophysiological change which can be seen immediately as it touches the organ. CT brain, MRI if there are suspicions of acute stroke or the hypertensive encephalopathies. So let's suppose we have this particular thing coming up, BP is 20 by 200 by 80 mm of Hg. What could be your possible diagnosis as a nurse? So it could be hypertensive emergency or it could be hypertensive urgency. So anybody who's able to get the concept can just put up in the chat box so that I can just see. So what could be the possible diagnosis with BP 200 by 80 mm of Hg, hypertensive emergency or the hypertensive urgency? Any answers? Exactly. Thank you, Anuradha. It is the emergency, because remember, just a second, I'm hanged with the screen chat box. I'm so sorry, this particular PPT is not moving.
Abhishek, if you don't mind, can I share?
Yeah, please.
Okay, just do me.
Yeah, it's working perfectly.
Fine.
Okay.
Okay.
Thank you so much. So the BP is 200 by 80 mm of Hg. The possible diagnosis could be hypertensive emergency only. So the approach to the possible hypertensive emergency, is there a known case of hypertension? The very first thing we need to find it out whether it is a known case or an unknown case. So the known case is a person who has this, the cardiothoracic history, or are there any history related to the hypertension particularly? So, their kind of CADs or kind of an stroke, scleroderma, renal crisis, hyperthyroidism, and uncontrolled pain or urinary obstructions. If yes, we can count them into the secondary hypertension. But if there are no obvious causes being find out, so we can just meet the target of the hypertensive emergency. So are there any target organ damage like acute kidney injuries, type 2 myocardial infarctions, hypertensive encephalopathy, pulmonary edema? And if it is there, then it could be a severe hypertension with a mean arterial pressure ranging above than 135 mm of Hg. And if chronic hypertension, the BP must should be well above the patient's baseline. And if not, it is not an emergency. Again, it will land up into a case where it could be treated as an urgency. And if it is yes, then it is an hypertension emergency or the crisis situation. We need to reevaluate the underlying cause, disease process causing hypertension. The very first thing we'll be ruling out is the considering the HCT head if the primary intracranial pathology is possible. Evaluate for the other possible causes as appropriate, like aortic dissections, intoxications. Aggressively treat away any possible precipitating factors could be there like pain, agitation, volume overload, or withdrawal. And if it is persistent with hypertension, again with no clear clue cause, so it is a primary hypertensive emergency, and IV antihypertensive is immediately being indicated. Immediate BP control required using IV antihypertensives. So it is nicapridine infusions. And again, typically target is just to reduce 20% reduction in the mean arterial pressure within the 1 to 2 hours of the duration. After BP control and clinically improved, transition to oral hypertensives and the routine, the follow-up care can be initiated, but based on this repeated again assessment of BP. So if it is severe uncontrolled high BP and there are evidence of multiple organ damages, so there is a mnemonic to be remembered. It is BARC. B stands for brain, and A stands for arteries, R stands for retina, K stands for kidney, and H stands for heart. So BARC explains about the possible pathways where we need to work upon. So the initial management goes as to underline and to find out the target organ which is been targeted, or which has the chances to be targeted as an failure condition. So if it is brain, we need to look about the stroke, ischemic or hemorrhagic conditions, hypertensive encephalopathy, and depending on the the targeted
Network issue. I think Abhishek sir's network is not stable. Please rejoining. Wait for a few seconds, participants, please. Sir is joining. Until then, participants, you can ask your questions if you have any. Just type in chat box.
Hello, am I audible now?
Yes, sir, you are audible now.
Oh, I'm so sorry. There is there are weather changes in Delhi. All of a sudden, we have a dust storm coming up and weather being changed suddenly. So,
Yeah, no problem, sir.
could you please help me in, the playing the PPT because from my end, I'm not able to change the slides appropriately.
Okay, sure. Okay, sir, we will share your slide.
Thank you. Thank you so much.
In few seconds, we are sharing slide.
Yeah. So we were talking about a thing which is known as bark. So it is brain to look out for the strokes, arteries. Again, A stands for acute aortic syndromes, uh, and the retina for grade 3 or 4. The Keth-Regner's Barker retinopathy. Then again, kidney acute renal failures and chronic renal failures. And the heart, H stands for heart, which is acute renal failure and pulmonary edema. Based on the assessment, the bark, we are going to decide the targeted organ, and depends on that we are going to give our treatment to the patient. Could you please change the next slide? Next slide, please. Yeah, the possible symptoms of the hypertensive emergencies could be dizziness. Patient may complain with the severe headaches, repeated vision problems, nausea, vomiting, trouble breathing, and chest pain. Next. Okay, so the nursing assessment, our major role comes as in the assessment part, because identifying the right thing at the right time is the priority. So monitor arterial BP continuously and note sudden increase or decrease in the readings. Precipitous drop in BP can cause reflex ischemia to the heart, brain. Again, the bath may come in place. Note trends in mean arterial pressure. It should be noted immediately and patient response to the therapy. Monitor hourly urine output and note any presence of blood in the urine. Continuously monitor the ECG for dysarrhythmias or ST elevations and T weight changes associated with the ischemia or injury. Next, please. Then the diagnostic assessment starts with reviewing the burn and the creatinine to evaluate the effect of BP on kidneys. If the burn is, more than the 20 mg of deciliter and the creatinine is more than 1.5 mg a deciliter, suggest renal impairments. So these are the immediate attentions we need to take into consideration, and we can go with the radio diagnostics to find out the final diagnosis. Review serial chest radiography for pulmonary congestions. Review serial 12 lead ECGs for pattern of injury, ischemia, and infarctions. Next. The patient management starts with the provision of oxygen and establishing a basic oxygen supply to the body with 2 to 4 liters of oxygen per minute to maintain and improve oxygenations to the and to maintain the perfusions. Minimize oxygen demand by maintaining the patient at bed rest. Help the patient to decrease anxiety and keep the patient NPO and provide a liquid diet in the acute phase. Administer nitrates at order to reduce preload and afterload. Nitrates will really help in the elasticity of the arteries, and the resistance, it's going to decrease the resistance. Administered beta blockers such as laboratory again may be given for 20 to 80 mm of bolus dose for every 10 to 15 minutes, rapidly lower the blood pressure for the very first 2 hours. Prepare the patient and family for the surgical interventions if it is affecting the target organ to correct the underlying cause if it is indicated. The next. So today we are observing World Hypertension Day, and the theme for this year is to measure your blood pressure accurately, control it, and live longer. Next. Now, since we are dealing with a hypothetical condition of BP with 200 mm of 280 mm of Hg, so the measuring of BP is quite important task. So the AHA has described there are certain things to be kept in mind while taking the BP, and the sometimes the false readings or the inappropriate readings could be suggestive of false treatment to the patient. Let's suppose somebody is running to my OPD and coming and just sitting and sudden all of a sudden, as to decrease my workload, I just tied the cuff and I said, okay, आप बैठिए मैं आपका BP check कर लेता हूँ. And immediately if I'm taking up, what will be the condition, what will be the the predictive things? BP could be higher, which could not be a sign of something which we are going to treat. But to begin with, we must be knowing that when to take blood pressure and what is the accurate way to take the blood pressure at what intervals is our skill as a nurses. In the 30 minutes before your blood pressure is taken, the patient must not be have done any episode of smoking, exercise, caffeinated beverages, and of course the alcohol. Right before, place the bottom of the cup above the bend of the elbow, wrap it against your bare skin, not over the clothing. Most of the times what we see in emergency situations, we just tie the cuff above the the basic clothing the person is wearing, and it's been attached to the body. Or sometimes it is the right size of the cuff is not available, so we just go on repeated again and again repeated measures to assess the BP. And if you're taking at like the intervals, so you must be knowing that 1 minute apart in the morning before taking medications you can take, and evening before going to bed record all the results. And the American Heart Association has given the criteria to find it out. And if you are finding the BP more than 100 by 180 by 120 mm of Hg repeatedly at the three intervals, 5 minutes each, 3 minutes each, then it is a suggestion of an hypertensive crisis or the emergency. Next, please. Ma'am, please, could you please share the next slide? The next slide, please.
Just a second, sir.
All right, all right.
Sir, can you please change slide? Able to share. Be able to change slide.
Should I change it from my end?
Please change it, sir.
So we were talking about measuring blood pressures because our goal for today is to measure your blood pressures accurately, control it, and live longer with that. So measuring blood pressure accurately begins with the correctly sized curve. So the correctly sized curve of an adult, the small adult, it could be a youngster coming up into your facility or the vicinity. So the ranges should be for the curve size should be 17 to 25 centimeters. And if you are taking that particular thing through the femoral arteries, it could be
Actually,
ranging
sir,
to
your
the
voice is
38 to
breaking.
50. Hello, can you hear me now? Can you hear me now, ma'am? Hello, am I audible? Am I audible, ma'am? All right. So we really need to look into, the correct sizes, and the artery mark over the brachial artery should be, rightly located in order to find the things. So like next time you are sitting in an OPD, or you're just measuring, a bedside with the patient, you need to look into the correct size of the cuff. Are you using it? And if you are not using the correct size, automatically it is going to give you the incorrect readings, be it you take for the third time, you take for the fourth time, or you take multiple intervals. So the very first, the error as a counterpart we need to progress with it is to find out the right the size of the cuff and when to measure the PP. So coming to the end of my, the talk, what we have discussed so far. So I would like to give you a take home message with this. So you must be knowing your numbers. Be you are the early person, you are the, the very happening person, you are very fit and fine, but you must be checking up your BP and the diabetes regularly at a month of at least, quarterly in an year. Know your numbers, take the lead. Healthy habits are what you need. Limit salt and keep stress low. With active stress, your health will grow. So keeping stress out of the box is not an option now. We have this stress, but how about to convert this stress into productivity, where we can work upon ourselves and make our health, again a shining thing. So with this, I sum up my this presentation today. If you have any doubt or anything, you can just ask me. With this, thank you so much again, Ruma Institute, the principal management, and the wonderful audience. I'm so sorry with the little bit of the disturbances which are happening in between, because all of a sudden we are experiencing some sudden changes in the weather, extreme weather in Delhi. So thank you.
For detailed presentation. As we move forward, I would like to inform you of a slight change in today's program. Due to an unforeseen scheduling conflict, Mr. Panwar sir will not be able to join us today. In his place, we are pleased to welcome Mr. Gaurav Tyagi sir, who holds an MSc in Community Health Nursing and currently serves as a nursing tutor at AIMS, Jammu. We look forward to his valuable insights and contributions during the session. He will be sharing his views on dissemination and implementation. Sir, we invite you to kindly take over the session. Mr. Gaurav Tyagi sir, please take over the session.
Good afternoon to all. I'm audible.
Yes, sir, you are audible.
Thank you so much for the short invitation. As Pavas is not taking the class, was very important work. So, when Pavas request, I take the class, and 5, 6 slides are there. So please share my PPT, please, ma'am.
Thank you so much, sir, for joining in such short notice.
So our topic is introduction to dissemination and implementation. So what do you mean by dissemination? Please share my picture, ma'am, please.
Yes, sir, we are sharing.
As we know, the dissemination means sharing correct information with the right people at the right time. We are providing the information to the right people at the right time. For example, sharing the knowledge about the checking the blood pressure, how to know the checking the blood pressure at homes, what are the symptoms, what are the treatment and prevention of hypertension with nurse, health worker, and the public. So we are providing the correct information to the people at the right time. And implementation means putting that knowledge into the action. But we are the planning, but at the planning, then we are implementing, like using proper guidelines, right? Using the proper, making the health worker follow the standard procedures, or encouraging patient to take medicine regularly. To implement in a what we are the plan, and we are part of the action to the right time and the right people. Next slide, please. And also the dissemination and implementation for hypertension control means we are referring to the systematic approach to spreading evidence-based strategy, intervention, or guidelines for managing high blood pressure and integrating them into clinical and community setting to improve health outcomes. And other things that the key aspects we are discussing, that sharing the findings or practice that have been proven effectiveness, or we can also select the target audience, clinicians, public health professional, policymakers, and communities. And other methods of disseminations like publications, presentation, toolkits, training, media campaigns, we are also included in the dissemination. And also we talk about the implementation in the hypertension, like we are adapting the intervention to the local settings, like clinicals, hospitals, community, and also providing the training to the staffs, integrating tools for the health worker, securing leadership supports, measuring how to well the intervention is adopted in super. We also check that what are the plan to implement that the plan are suitable for all peoples in community areas. And other things that what are the implementing dissemination strategy like. Firstly, next slide, please. Like key approaches. Firstly, we talk about the dissemination strategy. So our objective that effectively communicate evidence-based hypertension control practice to relevant stakeholders. What are the key approaches of dissemination strategy? Like firstly, policy briefing and the guidelines. We are providing the briefing the policy, develop and distribute clear, concise document outlining hypertension management protocol. So we are making the protocol and providing sharing to particular people at the right time. Next, training and education. We are conduct the workshop and seminar for the health worker and update knowledge related to the particular disease and update them on the latest hypertension management strategy. So the latest hypertension strategy and we are update to the particular health workers. Next, our awareness campaign, like utilize media platform to educate the public on hypertension prevention and control. So we can say that the prevention is the best weapon to control the disease or the prevention of the disease. So, like primary prevention, we are providing the specific health education, and also we are using the digital media and digital platform to educate the public on hypertension prevention and control. Next slide, please. Next, we discussing Again, the implementation strategy. Implementation strategy means, firstly, the key approaches discuss the team-based care. The team-based care establishing multidisciplinary teams, including doctors, nurses, pharmacists, and community health workers to manage hypertension. So we are managing, yeah, training provided to the doctors, nurses, pharmacists, and community workers to the manage the hypertension. Technology integration, like we are using the electronic health records, so every hospital they have the digital health records, the for the critical sensors and other things using like mobile health application to monitor and manage patient data. And many research and some develop the mobile application tool for the managing and monitoring the patient data. And third, the community engagement involve the community health workers to provide education and support to the patient. So, we also providing the youth and other community health workers. They are providing the education and support to the patient in their local settings. And next slide, please. And some the implementation strategy like multi-components program. So we can say that a team-based collaborative care, health provider education, health coaching session, home BP monitoring, BP audit and feedback. So these are the some strategy for implementing the programs. And other things also, I add some points rather than the PPT, future direction. What are the doing for the future direction for control and education related to the hypertension control? So firstly, we use digital health innovation. So like digital health innovations like developing mobile applications and telemedicine services to monitor and manage hypertension remotely. So the person not coming to the PSC and CSC. So we are monitoring these types of patients. So digital health innovation, next policy advocacy, like we are making the good policies for support hypertension prevention and control at national and international levels. Next, community-based intervention like strengthening community health system to provide localized care and supports. So, by the effectively disseminating evidence-based practice and implementing them through structured strategy, significant progress can made in controlling hypertension globally. So the what are the dissemination means the what is the process to implementing and the right information to the right peoples and implementation. What are the plan to establish or implementation in the communities area to control the BP or hypertension. So thank you so much for giving me short time for completing my topics on behalf of PK Panwar, and sorry for inconvenience. And thank you so much.
Thank you so much, sir, for your detailed presentation.
And
We are
sorry for giving short.
no problem,
Because
sir.
I know.
Sir, we are so grateful to you for stepping in such short notice and sharing your valuable insights with us. Thank you so much, sir.
Thank you, ma'am. Thank you so much.
Sir, actually, we are having our panel discussion for 5 minutes. Will you join this?
Sure, ma'am.
Okay, thank you, sir. Now, moving ahead, we all pleased to begin the panel discussion on the very important topic blood pressure measurement and monitoring in India. This discussion aims to explore practice challenges, current practices, and future directions in blood pressure monitoring across healthcare. For this engaging discussion, I warmly invite all the esteemed speakers to join us on the virtual panel. Your combined experiences and perspectives will surely make this session successful. And we also have few questions from our online audience. Panelists, would you like to take them? All the participants, if you have any questions, just ask in chat box regarding the whole topic. If you have any question from hyper blood pressure, you can ask in chat box. Questions.
Dear students, if you have any questions, any doubt regarding today's webinar, you just ask question in the chat box. One question we received: in hypertension crisis, why we provide low oxygen? A speaker.
Gaurav sir, there is some questions. Would you interested in answer that? Am I audible, sir? We have some questions. Sir, are you able to answer them? No. Just wait for a few seconds, participants. Our panelists is still joining.
So I could see some questions for the hypertensive crisis. What is the drug of choice? Again, it depends with the BARC criteria. Which criteria do we follow and what the target organ is being, affected. But to start with, we can always go with the labetalol. This is the first line. Nicapridine is again the drug of choice.
Sir, we have one next question in hypertension crisis. Why we provide low oxygen?
uh, the high doses of oxygen can lead to the vasoconstrictions, especially if it is more than 60%, and the targeted cerebral perfusion could be higher. और अगर हम लो ऑक्सीजन सप्लाई करते हैं ना, the hypertensive crisis, that narrows the blood vessels and reduce blood flow to the vital organs. So if it is reduced to the blood, the vital organs, automatically the pressure is going to decrease at the organs end. So this is how the low oxygens are being administered, and we need to keep checking on the oxygen saturation level at the same. If it is decreasing really low, we need to start with the immediate things, and if not, we can proceed with the planned things.
There is some questions also like, should I restrict salt to reduce my blood pressure in hypertension?
Restriction of salt is not a choice to reduce the hypertension. The usage of table salt is a precipitating factor which can lead to the hypertension. And then again, there is a history of hypertension. If you have a history of hypertension, limiting salt intake would really help.
Student is asking, what is the best way to measure my blood pressure at home? If
Early
Clement sir,
morning. Acha.
yes sir. Okay, sir. Continue, please.
I thought I am the only panelist who left. So,
Sir,
so if
Clement sir just joined now.
yeah, sure.
So
Hello?
there is a question.
Yes, sir. Yes, sir.
Can you repeat the question, ma'am?
Yeah. What is the best way to measure my blood pressure at home?
We have now digital BP apparatus are there, madam. So we can regularly check BP.
Yeah, sure, sir.
Digital machines are available now. We can check at home wherever we are there. We can check our blood pressures, or if
Okay,
not,
but
we can go. If not affordable, they can go to the primary health centers. They can have a regular check and regular eye on it.
thank you so much, sir.
But those who all are suspecting blood pressure, they need to regularly go for a checkup. Actually, they should keep an eye on it. Same like blood sugar, how we are checking it. The same way we need to keep an eye on blood pressure also. It's most important.
Thank you so much, sir. And there is a question, what are the reasons for giving first drug of choice is calcium channel blockers in hypertension?
Yes, madam. It's we need to start with depends upon the level of blood pressure actually. So it is mild level calcium channel blockers are very much useful. It is taking care of means it's reducing the blood pressure also.
Thank you so much, sir. We have Chota Marathi ma'am with us. Ma'am, are you interested in giving answer?
Yeah, sure.
Ma'am, there is a question. What is the standard diagnosis of hypertension crisis?
Standard diagnosis? Sorry, I didn't get you.
What is the standard diagnosis of hypertension crisis?
Actually, hypertensive crisis is generally a condition based on your blood pressure measurement recording, right? So if it is, above 180 mm of Hg, if the systolic BP is above 180 of Hg and this diastolic is basically above 120, then it is called as hypertensive crisis. So it's a little bit complicated emergency condition, like I discussed in the morning.
What health problem are associated with high blood pressure?
Problems. Okay, the problems could be which are related to high blood pressure includes cardiac, basically cardiac arrest or conditions like that. And then kidney failure can also be another disease condition. And also stroke can also be a complication which is related to uncontrolled hypertension.
How do I know if I have high blood pressure?
Basically you will experience certain symptoms like dizziness or profuse sweating or symptoms such as nausea, vomiting or something like that. So sometimes you also experience dull outs or blackouts basically when a person is just doing some routine activities or driving or something like that. So these are some of the signs which we should monitor.
Have Gaurav sir with us. Sir, am I audible to you?
Yes, ma'am. I can hear you.
Sir, there is a question. What is the standard diagnosis of hypertension crisis?
Hypertension, standard diagnosis. Nursing diagnosis, or you're asking about medical diagnosis?
Sir, no. There is a question: screening diagnosis of hypertension in nursing.
Nursing.
Screening diagnosis of hypertension.
Screening diagnosis. Nursing diagnosis, we just go for actual, means elevated body blood pressure. As an actual nursing diagnosis, we count it actually. We treat them in an urgent basis. Like we can give a sublingual nifedipine and other sort of like medical management. We will be giving it based on that monitoring as a nursing interventions. We monitor the blood pressures regularly. So the symptomatic managements will be given for the person.
Someone is asking, what is the recommended amount of salt per day as by WHO?
Recommended salt, it depends upon the blood pressure again. Actually, there is we cannot say it is mild, moderate, severe conditions are there. So hypertensive patients, it should be like exact amount. I am not saying right now, but thing is, it should be like a minimal amount of salt needs to be taken. Like a
Yes.
normal person, when they are taking, it's off of the level of the salt they needs to be taken actually.
Yeah. Actually, they say added,
WHO.
yeah, added to this, what sir has said generally, our food, vegetables or, the food what we consume already contains natural salts in that. So we need not to top it up with some, added salt or something like that. Normally, 5 grams if it is for a normal healthy adult. So depending upon the blood pressure requirement, as sir said, so it should be adjusted. So that is what they, doctors usually say to the patients.
And how obesity affect in hypertension?
So as we already discussed, obesity is one of the cause. So because it could lead to coronary block and all that. So because of these atherosclerosis or plaques which are deposited in the blood vessels, generally what happens is the blood flow will be affected and the pressure inside the blood increases. So that is only termed as blood pressure or hypertension.
The second line of drug of hypertension. Second line drug of hypertension.
There are so many categories of drugs, right? Like, there is no particular second line like we have it for dots therapy or something like that. So it depends upon the problem what is identified, whether it is caused because of calcium or whether it is caused because of kidney, potassium, or depending upon that, basically the drugs are prescribed for the hypertensive patients. So, like we have AC inhibitors, calcium channel blockers, then we have potassium sparing diuretics. So, depending upon the problem, generally, the kind of drugs are suggested. So, there's no particular, second line, something like that.
Ma'am, just add on to that, like when they are understanding that they have a blood pressure, better they can have a medical consultation.
Yes,
Most
sir,
important,
yes.
instead of like taking a self-medication,
Yeah.
that always should be avoided.
Yes. Yes, sir.
So whatever the prescribed by the doctors, and that needs to be followed, and every follow-up needs to be done to control the blood pressure. So medical advice is most important in this.
Sir and ma'am, thank you. Thank you all our respected panelists for the insightful and thought-provoking discussion. Your contribution have truly added great value to today's session. Now, to conclude this session on high note, I take great pleasure. I invite our Honorable Director, Manisha Singh ma'am, to share few words and reflection with us. Ma'am, we are honored to have you with us. May I now request to kindly address your gathering. Welcome you, ma'am.
Am I audible to everyone?
Yes, ma'am.
Okay. Good evening, everyone. Thank you so much for the kind invitation. I would like to congratulate organizing team and all the speakers for conducting such a well-structured and informative session. From the public health perspective, BP monitoring and measurement is very crucial. And in this webinar, we have covered all the related topics about the blood pressure and especially hypertension. Then I appreciate Principal Mr. Rahul Kumar Sharma for taking initiative in organizing first national level webinar from our college. My sincere appreciation goes to all committee members, all the moderators, organizing team, and the technical team for their collective effort for the successful event. I hope all the attendees have gained some meaningful knowledge from this webinar, and so that they can apply in their clinical practical area. And in the nursing profession, as I'm a gynecologist, in the nursing profession, hypertension in pregnancy is an emergency. So, being a nursing profession, you should know about every details about the hypertension in pregnancy. We can discuss someday, some other day on this topic. So, thank you once again for giving me this opportunity to address the session. I wish you all a continued success and learning in the future. Thank you so much.
Thank you so much, ma'am.
Thank you, ma'am.
Always inspire us to strive for excellence. Before we move towards the formal vote of thanks, we request all participants to kindly take a moment to fill out the feedback form. Your responses are valuable in helping us improve and make future webinars even more insightful and impactful. Here is the link to the feedback form in WhatsApp group. We truly appreciated your input and time. Now, to formally express our gratitude who made this webinar a success, I would like to invite our respected principal, Mr. Rahul Sharma sir, to deliver the vote of thanks. Sir, we kindly request you to take over. Welcome, sir.
Thank you, Kainath, ma'am. First of all, there's one question I would like to ask with Dipti, ma'am. Madam, what are the side effects of high blood pressure drugs? One question is left. Dipti, ma'am. Dipti, ma'am. Ma'am is not with us. Clement, sir, please. One question is there. What are the side effects of high blood pressure?
I'm speaking. Yes, Rahul. What you asked? Sorry.
Okay, ma'am.
Uh-huh.
Madam, one question is there. What are the side effects of high blood pressure drugs?
Okay, high blood pressure.
Drugs.
Okay, एक मिनट. You called me in between, na? हाँ और क्या? Because I am just supposed to drive now. That's why.
मैडम
Okay.
मैडम आज हमारी आप डायरेक्टर मैडम से भी मिल ली, मैडम भी हमारे साथ हैं आज।
Actually, disconnecting and everything is going back, na? So proper your voice is not to me, means it's not coming to me sometimes. It is
Okay, okay.
आप पार कर लो, मैं बात कर रही हूँ। हाँ 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 राहुल, I think you asked what are the side effects of high BP drugs, है ना?
Yes, ma'am. Yes,
That
ma'am.
that can be sometimes symptomatic, and we can say that yes, sometimes going with the nausea, vomiting, fatigues, and crampings. Sometimes we just go with some pain in subsequent areas, dizziness, like these type of things can be yes, experienced by the patient. Park kar lo beta. Okay, Rahul,
Okay, okay, madam.
may I
Okay,
mute
madam.
now?
Sure, sure, ma'am. Clement sir, one more question.
Yes, sir.
Can
I
children
add on
have
to that.
hypertension?
Sir, I just add on to that. We need to watch about the hypotension also. So
Okay.
even medications, hypertensive medications can cause hypotension also. So we need to check, monitor the blood pressures regularly. And that hypotensive, what type dizziness and all giddiness and all type of things can be, hypotensive symptoms can be appearing for this. That also
Okay.
keep an eye on, and that also side effects of this antihypertensive drugs. And
All right, sir.
anything
Thank you,
is
sir.
anything dizziness or anything, they need to be like immediately taken a care actually, because blood pressure, hypertension is a silent killer, and which will be like destroying all the organs. What we said morning, hypertensive mediated organ damages. That's the most very seriously we look into. Yes, sir. Any other question?
One more question. Can children have hypertension, sir?
Definitely, sir. Because now it's same like a diabetes, type 1 diabetes, same like obesity. It's everything, like even the blood pressures nowadays, because as madam said in the morning, the most of the environmental factors which contributes a lot for causing a
Okay.
hypertension. Like even a genetic is the main cause. We cannot, it's a two types of causes. Etiology, we can say that modifiable, modifiable. So in a non-modifiable, we can say like a genetic is the main cause. And also we can include the, this one, what is it, the physique. And modifiable, we can see like they are so much of stressed in childhood. The main problem is mobile addiction. And a lot of other more, the food habit, junk foods. And the cholesterol content food. They eat more non-veg. And a lot of other more environmental factors which causes, for example, morning madam said like water, even the
Yes, sir.
heavy metals. So all those things are contributing factors for a child to get a hypertension. Nowadays, we can see a lot of studies were conducted, research studies were conducted, that it's proven that like even childhood hypertensions are more common nowadays. Because day by day, we are including more factors like a mobile phone technology, even stress. They need to do particular amount of education, assignments, all those things which produces the stress for the person. Again, the food, what they eat, junk foods, the preservatives which is there in the in the in the junk foods, which also the contributing factors for increasing your blood pressure.
Fine, sir. Thank you, sir.
Yes, sir.
So now we are end of this session.
It's, I
So
should
as we
I should
draw this,
appreciate Ragul sir. I should appreciate you in your conduct a national conference in a right day actually, which is most important.
Thank you so much, sir. Thank you so much.
So I also recommend you like every health event should be like happening like this. This is a very basic. We
Sure.
don't want to talk anything like a very bigger level of informations. Very small piece of informations which we can give to the nurses. They will spread everywhere. So wherever they
Sure,
go to
sir.
the
Definitely.
community and family and wherever they go, and they will spread these messages. And also whatever they will be recommending to the primary health center, this type of small things which save the life of individual. So I really
Thank you,
appreciate
sir.
the complete team. Like you all, it's a teamwork which now today is a fruitful day for you to get a great success. So
Sure,
once
sir.
again, I
Thank you, sir.
appreciate the complete team for your initiation, hard work, and your dedicated service to the humanity. Thank you.
Okay, sir. So, as we draw this enriching and impactful national webinar to a close, organized in observance of World Hypertension Day 2025, and it is my privilege and honor to deliver the vote of thanks on behalf of the Ruma Institute of Medical Science, Pratapgarh. So, celebrating the 20th anniversary of World Hypertension Day, this event aimed to spread awareness about the importance of accurate blood pressure management and control. I am proud to say that with the effort of our speakers, management, faculty members, our students, and participants, we achieved this goal meaningfully. I extended my heartfelt appreciation of our dignitaries, Dr. Rajendra Singh, our chairperson. Thank you, sir, for your visionary leadership. Dr. Manish, sir, for his gracious presence. Dr. Manisha, ma'am, for her constant guidance. Thank you, madam. Miss Aisa, ma'am, our vice principal, for her thoughtful institutional introduction. I express gratitude to all our distinguished speakers who enriched this webinar with their expertise. Uh, Dr. Smriti ma'am for honoring with us with your gracious presence. And I would like to take a moment to acknowledge and thank Dr. Devansi ma'am for joining us today on short notice in place of Dr. Smriti ma'am, who could not be with us due to health issue. We sincerely appreciate Ms. Divansi ma'am valuable contribution and setting the tone for this event with your inspiring thoughts and wish Dr. Smriti ma'am has a quick recovery. Thank you, ma'am. Dr. Sushna ma'am for honoring. We express our sincere gratitude for your valuable insights and generous encouragement. Thank you, madam. Mrs. Malati ma'am, thank you for sharing your experience and wisdom, which truly enriched today gathering. Once again, thank you, madam. Dr. I. Clement, sir, a heartfelt thank to you for taking time from your busy schedule to be with us today. With us,
Thank you, sir.
thank you so much, sir. Dr. Deepti ma'am, we truly appreciate and involvement and valuable contribution you made this program. Thank you, madam. Dr. Gopi Chandran, sir, we are immensely thankful to you for your thoughtful words and kind presence. Mr. Abhishek, sir, thank you for your enlightening presence and kind support. Thank you, sir. Mr. Panwar, sir, we extend our heartfelt thanks to you for enriching this occasion with your thoughts and blessings. A heartful thank to all speakers and also participating in the panel discussion on blood pressure management and monitoring in India. Your insights made this session truly engaging. Thank you, Mr. Gaurav sir, for sharing your thought at the last moment. My special thanks to Dr. Manisha ma'am for her inspiring concluding remarks, which beautifully captured the essence of today's learning. Thank you, madam. My appreciation to our dynamic moderators, Ms. Diksha Mishra and Ms. Kainat Parveen ma'am, for conducting the session with grace, clarity, and professionalism. Special thanks to our organizing committee, Miss Aisa Khan ma'am, Miss Preeti ma'am, and Miss Tehseen Khan and Versa ma'am for your outstanding coordination and leadership. To our technical team, Mr. Rajkumar sir, Mr. Muniraj sir, Miss Sanjana ma'am, and Miss Jyoti ma'am, thanks for you for ensuring seamless technical support. To our organizing members, Miss Prasansa ma'am, Miss Vandana ma'am, Miss Ansu ma'am, and Miss Viva ma'am, your consistent effort were deeply appreciated. And to our e-certificate committee members, Miss Lavi ma'am and Miss Tanya ma'am, thank you for handling the certificate process efficiently and promptly. Finally, a big thank you to all the guest speakers, chief patron, faculty members, healthcare professionals, and participants. With a passionate team, I look forward to hosting more national and international academic events in the near future. Thank you once again and Jai.
Thank you.
Thank you, sir.
Thank you.
Thank you so
Thank you,
much,
ma'am.
sir.
Thank you all so much.
Thank you so much, sir, and all speakers. With this, we come to the conclusion of our national webinar. On behalf of organizing committee, I extend heartfelt thanks to all speakers, participants, and guests for the valuable time and contributions. Thank you. Have a nice day.